here.
Large
At
scale.
the outset, let me thank all of you for making it here on a Sunday morning. Special thanks are to our course directors, Dr. Neeraj and Dr. Pappas Patel, for helping us to put up this program. We hope to make it a good success with their help. My special thanks are also to the faculty members who have been from Ahmedabad outside and also from Calcutta and Chennai, who have graced this occasion and helped us to conduct this program. We hope that there will be good takeaways for each one of you at the end of the day. Begin with, may I request Dr. Neeraj to come up on stage and accept a small bouquet on our behalf. Please, sir. Thank you. Again. Please wait here. Can I request Dr. Pappas Patel? Welcome, sir. Please. Professor Sankarlingam from Chennai.
चालू છે અત્યારે
Thank you, sir.
તો આ બે શું છે વચ્ચેના સ્ક્રીન
Dr. Beuchel Pappas.
અચ્છા આ એક સ્ક્રીન છે આ એક સ્ક્રીન બે સ્ક્રીન
पर वो तो आएगा ही
पटेल
इतना दूर होगा तो अब चेक कर सकते हैं हम आया हेलो हेलो बराबर ने
Dr. Kuldeep Chaudhary.
हाँ अहिया टेस्ट करो हेलो हेलो हेलो
Dr. Karthik
बीजू
Shukla.
माइक जो से
Thank you, sir.
हाँ वो सर को देने के लिए
Dr. Mukesh Shah. May I also request, I also have a gratitude to Narayana Hospital for helping us to conduct a live surgery workshop from their hospital. And Mr. Hemant Patankar is here. May I also request him to come forward? Thank you, Mr. Hemant and Narayana Hospitals. Senior surgeons and all the other delegates who have come here, I wish to thank you once again. Dr. Bipin Shah, thank you very much for having graced the occasion today morning. Every occasion begins with a small prayer and we light the lamp as a mark of respect. May I request all the faculty members to help us to light the lamp, grace the occasion and start the proceedings. Before we begin the scientific session and the live surgeries workshop, we would like to invite the CEO from Narayana Hospitals, Mr. Hemant Bhatnagar, to share his thoughts on the business and the program as we go ahead before the day progresses. Mr. Hemant Bhatnagar.
Sorry, Liam. सोफा है साहेब ने ओला में नहीं त्रीजा में पाछू खर.
Good morning, everybody. On behalf of Narayana Hospital, first of all, I extend a warm welcome to all the dignitaries present here. I also take this opportunity to thank Mr. Venkatesh and Mr. Nagariji from TTK team, providing this opportunity to Narayana Hospital to be part of this academic exercise. Also privileged today to meet Dr. Neeraj Shah, almost after more than 2 decades by heart. could recollect a lot of refreshing memories when we first connected at Rajkot, Beuchel. Good to see you, sir, after a long time. Though my initial thought or my speech was scheduled to welcome, but at the last moment I was requested to provide a few thoughts in terms of the healthcare scenario going forward in the era it will come. I'll not take much of the time because I'm sure all the distinguished guests here would be eager to listen to Dr. Neeraj, the scientific session. But I thought of putting only one slide of our Honorable Chairman, Dr. Devi Prasad Shetty. And the slide itself will speak what would be the scenario of healthcare in the coming time. It's all going to be the digital space. It's all going to be the artificial intelligence backed and dominated predominantly. Of course, the service excellence part will take a major role in the entire output of the service delivery. And that's how, as a Narayana, as a group, we have highly switched from a paper to paperless or electronic supported system. We are moving into the space of providing paperless healthcare services to mandate exit to the patient. And of course, the robotics will also be added feature into the entire healthcare delivery to the patient. I also take this opportunity to give you a brief about our Ahmedabad presence. We have a 200-bed multi-specialty hospital at FAIRFIELD, of course, to cater to the need of your patients. We are into cardiac sciences, providing all kinds of adult and pediatric minimum invasive surgery. Going for heart transplant surgery. In terms of orthopedic systems, it's a high volume center. On an average per month, 100 joint replacement we are doing with Dr. Neeraj here, leading the entire program. In terms of oncology and oncosurgery space, we are a very busy center with 900 chemotherapy cycles per month, and an oncosurgery doing high-tech surgeries, just to name a few, in terms of the complex disease. Apart from that, the center is also fully equipped to cater for renal transplant services, bone marrow transplant services, and critical care services. That's all from my side for the day. And I once again thank you all on behalf of Narayana Hospital, to TTK and the organizer of this program, that you have provided this opportunity to partner with NH. And thank you very much for all the distinguished guests. You have spared your time. And definitely, as Mr. Venkat has rightly said, definitely it's going to be a fruitful session and there will be a lot of takeaway with the distinguished faculties being around. Thank you very much. All the best.
Thank you, Mr. Hemant, for your kind words of encouragement. And I will hand it over to the surgeons to conduct the program for the surgeons. Scientific sessions begin now. And may I request Dr. Beuchel Pappas to come forward and help us to conduct the scientific sessions.
Good morning, all of you. Most welcome to BPAC-2022. We will continue with the topic parallel cut technique. I would like to invite Dr. Neeraj sir as a speaker and Dr. Jyotish Patel and Professor Sankalingam as a moderator. Please.
આ કેમેરો બરોબર છે આનું ખાલી પછી ગોઠવી દે હે હવે દાખલા તરીકે આપણે આને બદલે આ કેમેરો અહીંયા જોવો હોય તો જોઈ શકાશે સંજયભાઈ તમે થોડોક આગળ અને થોડોક આમ લઈ લ્યો કારણ કે આ સંજય હવે ફાઇનલ કરી નાખો કારણ કે હવે 10 મિનિટમાં સર્જરી ચાલુ થઈ જશે બસ બરોબર થોડોક હા સાહેબ અહીંયા આવી જાય પણ સાહેબ એક જ મિનિટ સાહેબને જવા દેવા જેવા હતા આપણે કેમેરો જયદીપ પરિણામ લઈ લે પછી એક કામ કરો સાંભળો 1 મિનિટ માટે પાછળ લઈ લેજો એટલે સાહેબ ચાલ્યા જાય ભાર્ગવ નીચેથી ગાઉન સરખો કરવો પડશે અને પછી બધા કોઈ હલતા નહીં આવે પછી બોલો આપણે બે આપણા જ જોવા હોય તો એવું શક્ય છે?
Important છે આ.
બે કેમેરા ઉપરનો ને આ બે આપણે અહીંયા રાખવા હોય તો ઇઝ ઇટ પોસિબલ? હા જોઈએ, શક્ય છે? ન હોય તો કઈ નહીં. સાહેબ, કારણ કે ત્યાંનો ઓડિયો ચાલ્યો ગયો છે. ઓકે, પરફેક્ટ. હવે સાહેબ આમ આવી જાય એટલે તમે સાહેબ આપ આવા બાજુ આવી જાઓ ને. હવે તમે કેમેરો ગોઠવી દો. હવે આમથી આમ કોઈ ના કરે, કરવું હોય તો કેમેરાની પાછળથી કરજો, નહીં ટ્રોલી લઈ લેજો. આ કેમેરો થોડોક ઝૂમ કરવો પડે અને ત્યાંનો વિડીયો ઓડિયો નથી મળતો આપણને. જો પરફેક્ટ છે, આ પરફેક્ટ છે. હા 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 ચાલુ ચાલુ જ.
ત્યાં ચાલુ છે. ત્યાં લેક્ચર હોટલ છે, ત્યાં લેક્ચર ચાલુ છે. આ હોટલ
ઓલી સેકન્ડ સર્જરી થોડીક જલ્દી ચાલુ કરી દે. ઈ નહીં તો બરોબર છે. તમારે અવાજ ચડાવી દો ધીરુભાઈ. પલ્સ અવાજ ને બધું લઈ લીધું. ક્લેરિટી નથી, ક્લેરિટી નથી. તૈયાર છે ને બધું? બ્લેડ નવી, બેટરી, ડ્રાઈવર. આ તો ગયું. હું શું કહું છું કે ટીવી ને થોડું કામ લઈ શકાશે, થોડુંક ધીમે ધીમે હલાવજો. બસ બસ પરફેક્ટ પરફેક્ટ પરફેક્ટ. હવે એકવાર ઉપરનો દેખાડી દો ને કેમેરો. એટલે ને બે જો ત્યાં બે દે. આપણે જેમ અહીંયા આ બે દેખાય ને એ લોકોને ત્યાં બે દેખાય. એ લોકોને ત્યાંનું તો જોવાનું. ઠીક હે રહેને દો. હવે પાછો ઓલો ચેન્જ કરો. યસ ઓકે. આને થોડોક ઝૂમ કરો. પરફેક્ટ, વેરી ગુડ. ઓકે બસ. ઈ કે છે કે ત્યાં ધરશો ને એટલે બાઉન્સ બેક થશે. થોડોક આમ લ્યો. ચડી ગયો ને ચડ્યો છે
So this was these were not mobile bearing knees that they were doing. They were fixed bearing knees, but they still were doing flexion gap work because they realized that doing flexion gap will give you a perfect rectangle in both flexion and extension. So how do you create the flexion gap? Simple. There are only few ways of you can of creating that flexion. Let's say you have just how do you decide that entire one thing
ઓલું મૂળ માઇક ચાલતું જ નથી એ શું કરે ચલો ડાયસ છોડીને અહીંયા આવી અહીંયા મને લાગે છે કે કટ પતી જાય ને એટલે ત્યાં સર્જરી ચાલુ કરાવી દઈએ એટલે ઇમ્પ્લાન્ટેશન થાય અને બીજું લેક્ચર વચ્ચેનું પતે ત્યાં સુધીમાં ઓલા લોકોનો એક્સપોઝર પતી જાય અને આપણે થોડું જલ્દી કરજો લેગ હોલ્ડર નહીં જોઈએ અને કદાચ બાજુમાં ઓલાને પૂછી લ્યો કે એને લેગ હોલ્ડર જોઈએ છે કે નહીં ઘણા લોકો નથી વાપરતા પણ સાહેબ આમાં બહુ સારું પડે તમને અપાવડાવ્યું આ શેલ્બી નું સંશોધન છે વિક્રમ શાહ સાહેબ નું સંશોધન તમારો એક આસિસ્ટન્ટ ઘટી જાય પગ પકડવો જ ના પડે તમારે જે અને ઓલામાં હા ઓલામાં શું એક ફિક્સ હોય હા હા પણ પછી એમાં પછી પકડી રાખવો પડે આમાં આમાં કોઈ માથાકૂટ જ નહીં જે હોય અને આ ડિરેક્શનમાં છે ને મોટા થતા જાય ડિફ્લેક્શનમાં જાય ને એટલે આમ મૂકવાનું ચડતા બહુ મસ્ત વસ્તુ છે હા આનાથી બાંધી દેવાનું હા બે છે મારી પાસે તો ઘણી વાર બપોરે બે કેસ સાથે લઉં તો બે પડી અને ડ્યુરેબલ સ્ટીલ નું છે આ મેં 6 વર્ષથી કઈ કર્યું એકાદ વાર વેલ્ડિંગ બેલ્ડિંગ થોડુંક કરાવું તો ઓલા લોકો આપણને કહેશે ત્યારે કર હજી તો સાહેબ તો મંડ્યા છે સાહેબ એમ ખેલાડી છે બોલો નિર્ભય શાહ રાજકોટ હા નથી ચાલતું લાગે અને કાં તો એ દૂર રાખે છે છોડો ને ભાઈ આપણે એને ત્યાં સંભળાતું એટલે પત્યું તું સાંભળ અહીંયા મારા કટ પતે ને એટલે સાહેબ ને કે છે ત્યાં ઇન્સિઝન મારે બરોબર 1 નંબર 2 કે પૂછી લાવું પાર્ટીઓ ચાલશે કે નહીં ચાલે બસ અહીંયાથી જ બનાવીને અપાવડાય ટેબલ ની હાઈટ ઓછામાં ઓછી છે આસે આવે જ ને એવું સંભળાય
important points to remember. One, Please remember that all the tibial and femoral osteophytes.
એને મને એ નથી ખબર પડતી કે ત્યાં જવાની શું કામ જરૂર છે.
Because then we have
Ah.
a long because the ligament is tight. You want both the ligaments to be tight, but and then we will get.
એ ઓલા લોકો
Number two, no further unnecessary releases of the collateral cycle. And only in very severe cases of a very tight medial or lateral deformity, maybe some very.
હું ક્યાં ગાળ બોલ્યો?
Maybe in my rate, majority are not well, 99% are not.
તો એકાદ દેવીએ પડશે વચ્ચે.
And in such cases, maybe a pickup again,
Ah.
less than 5%. In my. How to make this better?
હા સંજય સંજય CSR છે. આની વાત કરો જ ને સંજય CSR કંપની CSR અહીંયા અમદાવાદમાં 2 જણા છે. એક બાયોમેટ્રિક સર્જિકલ કરીને છે અને બીજો છે માર્વિન નું નામ શું છે? વેલ્યુમેડ માર્વિન ખબર છે? માર્વિન ઓલો સિન્થિસમાં હતો વર્ષો સુધી. માર્વિન ઈ રેડી નું જ આ બ્યુકેલ પાપા એ લોકોએ રાઇટ્સ લઈ લીધેલા. એટલે જે મેરિલ ને મેક્સ છે એવું. કારણ કે ટીટી એટલે આપણી પ્રેશર કુકર પ્રેસ્ટીજ વાળી. પછી આ કોન્ડોમ એક્ઝેક્ટલી ટીટી કે ની એન્ટાયર બાસ્કેટ માંથી જે ની છે ઇઝ ચેન્નાઈ. એટલે પ્રેસ્ટીજ છે મેન ફોર્સ છે એ બધા આ લોકોના. કોણ કોણ એ પતી ગયું એનું એને આપી દીધી ડિવોર્સ. એ કરતો હતો. He has left.
You are not able to get.
He has left.
So this is why I know this method and that I'm doing it, that these people have used it.
સાહેબ તો તાનમાં આવી ગયા છો પણ અમને મેં એને કહેજો કે ઘડિયાળ પહેરવાની ભૂલી ગયા તો કઈ નહીં પણ પાછળ કેલેન્ડર તો છે. તારીખ ના બદલાઈ જાય હમણાં. આપણે હવે આ થોડુંક નાના પાયે છે ને એટલે બહુ જ પ્રોફેશનલ નથી થયા અને આપણે થોડોક સ્પેસ એટલે મારો પ્લાન તો શું છે કે ઇવન હિંજ અડધો પતી જશે ને અમુક કટ ને એવું તો ત્યાં જમવાનું 1 વાગે ચાલુ કરાય પછી લોકો થાળી લઈને જમતા એવી રીતે કરવું છે. પાછા જાઓ એટલે જ હું એવું જ કરીશ. તો તમે હવે અહીંયાથી હોટેલ આવશો કે બહાર નીકળી જશો? કારણ કે તમારે હિંજ પત્તા 1:30 તો વાગશે જ. ના ના ત્યાં ઓલા બરોડા થી લોકો ઘણા આવ્યા છે. 15 જણા આવવાના છે.
Number two. So
ના ના એ તો અમારે બહુ ખેલાડી માણસ સખત છે. નહીં ના આપણને અડધો કલાક થી વધારે નહીં. તોય તો પહોંચી વળે એમ છે. ઉસ્તાદ છે. બધું દે ઉપર એ લોકોને તો ત્યાં 2 દેખાશે. આ ને ઓલો
Then you are good.
Any
You are going to start with, be very careful about your environment.
ઇમ્પ્લાન્ટ ને બધું ભાર્ગવ લઈ આવશે ને સાઈઝ પ્રમાણે 2 કે 3 નું લાગે છે. આમાં સર્જિકલ ટેકનિક ક્યાં કહીએ દેખાડો લાઈવ સર્જરી જ આપણી છે પછી હવે તો આ 15 મિનિટ હજી મને 10 મિનિટ પથિક ભંડારી આનું નતો કરતો એ બાયોરેડ નું કરે હા પછી એને મૂકીને મેક્સ લીધું અને પછી હવે બાયોરેડ તમને ખબર હોય તો એક છોડો રમેશ સિંહ હતો બાયોરેડ માં એની હારે ભાગીદારી કરી પાર્ટનરશિપ હા 2 પગ કપાયેલા જોન્સન એન્ડ જોન્સન માં હતો કારણ કે મુંબઈ ગયો ને મીટિંગ માં એમાં ટ્રેન પગ આવી
Now you can give it
ના હવે 10 મિનિટ બાકી
So there you are.
આવું લેક્ચર ત્યારે લેવાય કે જ્યારે લાઈવ સર્જરી ન હોય ને ત્યારે તમે 3 સર્જરી દેખાડવાના ત્યારે આટલું બધું લાઈવ દેખાડવાનો અર્થ નહીં નહીં એટલે આપણે જો લાઈવ આમાં દેખાડવાના જ છીએ આ વસ્તુ એટલે આ બધું
When look at the trial, this is your trial. You could see that is why we are taking up the body. There is no medium like the extended point. I can have that position. Still that without this after So this is our parallel section. Now we are talking of bisection jacket. So there are many papers. Stay with me. I'm not going to. I just taken two papers.
ઘડિયાળ નહીં હવે કેલેન્ડર જાઓ પાકું. હવે છે પાછા કલાકાર. હિન્જ કરવાનું છે.
Then Dr. Dennis.
બ્યુકેલ, ડોક્ટર બ્યુકેલ. એ છે ને જોન્સન જોન્સન નું એક LCS નામનું નહીં આવતું હતું. એ સેમ આ જ હતું એકચ્યુઅલી. એની પેટન્ટ આની પાસે હતી ને આણે ડિઝાઇન કર્યું હતું. એ પેટન્ટ પતી ગઈ ને એટલે એને પછી આ બ્યુકેલ, ડોક્ટર બ્યુકેલ ઇઝ અ ડોક્ટર અને પાપાસ જે છે એ બાયોમેડિકલ એન્જિનિયર. એ મળીને બ્યુકેલ પાપાસ. અને ઇન્ડિયામાં રાઇટ્સ આ લોકોએ લઈને હજી મળે છે, અહીંયા નથી આપતા. હા હા
I experience usually the trial qualifying my
હા ના થઈ જ જવાય.
without doing this.
આપણે ટુર્નિકેટ ચડાવી દીધો ને.
I realized this that I had to increase the size of
કારણ કે મને એમ કે
body by 2 mm. Generally, young inexperienced surgeons are afraid of being young.
આનું
When the protection care for technique units are what precise care. Do that parallel cut technique to be related to the very complex.
એક કામ કરો ને રે ખાલી 2-5 મિનિટ વખતે પત્યું.
Thank you. Thank you. Thank you, Dr. Nirbhay Shah, sir, Dr. Jyotish Patel, sir, and Professor Sankalingam. Any question and any doubt? Thank you. Now we will have a live surgery, primary TKR with COCR. Will be done by Dr. Sringer Avasya, sir. And I would like to invite Dr. Nirbhay Shah, sir, and Dr. Satish Patel, sir, as a moderator.
ત્યાંનું સંભળાતું નથી.
Instead of Dr. Nirbhay Shah, I would like to invite Dr. Professor Sankalingam as a moderator. And most welcome Dr. Jyotindra Pandit, sir, to the event. Thank you.
આનું નથી સંભળાતું કહો. હા Dr. Keval, am I audible?
Yes, sir.
So I think the video is very much clear, both the cameras, dome camera and front camera. Dr. Keval, I think mic of Dr. Satish Patel is not working. Only the podium mic is connected. Yes, sir. Good morning. Sir, again the voice has gone. Slightly better. So can I start the surgery?
Can someone just show us a quick X-ray of the patient? Do you know what you're doing?
Knife आपने.
Dr. Neeraj, sir, can you hear us?
You see, I can hear you because you are speaking from the podium mic, which is very clear.
Okay.
Sir's, Dr. Satish Patel's mic is not working. So probably sir needs to go there and talk. Meanwhile, if both the cameras are working, then I can start the surgery.
Wait a minute, Dr. Satish sir will come.
Yes, you can start the surgery. Can someone just show us the X-rays of the patient just before you put in the incision?
Yes, please. Sir, the story of the patient is a 71-year-old male patient. We are operating on left side knee. We can just show the X-ray to the front camera. Please, X-ray દેખાડશો? X-ray ત્યાંથી લઈને camera પાસે રાખ, camera પાસે. Yes. We are operating on the left knee and it is a tri-compartmental osteoarthritis and 71-year-old male. Predominantly medial compartmental and patellofemoral compartmental arthritis. And the plan is to do Beuchel Pappas COCR knee and most probably rotating platform.
Okay, yeah, that's fine. Go ahead.
So I will be focus the camera back over here, front camera. Yeah.
Yeah.
So I use classically the anterior midline incision, slightly medial than the tibial tuberosity. Cautery. Tuberous medialis. I use the classical medial parapatellar approach. This is the patellar tendon. On the superior port, just to facilitate the closure. So this is the arthrotomy. The joint is now, for a while extend please. Retract. So first step to do is synovectomy from the suprapatellar pouch. We'll remove the synovium which is diseased. Very important point in all knee arthroplasties. We'll not try to strip off the periosteum from the distal end of the femur. Try to preserve a bit of blood supply. Not too much of synovitis, but whatever is there. Flex. Focus the light.
Do you use the leg holder in all your cases?
Yes, yes. I always use the leg holder. That saves one assistant for me. So this is partial excision of the infrapatellar fat pad. I would like to keep a sliver of fat pad over there because I don't replace the patellas. So patellas derive their nutrition partly from fat pad. So sliver will be there. This is excision of partial excision of infrapatellar pad. Doctor shown in his lecture. Now we'll release the deep part of the medial collateral ligament. After separating the medial meniscus from its attachment, anterior horn, then I am releasing the MCL deep fibers from the tibia. Just a word for caution that whenever a surgeon is doing Beuchel Pappas rotating platform, I would recommend not to vigorously release the medial collateral ligament because sometimes it can open up a bit more. So initially it is better to release till half of the tibia. There is an osteophyte, small. And then later on, if required, we can release the remaining part. But once released, then you will be in trouble.
So that principle stands for all tibias, all systems, isn't it? The
Sir,
minimum capsular section.
generally what happens that post and cam design sometimes can forgive a bit of medial lateral instability, but this knee will not. So a bit technically challenging knee in that case. So now we are clear from the medial side. A spike is there. Now I will be, the anterior horn of lateral meniscus has been released. Lateral spike, please. So the point is now clearly visible.
I think the intensity of the light is too strong. So we are getting
Intensity.
light outcome. Yeah, that's
Is it better?
yeah, better. Yeah.
Yes. So now I will be releasing ACL. Anterior cruciate ligament is sacrificed, and I will keep initially by me. If required, I will release it in the end, and I'll explain to you if I release it. So here joint is dislocated. Now we have both the meniscus out. First the medial one. And then the lateral one. So we are done with the joint clearance, meniscectomy plus synovectomy. So we are ready for the cut. So for, as Dr. Neeraj has explained, that we will be doing proximal tibial cut first. So we are applying the tibial jig. This is the tibial jig. And theoretically, we are supposed to cut 9 millimeters from the non-diseased side. But the beauty of this jig is that we can apply the pins, We can apply the pins first, and then we can make the jig shift up and down without taking it out. So first we will be applying the pins first. Pins, please.
You don't use the stylus at this stage.
No. And I would normally cut not more than 7 millimeters of tibia initially. If required, I will be taking 2 millimeters later on. Angel wing.
Would you remove all the tibial osteophytes before you start cutting the proximal tibia and the femoral ones as well?
Tibial osteophytes, yes, femoral ones when we are doing the sizing. And in this case, we are not seeing, if you are seeing from the dome camera, you see that the disease is predominantly on the medial side, not too much of osteophytes on the tibial side. So we will not remove, we have not removed any osteophytes from the tibia so far. Take it down a bit. Jig. So this is the approximate cut we are aiming at. So please.
Again, you've not measured the amount of cut.
No, sir, no.
Then how do you know that it is 7 millimeters and not 9 millimeters?
Sir, it is just eyeballing and experience.
The thinner has wept at Shelby as well. That's the Shelby philosophy.
No, Shelby, Shelby people don't use jigs.
They exist, right? So that means you didn't spend long enough time in Shelby.
So we can measure the cut now. Sanjay, please measure the cut for
less
sir.
time in Shelby.
Yes, yes, yes. Only 1 year.
Yeah.
We will measure the cut for you. So please. There is slight bump on the medial aspect which needs to.
This always happens because of either the bone is sclerotic or we do not use a new
Yes.
blade in every case.
No, this is the new blade actually especially for the conference. So this is 7 millimeters of cut, sir. Can you see?
Yeah, we believe you. That's fine.
7 millimeters of tibial cut. So now we will remove this spike and we'll side. First we will do the drilling the femoral canal and open up the canal. Please give me the drill first. And then we'll go ahead with the sizing. So unlike other systems where take the distal femoral cut first, in this case, we will be taking anterior and posterior femoral cuts first. And in that way, as Dr. Neeraj had shown to you, we will be able to give the flexion gap first. So after opening up of the medullary canal, these are the jigs. So these are the basically templates for sizing. So in this case, what we have to do is we have to put these templates on the lateral femoral condyle after osteophytes are removed to measure that what size will fit. So these templates will, because this system has 5 sizes, 2, 3, 4, and 5 for tibia and the same way for femur. So these templates will sizes. So this would be size 3. So size 3 cutting block should be given to me. Size 3.
But you
With
still
the
haven't removed the
intramedullary.
osteophyte.
No, not much on the lateral side.
Yes.
So this is anterior and posterior femoral cutting block, plus this will decide the rotation, femoral rotation. So in this system, the femur will be in natural rotation. Now for this, what we'll do is that we'll try to lift, please. Yes. So this spacer block is inserted inside, and now we'll extend the knee to 90 degrees. Hammer, please. We can gently hammer this, and this now knee is then 90 degrees. So now this femur will pick up the natural rotation. And
So tibia has guided the rotation for the femur. That is the whole system.
thing is that if this spacer block is of 9 millimeters, so if once the tibia is cut and we'll take the posterior femoral cut, then this spacer block tells us that your 9 millimeter insert will go in flexion. So now we can remove this spacer block. this is our this will be our rotation. So cut on the anterior side.
So again, with an angel guide, you
I
can
think-
see whether there is going to be any notching in this.
I think there will be a bit of notching. So what
Okay.
I will do is that I will manually change the rotation. So we will keep the pins over there. And then we will remove the jig and change the rotation. We have decreased the external rotation and now we'll it was probably around.
Will you recheck with the guide whether your rotation is okay or whether it's a rectangular gap or not yet?
So anterior and posterior cuts are taken. Lift. So now you can see the flexion gap and we will be inserting a lollipop. Push. Nicely time. Yes. So leave it now. So you can see, sir, that the 9 millimeter flexion gap we have been able to achieve.
Okay. And the anterior notching, could you avoid that?
No. We could avoid that. There is no anterior notching. You can see from the dome camera because I had to decrease the rotation. So there is no anterior notching. So anterior and posterior cuts are over. We have been able to achieve the 9 millimeter flexion gap. So as far as this step is concerned, probably we will not require to readdress the tip cut, most probably. So now we will go ahead with the rest of the femoral cuts. So first flexion, now we will be doing distal femoral cut. Tick, please. Intramedullary, yes.
So would you remove the
5 degrees.
tibial pin? Not yet.
Pardon, sir, I did not hear you.
Would you remove the tibial pins at this stage? or
No,
leave
sir,
it?
still, no, sir, to be on safer side, I will be keeping it. I will be removing it in the end just before the preparation of tibia. As of now, we are going to take 9 millimeters of distal femoral cut with 5 degrees of valgus. The jig has inbuilt 5 degrees of valgus and there are multiple options if you want to decrease the valgus or increase, the different jigs are available. So now, take distal femoral. Okay. So distal femoral cut is done. So now we will check the extension gap. It is a bit slight on the medial side, but overall, if you can see, this knee is stable and there is no fixed flexion deformity residual which is there. So probably I will not take the plus 2 millimeter in the distal femur, but still what I would do is that I would like to shave it off a bit. So on the medial side through the jig only, so that this slight tightness on medial side can go, or else what we will do is that we will release the So we could, as you can see that we could shave off a millimeter of femur on the medial side. Remove the pins. We are done with the distal femur. No. Chamfer cuts. Hammer, please. So at this stage, we will be taking anterior and posterior jig and the trochlear cut. And at this stage, we will be committing the medial lateral commitment for the original implant.
So you're sticking to size 3.
Yes, femoral size 3. You can see the size 3. So now we are going to have anterior and posterior chamfer cut. And as you can see, the cuts are really paper thin. So these were the chamfers, and now we'll take the trochlear cut. In the trochlear cut, we have got options that we can remove this part, trochlear bone, but usually we don't remove it. First of all, these are the pegs for the original implants. And now, hammer, please. We'll compress that bone inside only. Better not to remove the bone. And we'll just push it in. So this is the trochlear groove, which will in the original femur. So now we'll be removing the jig. We are done with.
So now you have only the physical preparation left.
So now we'll prepare the trial. And if required, then we'll take tibia 1 or 2 millimeters. If required, or at that time, if the flexion gap is tight, then we can remove the PCL.
Would you do any soft tissue release rather than doing bony cut?
Sir, soft tissue release, if required, I will be releasing the medial side because there was slight of medial tightness. Or else, as of now, I don't think so that osteophyte has popped out from the medial side. No, it is calcified meniscus. Grabber, please. Got attached part of meniscus. Now we are done. Tibia forward.
So what have you decided about the PCL?
PCL I am retaining. I will show you the PCL, sir. PCL, I have retained PCL. I will prepare the tibia now. And then size 3 tibia, please. Pins. Hammer.
How do you decide the rotation of the tibia at this
Sir,
stage?
rotation I will be deciding after taking the trial because the trial tibia does not have fins. The original tibia will only have fins. So
Okay.
as of now, we can put the tibia as per the platform allows us to accommodate, and then we'll decide the rotation after the trial is done. I will be marking the tibial rotation after extension of the trial prosthesis. So this is the trial size 3 tibia, and as you can see, there are no derotation fins in this trial prosthesis. So
There is
we'll
no
just
flag.
fix it. And this is 9 millimeter insert, which they call it size 0. We can remove the spike. Then now we will be putting the femoral component trial.
And this you do in hyperflexion of the knee or in 90 degree?
I once do, and then once the tibia and insert is going inside, then we'll put the femur, femur, and original the same way. So this is how the entire thing is sitting. So now you can see that the knee is fully extended. You can remove the tibial pins now. So there is no the tibial cut. And then now we will be flexing. So patella is up. We need to do a bit of lateral, which will retain the patella in. So if we put a thumb, then it is not lifting up. And all, I think everything is good enough. The flexion is good. The knee extension in mid flexion and in full flexion. You will see all lifting up a bit. But you see, this problem is because the original poly will have a longer, this short keel. So some in trial, especially for beginners, you will feel that the poly is lifting. See, you can see the lifting up of the poly. But then in original, it does not lift up. So now at this stage, what we'll do is that we'll mark the rotation now. And we'll keep the knees at 90 degrees and we'll mark rotation, tibial rotation. So this will be our rotation. And this will be the...
Someone is asking, can you do PCL release or even partial release to avoid this lift off?
partial release of PCL.
Yes.
Now,
Help your flexion gap in hyperflexion of the knee. Because
So what-
the lift off will give the extra pressure on the posterior part of the knee.
yes,
which
so
is
what
lifting
we
away.
can do is we can remove the trials. We can remove the trials and then we'll check that if the PCL is too tight, then we can do partial release. Yes, sir. I agree.
And
remove.
how is returning the PCL helping you?
Sir, I think the design of this poly is such that you can either keep the PCL or you can sacrifice the PCL. But over a period of time, I have realized that if we retain the PCL, then on the posterior side, there is a bit of safety because of PCL. So there are no chances of future dislocations. That is what I have felt. So in many cases, probably 60–70% cases, hammer and osteotomy, please. I usually tend to retain PCL. Lift. Take the original 330 mobile bearing. We are just breaking the posterior ridges from the condyles. That might also be responsible for a bit of lifting up of poly. And
So the posterior has to fight from the femur. You're removing that.
yes, and secondly, it also releases a bit of posterior capsule as well.
Yes. So that would help your flexion, your extension gap, isn't it? If you remove the
Yes.
posterior osteophyte, your extension
It is
gap.
going to help the extension there. Yes, the PCL is slightly tight. So what we can do is that with a scissors, we can do partial release of. Sir, please retract the medial side. Retractor, please. MCL retractor. So we can show the partial release of PCL. See, so we can insert the scissors there and few fibers of the PCL can be cut.
You remove,
You
you're
can
doing
see.
it on the tibial side.
From the middle, not from the tibial side, from the middle bulk of the
Mid-fiber.
yes, midway, mid substance. So we'll give the wash and prepare for the final implantation. Meanwhile, what we can do is wash, please. And we can show you the original implant. Tibia plus polyethylene plus femur. So can you focus the camera over
It
here?
has no flange, isn't it?
So this original implant has the derotation flanges, as you can see.
Yes, very minor.
Yes.
They don't need to be prepared.
No, they
Yeah.
can just hammer in. And then there is a keel in the tibia, which will prevent because this polyethylene, as you can see, a kidney shaped groove underneath, which is going to allow only 15 degrees of movement on one side, 15 degrees on either side, medial and lateral. So the poly cannot rotate. That is the safety from this implant. So it will have
Rotation which you can do with the knee.
15 degrees and 15 degrees on both the sides. In case I don't think so, the patients need more. And this is the femoral component, like this, and the flexion and extension. So this is the original femoral component, size 3, tibia, and the polyethylene. So we can wash and we can start the cement mixing. Yes.
Yes. Spin out in rotating platform knees is a bit of a myth. Very, very few people would have experienced it. I've been doing it for 20 years. Nearly all my knees are rotating platform. I've never experienced or heard about spinning out. These are things you'll come across in conferences, just like ceramic hip replacements. You always hear of people saying about squeaking, but very, very few people would have actually experienced squeaking of ceramic hip. So it's, you have to take it with a pinch of salt, the importance you give to these things. Ultimately, all knee replacements, unless your gap balancing is perfect, they will fail. The cheapest
Yes.
joint will work wonders if your gap balancing is okay. The long-lasting results are based only on gap balancing. And then I'm
Exactly.
talking
So-
about flexion, extension, and mid-flexion as well. And patients'
sir, you
results
can
are also
see-
based only on this.
That our entire aim was to cut less and save the bone, because we cannot create the bone. My TBL cut was only 7 millimeters. Still, we have been able to put 9 millimeter insert. And the entire focus, as you rightly said, is to preserve bone by dealing with ligaments more rather than cutting the things plus. And regarding this this myth, or you see, there is a fear in the surgeon's mind that post and cam gives you more stability, and rotating platform do have some chances of poly spin off or something, but poly spin off rarely happens, and it happens if your medial or lateral balancing is not proper, or otherwise it does not happen.
But if the medial lateral balancing is not right, no joint is going to work.
Yes, yes, but this the PS design would last for 4 or 5 years, and this thing will spin off early. That is the only difference. So now we are ready with the cement.
The tibia first.
Yes, tibial part first, and I would like to put a bit of cement inside as well, because if you have seen, the keel of this tibia is very short. So actually I have not opened up the medullary canal. So there is no fear of cement going percolating inside the canal. So now we will just, as per the marking of the external rotation of the tibia, we have to just push the tibia and then hammer it. So the flanges will sit inside the bone. We can remove the extra cement. Posterior cement as well. By the way, sir, who is batting first, Pakistan or Bangladesh?
I have no idea. Anyone who's following it? Bangladesh is that in fact.
Okay. So now the femoral, the poly has been inserted. And now after insertion of poly, we have to extend the knee fully. It will go inside. And then we'll flex it up to 100 degrees and then we'll put the femoral component. This is the way you have to do the surgery, or femur first, then the tibia and insert will not go, or then the thing will not get reduced. So now lift gently and then that's it. Okay. The femoral component has gone inside. We'll hammer it. Remove the cement.
On.
The plan is to start the second surgery early, and in Dr. Rajput's surgery, sir, we will be skipping the exposure part. He must have started the surgery in another day, where he will be done with the exposure, and then we'll start the surgery with cuts and implantation only. So this is the final implantation, and we'll just extend the knee once and take out the extra cement, whatever comes out. But you can see that there is full flexion, extension, there is no fixed flexion deformity, and we can flex it and then remove the extra cement from the notch.
Only thing one has to be careful about is to make sure we don't leave any cement in the posterior part of the femur. And the people
Yes.
cement would have been taken out before putting in the.
Yes. So this is the final implantation, and as you can see, I have kept a bit of sliver of the medial meniscus, which I usually do if this is the cautery is marking the medial meniscus area. So if you can see that we have matched the joint line as well, because the medial meniscus and the poly are matching, if you can appreciate the meniscus.
You know, a basic doubt in all the young surgeons' mind is going to be if the system is asking you to take 9 millimeters of tibia from the less involved side, how can you decide to cut less to begin with? Or why do you do it? How
Sir,
is it helping
overall from my experience, I have felt that rarely you require 9-10 millimeters of cuts in extremely bad cases, or else the knees like these, which are predominantly medial compartmental osteoarthritis, you generally get away with 7 millimeters of cut. And there is a simple philosophy that you can always cut less initially and then cut more later on, if required. But if you have cut more, then you will end up with a certain number of polys. So better to cut less initially and then always add on.
I think there is a bit of experience which counts in this, depending on how lax a particular joint is when you examine them. That can guide you about your basic part. Because
Exactly.
you
And
cannot
sir,
apply a simple rule to all knees. Some will be inherently stiff and some will be inherently very lax.
Sir, forget about 7 millimeter. In rheumatoid cases, I cut only 4 millimeters or 3 millimeters.
What do you do with the patella now?
Sir, debulking and circumcision. I don't replace the patella. So we are just debulking it and doing some sort of circumcision or denervation. There are osteophytes in patella. So we are just trying to remove it. Remove the synovium surrounding. So we have got a lecture in between.
Yes, we do.
Okay. So as of now, sir, I am done with the surgery. So you
Okay.
can switch to the lecture, and we can have question answers while we are post lunch session. We can have question answers because I think we are a bit late already. So we'll switch to your lectures, and as of now, thank you very much. I have been accompanied by my physician assistant Jaideep Sanjay from TTK and Dr. Manish from Baroda. So thank you very
so
much.
Sunil. I'll just
and
request the team to take a post-operative X-ray just for the audience
Yes,
to
sir.
have a look later on and now.
Definitely, sir. Definitely. Thank you very much, sir.
Okay, thank you. Any questions at this stage?
Sir, we can have question answers in after post lunch session during panel
Can
discussion.
you just show us the patellar tracking? Maybe take 1 or 2
Yes,
clicks and
yes,
let's
yes,
have a look
yes,
at the
yes,
patellar tracking?
yes. I have done the lateral release.
You've done the lateral release.
Yes, lateral retinacular release, and the word of caution is when you are doing lateral retinacular release, always burn. If you are cutting the genicular, lateral genicular, then burn the tree, or else it will bleed profusely late.
Okay.
And
As
try,
you
first
see,
of all, try.
There might be a bit of lifting off on the middle side, as you see in the patella when you do the tracking, but then the joint is open that side as well.
No, sir, it
ideally,
is.
you should decide after taking maybe 1 or 2 stitches at the patella level and then see the tracking as well. Then you'll get a
Yes, yes.
proper idea.
No, there won't be any lifting because the knee is going in deep flexion up to 120 degrees, but still there is no medial gap which is opening, and now I removed the thumb, still the patella is in the center.
All right.
Done,
See the
sir.
post-operative state.
Yes, sir. Thank you.
Thank you. Thank you.
Thank you, Kinnaravasya sir. Thanks for the live surgery. Now we will continue with the lecture topic indication of hinge usage in PKR by Dr. Satish Patel sir. I would like to Satish Patel sir as a speaker and Dr. Karthik Shukla and Professor Sankalingam as a moderator.
Mic बंद करिए. Mic बंद करिए. થઈ ગયું ને? ચાલો સાહેબ. હા. એક વાર
Can we switch off the OT mic?
એક વાર you are used to system, પછી 20-25 મિનિટમાં થઈ જાય.
Beuchel Pappas has a very nice hinge joint as well, and it comes to the rescue of difficult situations. Over the years, I've used it many times. It's a simple system, just like the primary system is also quite simple. The number of instruments are less, but there is a bit of modularity
જલ્દી કરજો.
which you can use as and when necessary. I'm just talking about the indications of hinge total knee plastic, and as you know, a couple of companies do have the system in place, starting from Indian-made systems as well, and of course the debut system is there because from Noise has been there for years. Very expensive, but in difficult situations, the hinge knee has to be considered, and nothing to be feared about because it does give good long-term lasting results. Indications, broad indications would be very elderly patients in which you have doubts about their collateral sufficiency. So, and whenever there is a collateral insufficiency, directly you can go to a hinge knee instead of building it up with wedges and extra metal. Very severe varus or valgus, that means deformity greater than 20 degrees, hinge knees can be considered. Collateral ligament loss, again, which can be considered. Cross flexion extension gap imbalance. Sometimes at surgery, you may face this. So as a backup, this has to be in your mind, even though you may not have the whole system with you in the theater. Then hyperlax joint. Some joints will be inherently very hyperlax. In these cases, hinge knee can be considered. Infection and post-infection management, which means the second surgery after getting infection under control.
So another knife, please.
Balancing is impossible or very, very
No, मुझे
difficult
kidney tray में
even
दिया करो
with,
sir. You bring kidney tray,
lots
take
of
away
metal
kidney tray.
going
हाँ?
in.
हाथ में
So
नहीं.
hinge knee is the bailout option. Then aseptic loosening, joints which have been in place for 15,
Yeah, that's
20
our
years.
video.
When you do a revision for these,
So let the video
all you
go.
see in
Doesn't
the
matter.
X-rays is loose
Let video go.
metal on one side. But when you actually go
वो
in,
talk में
you
disturb
see
नहीं होना
a
चाहिए.
lot of the bone has been converted to soft tissue. And once you remove all that, the gap balancing changes completely. And of course, instability and bone loss will join. Hinge joints have been available for many years, starting from 1975. Good hinge joints came in from 2000 onwards. Estrom mobile bearing processes, excellent system. As I said, very expensive, but you can do a totally uncemented hinge joint with that system. Hinge joints are two types of joints. One are purely hinge joint, just like a door hinge can be there, in which there is no rotation. And then there are rotating platform hinge joints. Now, the rotating platform hinge joints have changed the whole dynamics of hinge joints available in the market because they will last longer. The wear and tear will be less. The extra forces acting at the implant bone interface is less with the rotating.
No, don't take away the knife.
hinge
I'll
joint,
constant.
and
Four
they
step
should be
also.
considered whenever
Just leave it here
one is,
only.
taking up.
Rest you
And
can
usually
play
the
if you want. Right?
rotating system is at the tibial level, tibial processes level, so they can be considered. As you said, indications, a good paper from 2018 by Cook et al. Published. They reviewed the literature on rotating hinge processes for complex revision, and their findings suggest that the hinge implants do give good survivorship from 51 to 92.5% at 10 years. So a complex revision surgeries or a hinge joint are giving you long-term results is an excellent thing to have in hand. Complications rates vary, of course. The simple
Too much
ones
of
would be
synovitis,
from minor fractures to infection, and they can go up to 63% infection rate. And as I said, aseptic loosening is definitely there. We are seeing it less and less with the rotating hinge joints. And there are again indicators for infection, aseptic loosening, instability, and bone drop. This is a rotating hinge knee prosthesis implanted as a primary in a 74-year-old with severe varus deformity and bone loss. That's the pre-operative and post-operative X-rays. Hinge joint, in my experience, when I have been visiting various centers, German surgeons use them.
Whenever you
very,
want
very
to preserve things, stitch it back.
anytime they
Why do you
find
want to burn
a
them?
patient
My only basic thing is, if you want to take away something, excise it, that's fine.
complaints,
But if you're going to
they
stitch
don't
back things,
hesitate
why do
at
you want to
all
burn
in
them?
converting them to hinge joints. Whereas in India, we are much
So,
more
can I have
conservative in using our hinge joints. We try to build
the
up with
two
bone
homins, please?
grafts, metal,
One broad and one small.
cement. Whereas in the Western countries,
So what
they
I
don't
require
mind
is,
putting in more and
yeah,
more
one of
metal
the,
in the joint.
and
So rotating
two of
hinge,
these.
these processes in a revision case.
Is this what
as
you
can
use
see
for
on the left,
PCL?
large
Yeah, okay.
gaps, subluxation of the joint, and
So he's
posterior
a bit of
follow-up
tight
with a
knee.
rotating hinge
I have to
joint.
keep going
This
backward.
is one of my patients, 66-year-old,
Huh?
with a very
This one?
severe valgus
Yeah,
knee,
this won't have
fixed
much. You
valgus,
need to come here first.
and she had a FFP
That's a
and a
deep MCL.
valgus, not
And I'll
correctable
take
to
this
neutral at all,
sublux.
and with a
Definitely
large,
the
with a very
subluxation
lax
here.
MCL joint, and hinge
And there's a
joints
piece also which has
do
come out.
very well in such cases. And
Yeah. So now
in her
do what
case,
is Renshaw.
she had a previous
That's
injury.
it. So
The
subluxated.
anterior bone loss was there.
So
in
another
the
small one.
distal femur as well. If you could get away with a good. Because her walking unsupported, at least she got her alignment right. The X-rays look good. There was
Not
a
these
lot
ones.
of
You don't have normal
cement
ones,
we
is
had
it?
to put in the anterior part
Or
of
ऐसे
the
होंगे?
femur.
They
But
require one
with
like this.
using
There's
long
some.
enough stems, this is a very viable case.
Yeah, come. So
scenario.
that's
Infected
thing.
knees who have been converted to spacers, getting the infection under control. As you can see, there's major
We'll be
bone
ready
loss
as soon as
all
this
around
lecture goes.
in the tibia, except for the little glands on the lateral side near the fibular head. A lot of bone loss from the femur as well. In such cases, hinge joints are a lifesaver, and patients can be up
So
and
this
about
is something
without support.
I'll discuss
on the
when
next
we
day
speak.
or
Huh?
so. This is a patient with previously operated knee. She had been
So please be
injured knee.
Nibbler,
On
please.
the right side, someone has done a TKR for her. Very unsatisfactory X-ray.
Huh.
I did not revise that
Do we have
side
osteotomy?
because she
This will
has
be easier with
very
osteotomy.
adherent scar with skin graft on the right side.
Osteotomy.
The
कुछ
left
तुम्हारे पास
side
है
we
कुछ
did,
यहाँ
and
ऐसा
then
है.
this side you can see there's a
All basic should be with him.
Mercedes-Benz
No, no,
car
not cut.
in
Straight
front of the
osteotomy, please.
knee. But since it was the
It's too
old
big,
scar,
man.
we decided to do her left knee. And
Anything smaller?
that's
No?
the
Okay,
bad
hammer. Don't panic, hammer.
on the operator.
It's not very
and
tempting.
she had instability as well. So we decided to do a hinge joint in her. That's a PCK joint there. Another patient, 63-year-old with MCL there. Someone had
Is that
done an
one, but I need a
arthroscopy for
smaller
her
one for
a
this, but anyway.
meniscus injury. This is a very, very obese patient, 110 kg. So
Think
he
small.
came to me one month post arthroscopy during physiotherapy. She broke her MCL. She tore her MCL. And
Thank
then she was not walking for the last 8 months. So we decided to do a hinge joint in her because it was pointless in trying to reconstruct her MCL.
Okay.
This is her
You have a femur sizer?
3 weeks post-operatively.
So I
back on her feet.
always do this one now
And
to
it
just get a
goes
rough
flexible.
idea where we'll be
So
heading
these are
towards.
just some of the broad indications for these
Just
joints
a bit more.
available now and should be
Sorry.
considered without.
Four seems reasonable, minus this cartilage. Okay, four. Just give me 5 just for check. So,
Thank you, Dr. Satish,
just
sir.
because you felt good with
Now
somebody
we would
doesn't
like
mean
to
you. So this
continue
is coming on
second
top
case,
also, huh?
live surgery
So
to
this undersurface should
primary
be
replacement
with
with pin by Dr. Rakesh
think four
Rajput,
is-
and I would like
So
to
just give me
invite
4
Dr. Satish Patel and Dr. Karthik Shukla as a moderator for this surgery. Thank you.
So we can do medial lateral also, we are pretty okay, huh? So 4 is good, yeah. So we do check also. So now we can go ahead with what we want. So now get connected. Is my voice on?
Can you hear us, Dr. Rajput?
Ah, Karthik,
How are you? Good morning.
so nice to see you. You've added a couple of more kgs, man.
Most welcome to Ahmedabad. Show your
Thank you.
miracles to us today.
Right, so I think we've taken away the boring bit, the exposure that's been done very well by the previous surgeon. So what I say here is before you actually do any TKR, and even more with gap balancing, always do a check. You can do, if you do strain views like valgus and varus strains in the, for every case, that's fine, but that's too much of radiation. So anesthesia, always do that. Many of these look very bad on X-rays. The moment they lie and you stretch, they come back normal. So in these cases, what the previous surgeon was saying, do very less release on the medial side. Don't do too much releases, but mine was very rigid, very arthritic. So we have gone all the way till back, release that. Number 2, regarding the PCL. So in this case, if you have got experience with our lax knees in India, you will get away with many times with PCL preservation. However, if you speak to Frederick Beuchel, he'll tell you the first thing to do is to cut off the PCL. That makes your whole operation very easy. And I actually agreed with that. Because when I tried to preserve the PCL and do these operations, many times I really struggled. So that's something I've now learned. Unless it's a very lax knee, as I said, during testing, then I would preserve the PCL if I need to sacrifice. Otherwise, PCL sacrificing at the beginning itself. Number 2, it is a gap balancing, so you don't want any osteophytes going to affect you. So take away all the osteophytes. Tibial osteophytes don't need to be taken away at this stage because you're going to cut tibia first. So we can debate about that, whether it's gap balancing or section. But in the end, I'll tell you what, if you look at the most literature, most of them are hybrid. And I think you had the previous speaker also, after doing everything, you were still thinking about releasing the MCL. So at that time, I think you become actually a mixed person, which what we call as a hybrid. And most doctors actually are hybrid. Even if you look at the measure dissection after cutting, they go back and cutting some more or take away some osteophyte reduction, osteotomy, whatever. So you're still doing cutting going on. So none of them is actually a pure gap balancing, but yes, predominantly how you start is what you actually call your technique. So we are going to start as a gap balancing. So tibial cut, please. Huh? Karthik, am I not audible?
The sound is, you are audible, but the clarity is not much. So difficult to pick up the words and sentences very
So
precisely.
maybe I'll speak a bit slowly. Will
Yeah,
that help?
that would be good. That would be
That's
good.
not like me though. So that will slow me down even in the operation. Okay, so maybe have the TVL check. Oh, that's difficult to talk really slowly. So if there are any queries from the previous case also, we can keep on tackling. Now even I can't hear him. This is 0.
Dr. Ashok, can you hear me?
I can hear you, but sometimes it breaks.
Okay,
Okay,
I
can
just
we,
want to ask about the tibial slope.
Slope?
Tibial slope, what would be the tibial slope you put in this system?
So in this system, literature system, it's not very maintain the anatomical slope is what they say and they get away with it. So I think you need to use your own mind, what you're looking. If you find that the patient's a bit lax FFDs and all that, then I would actually reduce the slopes a bit. So I won't go on the anatomical one unless if somebody is like beyond 10 degrees, I would go match that. Between 5 and 8, I think that I would keep. So this guy has got a hardly not too much of a slope, but slope. Probably about 5 to 7. This one. When you're eyeballing, you cannot be perfect, but match it if possible. Okay, can we have the stylus? Yeah. So because his rigid will go under the 0. Yeah. So because we are dealing with a rigid knee, we'll probably go to the depth of the, which is not great anyway, but it's denuded, cartilage gone. So we'll go to the depth and we'll put 0 there, the starting point. And also I think, yeah. So pins here, please. Yeah.
So the stylus in the system has only 0 and 2. So you can
0
see
and 2, yeah.
not like the other system, like 6, 7, 8,
Only
9,
stylus
0 and 2.
So can I have the angel wing? So again, you are probably in this one, I think, again, your sizing depends upon how much the thickness of the poly is going to be. So for smaller sizes, let's say you even get polys of like just past 6 mm and all that. So the bigger you get, the minimum poly will be slightly larger. So what you want to be sure is that you're not cutting too much bone. So be bone conservative in the beginning. That's more important. So again, you do a visual check, how much bone you're cutting. So I think we are just about okay. We're not very conservative here, but we're not too much anyway. You have shims you can add to increase the gap, but I think be on the least gap if it is possible. So that's next message. So
So any system in the world where you are more towards gap balancing, your tibia is a platform. The tibia cut is everything on which your next step will be decided upon. So tibial cut, you have to pay a lot of attention, and it's very important cut.
knife, please. No, I'm a knife man. So he's got lots of capsular attachment because I said he's really arthritic. We do a measure here, please. So we do a measure. It doesn't really where you started up, but you need to know where you were. We are about 8 mm. I think that's about 7 mm, 8 mm is a very good start. Okay, so can we leave the pin and just take this out? वो करेंगे, इसको निकाल दो.
We can hardly understand. I think maybe you are wearing a helmet and hood.
Just keep this here. So then. Okay. Now, it's nice to actually have a rough idea about what sort of tibia you're going to aiming at. So just give me 4 or 5 tibia. No, just the tibia. So get a rough idea about where you are with your tibia. Because as I said, now you still have some osteophytes on the medial side, which you will be balancing on the femur. So take away those osteophytes now. So I think for us 4 looks good. So we have some amount of osteophytes here, which will take away. I the
I think
saw
this
to
is a good thing to do. Put your child tibia, and this will help you to plan to remove your osteophytes in a very better position.
saw again, please. So we have a bit of unevenness here. We'll just take that out. Okay, he's very rigid. There's a saw which has skidded out on this side, but I think we're okay now. So next comes the femur bit. So you'll probably see most doctors adapt to the technology in their own way, but we still go by the book. So can we have the size? Oh, we've done the sizing as we were talking before. So we found this to be size 4 femur. So the previous doctors already told you how to do the sizing, so we'll skip that step. So, sorry, can I have the yoke and this thing? Size 4.
The
No,
lateral
not this.
condyle is the
Yeah,
thing
so
that-
lateral condyle size, we've done that, okay? So that's very good batch. And you are sizing the bone, not the cartilage. And so this is where you are actually really pressing hard on the superior cortex. And on this inside which you're seeing, you're slightly medial to the apex, okay? So the notch, the top of the notch, you're slightly more, ever so slightly medially, okay? Now pin, please.
The advantage here is we are referencing the distal femur. The doing in our patient is too much sometimes. So if it is a long rod, just like a routine system, you are
That's
putting
fine.
your femur in different position.
So drill,
So
please.
distal femur, 1/3 of the
So
femur is
all
lateral.
this was just to get an entry. Again, never trust your jigs blindly. So feel. Your drill is like your third hand. So keep feeling that you are in the bone. You can err at times if you have deformed femurs. Okay. And go slow. So can we have these out? So we are aiming for these 4 on both sides. So we feel happy actually. If you're matching, you feel happy on one side up and down. But you're in trouble if you're actually having 2 sizes up and something is not right. Okay, so 4, please.
How much valgus you are planning in this case?
Sorry, so valgus, another good question. Thank you, Karthik, for bringing this up. So valgus, I think actually depends upon, we should have templated that in the beginning. So this patient looks like a very normal, his average height. So probably 5 degrees on this one. But if you were, very tall, then you would decrease the valgus, and you would also decrease for very obese people. That's how I go about. But the best thing is actually template them on the scanogram.
Okay.
So can we get this? Okay. I'm guessing I'm too loud. Sorry? Test, yeah. Hello, Karthik. How's the audio now?
This is better.
Better? Okay, chalo,
Yes.
let's go now. So the trick to actually get this in is don't put this intramedullary rod all the way in first. Okay, keep it out and do in maximum flexion. Try to thumb hold and then go slowly in. Sometimes you need a couple of hammer blows. Just okay, no. Just hammer just to get this engaged in. Just hammer. Yeah, and if it is not going, which means we need to cut more. So a bit more. Okay. And now? Yeah. So I think we just but okay, we are on the tight side, not on the loose side. Okay. So that's something to think. And then you have a look. This also actually sets your rotation. And I think we can just see the mid side down and the left side up. We have derotated him. So this probably seems to be one of those ideal cases. Sometimes not all cases are like that. Seems okay. Okay. Pin now. But just in our mind, we are on the tighter side. That's what we have to remember.
Can you hear my voice better with this mic?
I can't hear this. What was it? Karthik, can be a bit louder? I didn't miss that question.
Yes. You are just checking the another mic. This is fine.
Oh, another mic. Okay, okay, okay. Yeah, so can I have the ECG? So I think before you do any more cuts, do again check with, I have one thing with this company. I think they can do a bit more better angel wing. Their angel wing isn't very great. So I think that's something Sudarshan and team Venkat probably just have another go at this angel wings. I think we can make this better, but you can check like we are on the top here. Okay. Because sometimes I've seen with this that it seems to angle down and there is a small amount of notching which happens, which is not terrible because it happens only on the lateral side, but just be aware of that.
So actually, this is interesting to understand. We are not measuring any degrees here, like 2-degree external rotation or 4 or 5 or 6 or something like this. And that's why
Yeah. So we do a superficial cut first and then we do a line. So we're really absolutely flush here. So can we bend this a bit more? Yeah. So before I think they used to have actually go on. I used to find very tricky to work with, but now they have closed boxes. I think are better. Oh, yeah. So you can go.
So what we are accustomed with upsizing, downsizing, flexion and extension, and this is not going to be needed.
Yeah.
Here. If a table cut is perfect, everything will fall in place automatically.
Because of the box, sometimes it doesn't cut on both the sides. So we can do that now if required. Just take this out.
So in the nasal resection, we have two systems for femur, anterior referencing system and posterior referencing system. Here it is just
Do you have a laminar spreader?
referencing system, and the whole idea is to
Do you have a laminar
fiber
spreader?
cord in the center.
No, okay,
So
fine. Give me that yoke.
Based completely on the tibial cut. That is
The
very
intermediary
important.
thing which you had given. That yoke you had given, yeah. So we can use that to lever up. So just hold that. So what I'm going to do, we don't seem to have a laminar spreader here, but we'll try and clear the posterior side now. Okay. So because he's quite athletic on the medial side, we do so we have this tiny osteophytes or pearls. We might have more.
So if you see the rod also, it is not a long rod in this system. There's only one rod available, and that is you have to use that standard rod to reference the distal femur growing all the time when you implant the femoral component.
This is not a very good technique though, Karthik. I think in rheumatoids, you can actually crack open the anterior cortex. We're doing this, but I think he's quite athletic. So we have another osteophyte which is coming out. So you can see that. Big pearl. So a few more. So we have quite a few actually. So we have some more coming out. So we have nibbler. So 3 more have come out. So it's got fair amount of things in the back, which wasn't very clear on these type of X-rays. So there's another smooth osteophyte, soft osteophyte. Oh. That's a big amount actually. That's taken up.
So
Now I can actually put my finger behind and feel everything. So we are okay now on the medial side. So I don't expect a lot on the lateral, but I think we'll just have a quick look. Another moment, please. Yeah.
So pay attention on the bone so that you don't need to disturb soft tissues or not. So bony preparation is so important rather than
So the shoal here is quite stuck to the posterior femur condyle. So I'm going to just release that a little bit because this actually affects your extension gap. Thank you.
And because this is a lift liner inside, your posterior clearance is very important in this system. So this is a high flex knee. So if you leave posterior up to 5 and the curvature of the poly is little bit proud, it will impinge in the deep flexion. So this is a very important step to clear your posterior femoral area to prevent impingement and prevent unnecessary dissection of the distal femur, because any release of the back will affect the rectus. So if this step is not done properly, you are going to cut more distal femur because you are not measuring anyway, and you are going to elevate the joint line in this system. So one criticism usually seen in literature is elevation of
Done there
joint
now.
line. But this is very
Okay.
important step.
Yes, sir. Been- So now give me the yoke and the distal cut. Jay. The gap, okay. So the other thing which I find sometimes with BP is that this is very good and solid gap measure. So you can't cheat this, okay? The only trouble is that sometimes it's too wide for some of our smaller patients. So maybe we should have another sizes which are slightly less mediolateral. So that's another feedback I can give live here. So that's listening, I hope. Right? So which actually nice. Maybe you could call a drawback of this system that you are only checking at 0 or maybe 20 and 90. We should be checking somewhere in mid. So we leave ourselves open to mid flexion instability. If that can happen. Luckily for BP knee, it's got very good wedges and very tight inside. That's why you put the femur in when the poly is already there. So that overcomes this small issue of mid flexion instability, but that can happen. We are pretty clear. All happy. So now let's go for
So the flexion gap is done, soft tissue release, posterior clearance is done, and now extension gap is reproduced as per the flexion gap. So that's the whole idea.
okay. So give me the gap. No, first put this first statement. So you start off with flexion and then pull it towards. Yeah, that's it. So that
Always very
you go in extension straight away.
range of motion.
So I think patient might be a good man. They're getting you at one go everything right. But I think we've got very nice stability on this one. Just the amount of tension you want both in flexion and extension. That's what we have exactly got. So if you put one, leave this in half. Full. Okay, we can do that. Okay. Right. So we are reasonable now. Maybe we can take this out also now.
So if this system is understood very well, this is very easy way to do a total knee replacement. So we are not measuring plus 2, 9, 10, 11, and just reproduce your extension gap as your flexion gap.
Now put it somewhere. Oh, so we'll distal cut now. So here, another one here. So if you can come this side. So just put one more here. You don't have a spike? One more spike, please. Big one out there. Yeah, that's fine. Anything just to take. Softly.
If you are a little bit tight or loose, you can play with your valgus angle even before you want to release any soft tissue. because there are 4 options available for distal femur valgus. So that is the modularity you need maximum. This is a bit oblique distal femur cut. So it looks little thicker anteriorly and it becomes thinner posteriorly. Very small chamfer cut, very small. So it's very bone preserving
Okay.
system when you actually see on table. Very minimal amount of bone resection is done in chamfer. And as in previous surgery we had seen, you can just
Can come back.
impact the notch. So
Okay,
actually
pin
you
out.
don't need to put a bone graft or anything to catch your intramedullary canal. You can utilize the same bone, just impact it at the center.
Okay. So maybe we are a bit tight. Just bend again. No, we are not tight actually. Okay, we are absolutely fine. So if you try to straighten and then put this jigs in, it doesn't want to go in. So do flexion a bit, put it back and then straighten out. And then you're fine. So we are okay now. Okay. So that we've done. Stability wise, it looks quite good. So out, please.
After infection, the second biggest problem is instability after total
We'll
knee.
do finish the femur.
So this is least possible in the system. Very easy way you can have a very stable flexion gap, extension gap, and mid flexion stability throughout range of motion.
Just a little
And
bit.
now you can see how less bone we are going to remove in this system.
You need a bigger hammer than that. ये क्या hammer है? और बड़ा चाहिए. This is too small.
Second thing, the problem of putting your femur into flexion exam. You have done everything and you realize lastly when you are putting your trial that your femur is going in flexion, will never happen because of this is a snug fixed box system. So that is not possible again to have that issue.
थोड़ा सा medial थोड़ा हो जाएगा. मारो तो. Okay. You will be okay with that. So the bang in. Okay, pins. So Karthik, again, one good thing about this jig I like is, not one actually, there are quite a few, but one what I like about is that all these chamfer cuts are well protected by metal. That will probably kill your saw, but I think it will prevent any soft tissue injuries. The second one is the one I think in the previous surgery you might have seen. That
You are not going to cause any damage to the soft tissue because it's a closed system. The box is closed and your cuts are inside the metal. So that is ensure your safety as well indirectly. And very less amount of bone resection is done in this system.
But because of that, sometimes you don't know whether you've cut the chamfer or not. Because you never feel the give. You have
Very
an
little
osteotome?
cochlear cut.
We don't have a small osteotome, no?
Then you can just cut it.
Oh, तेरे पास था chisel है sir. Okay. But I need to first lift it up. It's okay, sir. Chalo. Give me the punch. So I think we were discussing the other good thing about this is that with this bone, most of us actually just put it back. It does two things. One, it actually gives you some more bone in that area. Number two, it plugs your hole which you had made. So you don't need to put any.
It will be locked inside.
The canal. Okay. And okay. And give me the posterior osteotome. So now flex it a bit more.
With two bag hole.
Yeah, so now what we do is, just for high flexion sake, we go behind and see if we have any osteophyte. So actually check first. I don't go blindly hitting with it, because if you go blindly and if there's no osteophyte, you'll go and hit the posterior cortex. So just check whether you have any bone. In this case, we don't have actually. So there's no point in hammering it unnecessarily. Okay, pin out, please. Relax. Very hard bone. So a lot of work for you. Okay, slot.
How flex fit this box cut?
Yeah, so this is what I was saying, that you never know whether you've cut the whole chamfers or not. Nibbler. 4-step. My 4-step has disappeared. Thank you. Right, so we'll go for tibia now. Huh? Want to sit? You can do. You don't have faith in your system.
The design is very narrow anteriorly, so the overhang issue will never be there. You can appreciate in this image very well. It's quite narrow.
Okay.
You can do reverse framing inside as well, to preserve a little bit more bone as well if you want. Rather than the clockwise, you can go anti-clockwise, but one will be settled inside.
Karthik, always go anti-clockwise.
Hello?
You always want to try and preserve as much bone as you can.
Yes.
So here I would to bring parallel with Dipui, because this system was originally with Dipui, right? Karthik?
Yes, I cannot hear your word actually.
So originally with Dipui as LCS, right? So what they have is they have Dipui now. I'll tell you why. Because the LCS was so popular and many such still wanted it, they launched their attitude. They did the same system in tibia for both fixed bearing and rotating platform. They made huge hole for even fixed bearing people, and all of them are in trouble. So this is a legacy of this system with Dipui, that many reasons when they were designing the attune, they ended up making this huge hole. And now they have problem with tibial base plate for fixed bearing people. So you shouldn't copy a design not knowing what you're intending to do with.
Actually, this is the third generation.
I hope you guys are listening.
Second is LCS. First was NJ1. This is NJ3. New Jersey 3.
Yeah, just
And
extend.
it is now with CTK. It is
No,
Beuchel Pappas.
Bend a bit more.
You
Okay.
can see the
Now
quite
female.
curved congruent poly anteriorly looped. So you have to
That's
follow
okay.
this sequence: tibia,
Now come back.
poly, and femur. Every single time.
Okay. Okay. और कर लो. Okay. Right. So now we have more or less our trial implants gone in I don't know, what do you want to more stable? But so we are going into almost full flexion. And check it. I think this one is actually very good pattern. And we can at chest stability at 90. I don't even check 45. So this looks very stable. So because we've gone slightly on the tighter side. So is that so you want to till the whole cement goes, or do you want to stop here?
It's fine. It's fine. We can start here. Excellent demonstration, Dr. Rajput.
Okay.
Thank you for showing us a wonderful tips and tricks as well. So we will go ahead with the further lecture here and expecting you come back here to meet you. Okay. I think so. We can just have a tea break and then there will be one lecture. Okay. So we will gather after tea break again.
Do we have a Austria? So you can start opening the thing. Huh? So can we give a wash? We don't have. Whatever. Previously, I was seeing one round disc-like thing. So not every carry. So you first thing is to find out whether they're lax or not. That's the first thing you need to find out. Your whole steps become different. So if it was lax, I would have left PCL. So when Beuchel came to us, I spoke to him and I said, I'm struggling. He said, cut the PCL. I said, but many cases I have got away with it. So your cases are different. We don't seem to get away in US. But yeah, that's why he preserved, isn't it? Yeah. So you probably 35% in that practice. That time you are hammering these boxes, the PCL goes. This one is very high up, but sometimes here, just about here, it tends to go. So were you saying something, sir? Yeah, the extramedullary jig is to get the intermedullary rod in, because that sets your entry of the rod. So give me that jig, extramedullary jig, that yoke. Not that. No, not that. ये तो बाद में है. Yoke. The one at the beginning. Yeah, this one. And you attach this to the, not this one, the original one you had. Now this goes in. इसमें डालो. So when you this touch the anterior cortex, it gives you just that amount of space down so that you can actually start drilling in here. So that you are parallel to the shaft. This is parallel to the shaft. So your drill will also go parallel to the shaft, just down. So this is guiding you to go into the cortex without, because your hand can sometimes shake when you're putting normal cases. It's a very beautiful thing actually. But again, I said some cases will be very curved. So when you're entering in, you always feel with your hand when you go in. Are we done? Wash. Should I change gloves? Huh? PMJ नहीं है ना? यहाँ पे आके बहुत सुन रहा हूँ PMJ. ये वो नहीं है ना? Gloves change होगा? Okay. So goes in red. Thank you. Retractor? Whatever we've been using, just go with it. We just need to take away these dirty things. Too much of. So what we do is this stage, a new sheet comes in actually. We don't use. We have one small bag which we tied up. So mop. Is your mop? हाँ mops लगेगा अभी. Also, what happens at this stage, there's too much of water around here. So our sheet actually goes like this. So everything is, so your sutures will also go on a very nice clean sheet. So, yeah, and we have that. Oh, you have that.
No.
Mosquito रखना दो.
Hello, hello, check, 1, 2, 3, hello. Hello.
They're talking to us.
Yes.
Is my volume still on or off?
Hello, check, 1, 2, 3, hello,
Okay,
hello.
they are checking with the other mic, is it? Okay, are we ready?
Hello,
I need some water. We use this.
check, 1, 2, 3, audio check.
Is this 40 or 20? 40.
Hello, check, 1, 2, 3.
So ये system ना Attune ने copy किया है. उन लोग का TBI if you see. No. They're Attune design. That's so most modern. Yeah. So now they have such a huge hole, but they have a fixed bearing. So the table base plate toggles. They should be having a small hole for fixed bearing because they want to have the same system for both mobile bearing and fixed bearing. They use this hole because mobile bearing needs this big hole. So I keep cursing them. Why did you ever do this? Bola, sir, galti ho gaya. Bola, bukto. So now they have brought something called inlines, which means the same size peg. So that cement can be pressurized, but still they have base plate loosening. They have buggered up this design because of copying legacy of Beuchel Pappas. Ready? थोड़ा सा और लगेगा और नहीं मतलब थोड़ा और वेट करेंगे तो ये चले जाएगा अंदर बाकी के लिए और लगेगा टीवी में so this is where you really need to pack huh
Hello.
थोड़ा और होगा फीमर में थोड़ा जाएगा तो नो प्रॉब्लम फीमर इसका हमेशा इज वेरी सॉलिड इट्स द टीबिया व्हिच इज द ट्रबल
Hello, check, 1, 2, hello. Hello. Hello.
Hello.
Hello, my check. Hello. 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 Hello, my check. Hello. 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 Check. Hello. 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 Hello.
So you see I didn't use diaphragm at all huh if you see one from diaphragm here you will stop using so I've had two so I said if I can do without diaphragm I will always also I think okay Holly okay let's get it out sit bend okay you have to give me quickly this will lift off because we are slightly tighter Ben. Okay. Okay. Ben. Okay. Straight now, a bit more. Now bang. Okay. और मारना है थोड़ा. So one more bang. थोड़ा ये लो, चलो थोड़ा जोर मारना है, जितना जी में है. Okay, चलो. Okay, we need to straighten it now. ये बाद में निकालेंगे. तो उसका टीबिया उठता रहेगा. Do you keep a pillow here or no? No? Okay. हाँ? कहाँ पे? कर लो. इसमें it doesn't matter much. No, because it rotates. So that's the whole beauty of this, that is not critical where you put tibial rotation. But yeah, try to be as good as possible. So if it's not at 0, do 5, 10 also. Base plate. Base plate is just for putting the tibia will move more around with the femur. So rotation doesn't really matter in this. That's the whole beauty of this operation. That you can get rotationally wrong and still be right. मुझे एक मॉप देना. I don't want to push my hands on this. नहीं ये गंदा है. और एक ये भी योजना वाला है क्या पेशेंट? ये भी योजना वाला है क्या? इसीलिए इतना कंजूसी चल रहा है. Seriously, you guys are really fucked. मेरा जो WBHS है, which is the cheapest, that is still almost double than this. उसमें भी 90 plus 55, so that's 4150 चले जाता है. We get 150 with the implants, of course. So we don't do any of these conjusies. मैं सुना. I was hearing yesterday and I told all this, and I was saying that the Prime Minister is. This is not practical. Now he should talk to doctors and say, is this practical? Talk to 20 surgeons if you want and say, is this practical? या तो आप योजना सबके लिए मत करो फिर. You have a poverty line drawn in कि ठीक है तेरा salary दिखाओ. हाँ, salary दिखाओ.
Everyone will get that card.
नहीं, you have to go.
Political.
ठीक है यार, जो 2 लाख रुपया सैलरी मिल रहा है वो नहीं कम कर पाएगा, कितना करेगा? तुम बोलेगा क्या मैं वोडाफोन का रीजनल हेड हूँ लेकिन मेरा सैलरी 5000 रुपया महीना है? कैन यू से दैट? या मैं टीटीके में काम करता हूँ लेकिन सैलरी 10,000 रुपया है? हाँ, वो तो हो सकता है. बोले क्या सुनील? So Sudarshan and me were together in Bharat. So I was designing Bharat at that stage. Then I'm still doing. So you show me a jig, the tibial cut, the femur distal cutting block. Yeah. So this is where you cut, and then you have to move.
Yes.
So in my jig, this slot is also another slot for a 2 mm cut. So if you want to move 2 mm, you don't have to take it out. Just from here, you just cut from here. So I designed that for Bharat. So it's called my block. So they give it to everybody. Rajput sir ka block hai. And otherwise we can see, I don't think there is much now difference between implants. They've all caught up with each other. This is something different, absolutely different from others. ये कौन खड़ा होके बोल रहा है? ये बोलो टी ब्रेक लिया है शायद ना? Similar to that LCS design. Yeah, LCS ही है. It just slightly more. So give me that trials which you had just. No, femur tibia. So if you look, no, उसका जो बे, इसमें वो नहीं है, but original में आता है. So है trial में, कोई trial में नहीं है, नहीं. So if you look at the original, they have a knob here. एक knob वो इसमें घुसता है. So it allows you to rotate only this much. This stops, so that knob goes in here. The center knob, you saw when we put it in. So it only allows you to move this much. So LCS में क्या था? It could move so much and then open up and fall. So spin out, as we call. So वो pin के कारण it only allows you this much. So spin off नहीं होगा. Number two, these edges have gone in. This is raised quite a lot. So you get a bit more of valgus medial lateral stability. This will prevent you accidentally tibia going forward. Right? So femur won't go on top of it. So that's, so like if you look at Marriott was the first one who actually brought this design in. It used to be called anterior stabilized. And now, otherwise, see, this wasn't, you could actually put femur first and then put the poly in. Because of this, you can't put poly thing. Yeah, and also piche bhi nahi jayega. So this back-to-back movement has been taken care of. We don't want that. Right? So that's two things. And the third thing is that the femur, if you look, this is slightly deeper, but if you look at, this is slightly in compared to that. So this has become longer with more modern designs, right? So they have become longer. So lateral flange goes in, it becomes thinner. This hasn't become thinner. So the next innovation might be to make this thin so that you don't get anterior stuffing, right? So this will become a bit thinner. I'm sure they'll do it. Otherwise, the group has always been patella friendly. So even if you don't replace patella, it's fine. So the only thing which we might have some argument would be that are these pegs really required? Because in soft bone damage, so you have made hole in the middle, two more condyles can come out. So far, I have not noticed though this. So the contact between LCS and this, LCS used to have 35% contact between this at any, only between 30 and 90-degree flexion. So your weight bearing depends in there only. So full knee, straight knee, utna weight bearing nahi hota, but moment you go 30, then a lot of stress is going. And then stair climbing with 90-degree pe stress padta hai. So that is where you need good contact. So it adjusts and take away the stress. So you can move slightly adjusting and it will take the stress. Mainly हम लोग का medial side उतना नहीं हिलता है. It's the lateral side which moves a lot. So if you can rotate laterally itself is enough. This is why you nowadays hear about medial pivot, like medial stays and lateral side moves. So medially it's pivoting. The knee is a very complex design and we are trying to make it simpler. At least this has gone to take some more. हो गया? Heat है अभी इसको थोड़ा सा cool होने दो. I don't believe much in this, but yeah, so I used to first do that. I used to change patellas, then I stopped changing patellas and did circumcision. And then I brought the circumcision closer because they said 4 mm ke upar mein blood supply hai, nothing seems to matter. So Bristol have come in, John Newman and Ben Squires. They've clearly showed that it doesn't make any difference. Like you can't look at a patella and say it has to be replaced. But yes, this one I take out. Yeah, so I'm having tracking problems, suppose now. And then if I find that release is not going to be enough, then I can change patella now and shift for smaller size, but shift more medially for it to track. So that can do some cheating. But if it's tracking well, it won't change. This is tracking quite well. नहीं, I didn't use it. मैं marking भी करता हूँ तो generally I use pen. Even UCAS I just use pen. I don't use this. UCAS में mark करना पड़ता है. I like just cauteries. इसका smell ही first of कितना खराब है. Number two, you're burning tissues. Bone में ठीक है, I can understand. But soft tissues में you're going to stitch this bone now and you actually cut this. क्यों होगा? नहीं होगा. अच्छा आप लोग टूनिकेट नहीं देते हो? You moved away from tourniquets. Using. So tourniquets we use only for 4 hours. वो PSC से जब वार्ड में जाता है patient, tourniquet off. All bleeding happens as soon as you take out the tourniquet. उसके बाद तो फिर it's a nuisance. Then it can carry infection inside. So you just take out the tourniquet after 4 hours. In case some आजकल once we started using tranexamic acid, we don't see that big bleeds we used to see 700-800. Then we used to clamp the tourniquet. Clamp it for 1 hour and छोड़ दो. But since we've started using tranexamic acid, we never see this bleed. So that has been really good. ठीक है. चलो, I think we're done. Let's go back now and see. कहाँ पे ये है? यहाँ पे थोड़ा ऑस्ट्रोटम है हमारा. तुम कहाँ से है? नहीं ये गुजरात का ही है. अच्छा
मैं मुंबई.
हाँ आमची मुंबई. मुंबई में कहाँ से? अंधेरी. हाँ कांदिवली ईस्ट. Houses. But I don't stay there. My younger brother and dad used to stay. TMRI, Calcutta Hospital.
Thank you.
Same chain as Bengal, Bombay Ortho. Same owners, same day, 53 years. Inception. तुम लोग 8 साल हुआ ना अभी इधर? 8-9 years. थोड़ा वॉश करें इसको. चलो, we'll catch this whatever spill comes, and we can suck. Okay. Okay. Where's your yellow one? You can't pick rice up. You shouldn't be touching it. Okay, can you close? Actually, I use 2, then 20, and then 20 skin. But you can use whatever you've been using. We are okay. Yeah, pretty good. Okay. So एक sheet ने बहुत मुश्किल है. We can start this. I'm so thankful to God कि मेरे वहाँ पे ये नहीं है प्रधानमंत्री. So we can suture material will go good clean sheet. अच्छा, you want me to go? नहीं. हाँ ध्रुव ना. हाँ मालूम है. लो चलो ध्रुव. So this is we had learned. Normally people say middle parapet. We see make a L here. You see that? That was something. Not everybody does that. You see there's an L. So back. So you can do in semi flexion. Thank you. Thank you.
I hope कोई तकलीफ नहीं रही.
नहीं, it was quite pleasure. Oh. हाँ? Thank you. Can I give you this? Just take out yourself, otherwise I might bend it.
बस बराबर સંધે ઓલા કોણ આવે છે બીપી તમે છો બોમ્બે થી આવેલા એને જ બોલાવવાનું અહીંયા થઈ જાય એને અહીંયા બોલાવી લ્યો મને સારા સાથ આપો તો હું પેન્ટિંગ ડ્રેમિંગ પછી ગ્લો બદલીશ અને સિમેન્ટિંગ વખતે ગ્લો બદલીશ તમે સ્ટેલિયમ થી હાથ ધોઈ લો કલ્પેશભાઈ પ્લાસ્ટિક શીટ કે ક્લિંગ ડ્રેપ કે કઈ રાખો છો એ વધારે સારું પડશે ઓકે પહેરાવી દઈએ. અચ્છા તમે કમ્પ્લીટ કવર કરો છો
Hello everyone.
ઓકે
Now we will continue with the next topic, ease or at ease. I would like to invite Dr. Karthik Shukla sir for the topic and Dr.
તમે ઉપર પકડી લો.
Satish Patel sir as a moderator. Thank you.
ધીરુભાઈ લેગ હોલ્ડરની પરિસ્થિતિ શું છે? લેગ હોલ્ડર ડોક્ટર કોઈ ઉભો થઈ જવાબ નહીં આપતો એટલે બહુ
શું કરે છે થાય શું
So
અનકમ્ફર્ટેબલ બહુ છે ને
waiting 2-3 minutes till some of our friends will join us. I would like to ask one question.
Situation
I
આપી
would
દે
like
તો.
to answer this question. What exactly we mean
હે ને
by
મને
joint
કીધું
line
પણ
integration
લાગશે
in
ઓટો ક્લિપ છે ને
What
આવી
is
જાય તો
joint
કરી લઈએ
line?
હાલો તમે ના કરી લો તમે કીધું લગા
Anyone
તમે
would
ના
like to
કરો
answer this question?
બસ અહીંથી પછી કટ
What
કરી
is
નાખશો ને
joint
વચ્ચે.
line?
હાલો go. હા આ કટ કરીને તમે ઓલું ઓલું મારશો ને આવ્યો બેન
How you decide joint
Good
line?
enough. અત્યારે કેટલા વાગ્યા 12:10 છે ચાલો
How you decide your joint line in a knee replacement surgery when you are operating a total knee? So that is different. That is epicondylar axis we are talking about. Flexion extension axis is an epicondylar axis on which the flexion extension occurs. All the time we are taught since when we are young surgeons, the joint line, maintain joint line, maintain joint line. But what is joint line? So that is the line connecting the distal most femur and medial and lateral condyle, and that is what we consider as a joint line. But how we know on table, it's difficult situation. So if we really honestly, if we ask ourselves, see, I have been doing joint replacement since 2003 and my private practice since 2006. So there are so many questions in our mind, and we usually are aware of this, but we don't have an answer. So this is a very honest confession we should do to ourselves. If we are in 2022, we say we don't know alignment in joint replacement. Which alignment you follow? Anyone specific? What is your alignment protocol for a total knee? Why mechanical alignment? See, I'm not biasing anyone. See, we all are facing same problem, not only you, me as well. Which patient we should do which alignment and why we don't know. So now if we see the literature worldwide, there are so many alignment systems evolving like chondroprotective medicines, like Dicer and glucosamine and this and that and bupivacaine and this. So mechanical was the gold standard. It is the gold standard, but still we know there are problems sometimes we face with the mechanical alignment. Kinematic alignment by Stephen Howell has evolved. It has its own limitation. So he believes anyway, any degree of tibia varus is fine. You can put tibia vara in any like 7 degrees or 8 degrees of varus is fine. You just fill the gap, the amount of bone you remove, that is kinematic alignment. And then it is not designed because our implants is designed as for the mechanical alignment system. You cannot change the implant for that. Then came the restricted kinematic alignment. And then came the inverse kinematic alignment, then constitutional, functional, anatomical. So we all are baffled actually how and precisely we can do our patients. And the second most important thing we have understood and studied literature that after infection, the second most problem we face as a surgeon is instability. So if we honestly admit this thing, so this is just a teaser lecture. So I am not using this system since long, but I explored this very recently. I am using gap balance since 1 decade, but that is a different story. So I'll just make you aware that this is how our thought process can help us, and you can explore different systems, and you decide as a surgeon, individual surgeon, that what you feel better, you feel comfortable with. And like in HIT, we say we should know all the approaches. You master one, but at least you know the 2 approaches and 2 approaches. So you can have this lecture just to ignite your minds. So let's go to this lecture. So this is just thing like T's or FTs. There are 2 ways. It is applicable to the surgeon as well as what you are doing to the knee. So you are T's on table, you are not happy, you are not getting what you want to do on table, and your knee is equally not happy, and you are T's because you are not comfortable in the way the surgery is proceeding or the steps are proceeding. So first of all, if we need trust, we need truth. And that is your individual quest as a surgeon. No one can just decide to have a trust unless you know the truth about that particular situation. This is applicable to life as a whole as well. My journey of gap balancing is very long. So I can say myself proudly that I am a gap balancing surgeon, but in partial knees. So I'm just, this is not a topic of partial knee, but I just want to highlight one important thing. This is flexion gap created on table in a meniscal bearing knee. So there is no constraint. We are just putting plastic in between 2 bones. The whole idea why I'm trying to show you is how simple physics is applied. No technology, nothing difficult. 2 millimeter was loose, 4 millimeter is tight, and then I'm putting 3. This is the value of 0.3 millimeter in a plastic. Just we are putting between the implant, between the bones, without any constraint. So what we are relying on this? This is the question I ask myself. We are completely relying on ligaments. Absolutely relying on ligaments. Same thing we do in extension. The 2 is loose, 4 you cannot put inside, and the 3 millimeter will go inside. And this is, you are absolutely happy just because you trust your ligaments more than your bones. So this is just to ignite the first thing. You can rely on your ligaments, and here the ligaments are normal. We can always argue this is a normal ligament because it's a unique patient. In TPR, we have a pathological ligaments, pathological capsule, but with minimal release or mandatory release, you can get away and you can completely rely on ligaments if you know the procedure. So this is the video. You can see just putting a poly inside. Nothing is locking that poly. It is a meniscal bearing design, and the poly is just put in, and it is will be there with the force of ligament and the kinematic. So what I've understood after doing good number of mobile bearing is that balancing in mobile bearing, why we are talking, this is a mobile bearing system, is independent of leg alignment. We don't bother to see the alignment, or we are not planning the alignment as a surgeon in this system, but our system is integrated with the metal anatomy, and most important thing is mechanical forces on the implant. So either you are 90 or 3, fine. You don't need 6 or 7. You don't have to bother all the things in the system. So let us understand this. This is the trial, and you can just get a feel. That's it. So we trust this. On which base? On ligaments, nothing else. So let us start. There are 2 ways you start your surgery as a surgeon. You have bony landmarks, which are not always consistent. As we had already talked, everyone has at their own right side line, transepicondylar axis, posterior condylar axis. So either you consider this as a first way that it's okay, I will follow these landmarks, which are not consistent, or you have just to remove the osteophytes. So that will be the consistent. Anyone, I think anyone will agree, no one will disagree that it is easy for or more reproducible between all the people sitting here to remove just the osteophytes. That's it. Now things done. The second important thing, in prime measure dissection technique, what we are doing, or in the way we are looking, we don't touch soft tissue because we are completely told repeatedly, please don't touch soft tissue. Please don't touch soft tissue. Minimal soft tissue dissection, agree. But you have to touch certain soft tissue. You have to remove deep MCL. You have to remove the PCL in this particular system, and this is the minimum soft tissue you have removed at this stage. The advantage of this is here you have not addressed or evaluated the soft tissue. You will do it later. So you just completely rely and in a blind faith that I will do everything later on. Here you evaluate your soft tissue because we are going to check the tissue tension at this stage. So what will be the problem? You will cut femur as per your femoral anatomical landmark. Tibia you will cut 0, 3 degree varus, 7 degree slope, independent. The femur is cut as per the femoral anatomy. Tibia is cut as per the tibial anatomy. And here you are cutting everything as per the soft tissue. So your bone cuts are integrated bone cuts. And that will end up in your problem is alignment is explored in extension only. So you extend your knee and you see your alignment. And that's why there is a confusion. We have a lot of confusion that mechanical, kinematic, restricted kinematic, inverse kinematic, or functional alignment. We don't know what we should do and how to achieve this in which patient. Here it would be easy because it is always balancing is obtained in flexion. So we have balance of flexion gap. And lately now we realize that what we have done independent, our common linkage is our soft tissue. So MCL and LCL, now we suddenly realize, oh, we have to do this bone cut as per our soft tissue linkage. And then you end up in like some tightness, some looseness, or already you are femoral lifted and you want thicker poly. This is scary, actually. This is very scary. So I think removing soft tissue is more inconsistent, and then each surgeon will come with their my way of doing joint replacement. That I will do pie casting, I will do posterior release, I will do this, I will do that, which is very difficult for a young surgeon to understand why and when we have to do this soft tissue releases and how we can stop, where to stop. So I think here nothing comes in picture because your extension cap is also going to be balanced by the ligament. So what you will have is well-balanced extension gap. And this is less functional balancing. We are talking about alignment all the time. What about functional alignment? We all want to do in every case, but how to do a well-functional balancing? No one talks about it. There is no terminology to functional balancing. A pathological ligament, what we are left with, how to utilize those ligaments to make patients so comfortable in doing those activities. So this is Functional balancing, we started and we are ending up automatically in a functional alignment. So here we are not going to measure degrees. You have seen no measurements. So it will seem very interesting for a surgeon that we are not measuring anything like 9, 3, rotation, proximal, distal, anterior, posterior, no, nothing. You don't need to much. Only thing is to remove osteophyte, check your ligaments, minimal soft tissue relief, and your precise tibial cut. Tibia is very important in this system. Now what happens if we follow? This is what routinely we see. And these are the charts. Young surgeon, I had applied this big chart in my OT when I started my private practice. Loose in flexion, tight in extension, tight in flexion, loose in extension. And I perspired when I had this situation. It's a big chart all the time in OT, and just like a Gita or Quran or Bible, every time we see this, upsize your femur, downsize your femur, proximalize your femur, distalize your, it is too difficult, I think. Everyone will agree with me that over a period of time, 3 years or 4 years, you will realize, no, it's in the middle of the night, if I send Dr. Satish Patel, you will instantly realize that's a problem. But it is a journey that is very painful, very difficult. And sometimes the surgeon loses their confidence that I am not good at joint replacement. So believe me, joint replacement is the easiest procedure on the earth unless surgeon complicates it. This is a very simple slogan. It applies for hip, it applies for uni, it applies for knee also. It's a very easy procedure. Follow the basic rules. Don't violate the rules. Even your driver can drive on a highway. So it is just like it is easy. You have to understand what you want. So this is not the end. You think this is scary? Good. This is more scary. Every gap has medial lateral and global laxities. Now imagine if you are sent as a surgeon, find out the problem on this knee. See how much experience you need to understand what is tight inflection, loose inflection, medial, lateral, central, or both the medial lateral. Not easy. Not easy for anyone to go through this. But if you can remove this all stuff, only one is correct. That is good inflection, good in extension. This is what we all strive for in every single case. So what I've understood as a cluster of words we are taught or we catch from the literature, that one is measure resection technique, where you have more focus on coronal plane only, you have more focus on femur only, you have a joint line all the time maintaining joint line. We don't know what is joint line on table. Mechanical alignment is a gold standard. Posterior condylar offset is again when you are doing a CR surgeon, you are preserving CR, the TCO becomes very important, and the fixed bearing is more easily accepted with a measure resection technique. While when you do a balance resection technique, gap balancing is nothing but a balance resection. Either you measure something before you cut, or you balance something before you cut. Very simple to understand. So sagittal plane is very important. Start with a tibial slope. Your tibia is more important than your femur. Functional plane. I prefer the word functional plane, not a joint line. It is a plane on which the implant moves, not the line. And the functional alignment and the distal proclia, that is very important. How much femur you are cutting, the only consistent landmark is a distal femur trochlear cartilage. So you would have heard number 8. So if you are getting both the condyles together, you are cutting more. Both the condyles separate, you are distalizing the joint line, and flush with the trochlear cartilage means you are already in the joint line. You don't have to bother for that. And you need a rotating platform design for sure, or mobile journey. So if you don't restore the soft tissue balance, if you end up in a soft tissue imbalance, these are the problems everybody knows, no need to mention it. Then you have a problem of under-release or over-release. Under-release, stiffness, loss of motion, over-release, instability. Easy just to remember. And this all adds complication with the patellofemoral joint and ultimately arthritis. And we proudly say in all conferences that total replacement success is 80 to 85%. So we have to think, I think, where we are going wrong. So I think the functional balancing is very important word to understand. Easy way, very precise and easy way to achieve your functional balancing. Now, if you talk about alignment, this is again very interesting. You all will agree upon me. Coronal alignment, we are trying to understand. Okay. mechanical restricted. We are reading literature, we are exploring, and we try to understand. The moment we bend the knee 90 degree, alignment is gone from our mind. And this is I'm thankful to Dr. Ravi who is working with me. He asked me this question. So what when we measure 90 degree, what will be the alignment? Why the robotic system even is showing alignment in 90 degree of flexion? So what reference point we are taking in when we say 7 degree of alignment or 6 degree of VARF in 90 degree of flexion? What does that mean? And no one knows. Even the company doesn't know what does that mean. So the moment we bend the knee 90 degree, we come with our shift of mind to balancing part, because our patient will come to you and say, sir, when I want to try to get up from the sofa, I feel difficult. When I'm trying from the car to come out, I feel difficult. This is instability in flexion or mid-flexion instability. And we try to remember everything about the sagittal plane. The sagittal alignment is either you can achieve through metal or you can achieve through bearing. So bearing is the easiest way to achieve this. This is already discussed. Most of the time, the companies provide very long rod for the femur. So if you put a long rod, you are putting the femoral component in very different position in rather what you have planned. So in short, you can say Indian population have very much significant sagittal bone. Intramedullary rod is very important. The tip and trick is long rod is good for coronal plane. It is used like intramedullary nail, but not good for sagittal plane. We have already discussed this. I will just give this. The functional plane in functional balancing is what we are exploring in this. So the take-home message would be something related with this. The surgeon has two horses. So if you choose alignment, the patient will be happy and the family will be happy. So it's a very straight leg. It was very crooked and now it looks very straight. But if you balance the knee very precisely, your physiotherapist will be very happy. So this patient is doing tremendously good. So at this point, you use all your four forces: alignment, balancing, correct kinematics you achieve, and fourth is optimum stability. You can't blame horses here. It's your way how you use your horses on table. This is already discussed, and we all know no one is able to do this. Again, just like right side line or the transepicondylar axis or surgical transepicondylar axis, this is a problem, burning problem, tibial rotation. And you have already seen, we don't bother much here, but this is a problem. And most important, but most arbitrary. So you must be as a surgeon thinking how I would do a tibial rotation. But the same, no one knows what's tibial rotation. So either you can trust the technology or you can learn the right technique. But our mindset is always towards technology. So Robert can't do this. Robert fails in this tibial rotation by robotic system. But the answer is a mobile bearing because it can rotate. It is more forgiving. The only thing is mobile bearing means gap balancing. This is me, and that's why I have a firecracker. Many will not agree with me on this. That I believe when you put mobile bearing, it has to be under a soft tissue balance. And the right technique is helpful, not even robot is helpful. To take a message, which one is more important is a question to my mind. What my healthy mind knows when I get scrubbed or what a disease knee joint needs on table that I have to make them understand. Lines are connecting 2 points, but planes incorporate many lines. This is very important to understand. Hence, alignment of lines means balancing a plane by default. If you align many lines, it becomes plane, and if you align planes, you are going to have a balance. The resection of ACL and PCL in total knee left us with only collaterals and coronal plane. We have removed ACL, PCL. Now our whole region is in coronal plane. Our eyes and minds are going for the coronal plane all the time because we are standing in front of the knee. This brought us focus more on coronal plane and coronal alignment. Sagittal plane stability can only be reproduced through either polyliners, fine mechanism, or curved poly, or congruent, medial congruent, lateral constraint, lateral pivot, medial pivot, so what? Whatever is the possibility. But most important thing, in any other system, you are just recreating the PCL through spine mechanism. No one is talking about ACL. The ACL is gone, it's gone. That's it, leave it with this. So anterior curved liner in this system is recreating the posterior lip through posterior lip, and ACL is created with posterior line, means vice versa. So cervical stability is restored. And measurement of bone cannot incorporate topic. We all agree upon this, but tissue balancing can incorporate measurement if we cannot think beyond our old teachings. That is joint line, postoperational offset, femodal rotation. It can be done if we still want the numbers to be printed on our mind. Otherwise, it is not needed. And last but not least, when leg is straight, we value alignment. But when the leg is bent, we start realizing the value of balancing. So the truth of message is, let us be humble and learn together the art of balancing. Thank you.
Nice.
Any questions or we will take later on? No problem.
Thank you, Karthik Shukla, sir. Now we will continue with the third case, live surgery 3, valgus knee with the severe lax deformity, correction using BP hinge knee. Will be done by Dr. Neeraj Shah. And I would like to invite Dr. Karthik Shukla, sir, and Satish Patel, sir, as a moderator. Thank you. Neeraj, sir, can you hear us?
Yes, we can hear you. Can you hear me?
Yes, sir.
Yes, we can.
Am I clear? Tunic on, please.
Yes, can someone
Yeah,
just
just
put
let's
up the
put in
X-ray
the.
first?
Can you focus on the X-ray? Can you show the X-ray from there? We are trying to show you the X-ray. X-ray नजीक ले लिया.
On camera.
टूर्निकेट चलाओ. जो तो टूर्निकेट चलाओ.
What is the age of the patient?
He's 48. 48, na? He's 48 with a inflammatory arthritic joint leading to severe subluxation, severe deformity of the tibia. Looks like a Gobi Desert double-hemmed camel, and subluxation of the joint. Now I'm going to do this with the subvastus approach, so I'm going to demonstrate that also. So can we come back to the joint, please? Yeah, X-ray is done. Yeah, I'll demonstrate the instability. So as you can see the instability in the anterior posterior direction, severe, and go to the upper camera, please. And you can see, can you zoom out, please? Upper camera. You see, and very severe varus. Almost there is pressure on the lateral side. It's completely fine. So I'm going to surgery now. We are going to put an incision and we're doing the subvastus approach.
Rheumatoid arthritis, maybe?
Rheumatoid, yeah, possibly, because it's an inflammatory. They are not sure about rheumatoid. They are not sure about Charcot's like, because all sensations are normal. Now in subvastus approach, we cut the fascia, extend the knee. Can you please extend the knee? Now what I do is I hold it with the skin and the subcu, I hold with my hand, and fascia over the vastus medialis muscle. I want to make the vastus medialis muscle bare. There should be no fascia on it. See, now my muscle is bare. I can put my finger beyond that, and I want to put my finger on the fascia and go between the fascia and the muscle. There I am going. Detector, please. I want a right angle retractor with a long handle. Please, thank you. Yeah, please give one to him. This job will have to lift the vastus medialis. Now I'm going behind the vastus. I have to just increase my incision in this case, just for good demonstration. So I am going between the
Fine. Everyone able to see? Now I'm going back behind, and there is a bare area between the vastus medialis and the femur. This is where I take the muscle in my finger like this. I want this assistant of mine to hold it vertically upward with a full traction on. I'm traction can pakdi rakho. Yes. Now I'm going to use nothing but my thumb. Very gently, I'm going to just remove this fascia and wipe the vastus medialis right from the femur, from the medial ridge of the femur. See, now this is completely over. And that's good. So completely detach the vastus medialis from the femur right till my thumb can go. To dissect this at all, maybe some if it's coming in my way. Right? Now I'm going to go to the junction of the vastus medialis, and this is the midpoint of the patella which I am marking. So can you retractor Muko, please? Now the retractor has to come here. That junction between the vastus medialis and the retinaculum, and here this is how I expose my joint. There has to be a lot of synovium here. This is what is going to come in between, and I will remove that with. Can you increase the cautery, please? The cutting part, yellow, please. So now I am in the joint. I am holding the patella. I am still not able to cut this, so I am trying to use my cautery to give me some leeway here, because this is not a routine. This is not a primary knee. Otherwise, we would have been. I have to be careful that I don't cut the patellar tendon. Yeah, this is it. So I am able to put my thumb right into, and this is vastus medialis held there. And I'm going to palpate my tibial tuberosity, go vertically down, patellar tendon I'm not touching, go right up to the medial part of the tuberosity. So we have an L shape here. Is an L shape to mark. Please. Now, get out the medial part, the medial retinaculum and the medial capsule and the medial tissues over the tibia. There are a lot of osteophytes, so I would take some time here.
When the intensity of the light is cut down, not see anything.
Spike Lily, please. Spike, please. So one spike goes medially. You hold it, please. आप ये पकड़ लीजिए. Thank you. Now I'm going to Action, please. Left hand for this, right hand for patella. Just invert it. And I don't usually do the and that's why I'm taking his help. Fine, and I'm going to remove this thick. Do in primary. I'm going to can you give me a I have to see the plane between the synovium and the capsule. I don't want to cut that. You have to bear with me because I need to do this. It may take some time, but this is what is more important here. We have to remove the synovium, otherwise we're going to land into trouble. You can see now. See? Now I'm clear. Again, I'm going to remove. Actually, Ram, just hold it.
On the wheel side of him.
Here, but I'm just going to burn it out. I'm not going to cut the tissue because I need. Let me now do what I need to do in a. So the next step is need to bend the knee. But before that, I have to be very clear that I don't damage fibrosity. Here. Yeah. Don't need to gutter here. As you can see now, we have a very beautiful view of the knee. This is subvastus. You can do it in revision. You can do in obese patients. You can do in lower end femoral replacement. You can even replace the lower end femur with the same approach. I have not everted the patella. I can even do that, but I don't need to do it now. And I'm going to now put in a spike. Spike, please. And you have to be very careful not to pull it because we don't want to damage the it from the tibial tuberous. That's good. Now what I do is,
What is the
the
condition?
tibia, but I need to expose it slightly more.
Wait.
And please let me know what your questions are.
Wait. What is the condition of the collateral ligaments?
Of not good. There is lateral opening, lateral side. But we don't want. I need some time to decide. See, once I extend it, now you can see. Can you show from the? So that please don't. Yeah. Now see this. See, it's opening, totally opening.
But is that due to the collateral ligament laxity or the bony lapse?
Bony also and collateral, the lateral is opening totally, see. But again, once I do my cuts, then only I am going to decide. At present, it seems I am in no hurry at all. Just hold it now. Just careful. Okay, now my tibial cutting guide, but first I'm going to go hyperflexion. Yeah. Now, I'm okay, this is okay. I am in hyperflexion. Now I post some time. This is not a routine case. I need to remove the PCL now before I do anything else. The PCL is beautiful, but non-functional. Condyle, tibial condyle. The lateral femoral condyle is dipping into the tibial condyle. So I'll have to subluxate that into position. Okay. There is some place that I need to. There is almost. Give me an osteotome, please. Because now this condyle is dipping here. There is no space here. This femur on here. The central, give me a small osteotome. Curved. This is there. No. I'll try to see if I'm able to put it. I'm very difficult. It is not. I'm not able to subluxate it because it is not coming out. There is a locking of the femoral condyle in the tibia. હવે મને છે ને ફીમર લિફ્ટ કરો તો નહીં he'll do it. No, only he'll do it. તમે અહીંથી છે ને આમ જો આમ લિફ્ટ કરો ફીમર બે હાથે. We are trying to lift. There is no bone. Okay. Rakha. Implement failure.
You're trying to dislocate the knee?
No, we broke the handle of the osteotome. That happens. I'm trying to be very slow and steady because this is a very joint. The bones are okay. You can just hold it there. Give me the central. This is it. The cliff पर से. दूसरा दे दो ना, ये नहीं दो. Yeah, give me no. है मैंने देखा है when he was removing I saw it. This one. Let me try this. And Alpesh Bhai will hold. Let me see if I can subluxate it. Very difficult. Very difficult. Very gentle. Okay, now able to the lateral man, which surprisingly is intact. And I'm. Can you hold this for me? Going to remove the inferior pole, the patella, so that it.
Those are the osteophytes in the patella?
Excuse me?
Those are the osteophytes in the patella?
Yeah, there is an inferior osteophyte in the which I'm now. Whatever is coming in later on, the final patellar later on, we may not replace the patella, that I don't plan to do. But first, let me remove the meniscus. Sorry. These are the remnants of the PCL that I am removing. And trying to come to the edge of the bone. I need to have an idea where I am. Okay, now. Can I get another osteotome? I need here, which is going to the tibia. Hammer, please. Yeah. There I am. Yeah, I action. Hold this with your left hand. Forget that. Forget that. And just hold this here like this in external rotation. Yes. Need to do it again. Give me this, please. Okay, very careful of the femoral condyle. We don't want to fracture that. Oh my God, it's a horrible knee. Yeah, I'm almost now, but I think I'll do my cut first. There's only way out. I have to go till the depth here and do the cut. Do we have tibial wedges here? I was told that we have tibial wedges. Okay, give me the tibial cutting right now, please. Let me do the cut first. Let us see what we can do. Whether able to cut the tibia, it's also a big issue now. No, just hold it like that. Not much. Give me a nibbler, please. Hold this. Huge. If you want to go flat, we will need a very highly raised tibia. We'll need a tibial wedges if you are able to do this then. I'm trying if I can get here, and if I can go here, maybe I just cut this vertical and have a support and then do it. A lateral support and lateral cut. This I want 5 degrees. This is a listen. No, go here. Yes, okay. I'm trying to decrease that slope. And I'm trying to come up because I may go directly into the wedge here or make a drill hole here. Pin, please. Lateral pin first. Yeah. Go. Go. No, you can use the hammer. What soft? Use the hammer, no? Easy and soft. Bone is very soft. Don't bother. Please remember, this is not a routine primary case. I may take some time. I'll rectify it again and again. Go.
How much bone are you aiming to resect from the less affected side?
Yeah, there's no less affected side. There is, everything is affected. There is no less affected side here. So I may forget this. If I can get some support, remove all this here. If I get it stable wood, I can use it. I think this is than this. And this is absolutely what I want. Okay, give me the saw, please. In Hindi, Bhagwan ka naam leke, okay? Good. It's okay. Give me, please. I'm not bothered about the ligaments. We are going to go do a hinge. Still, if I can save some, just good enough. So I'm trying to expose that lateral tibial condyle as much as possible. I want to come right till the edge so that I can get, and if I overhang that, I don't mind if I'm able to in the center of the tibia. So this is the edge of the lateral tibial condyle. I'm going to mark it here, and I get some support here. I'm going to take it, and I'm going to forget that medial thing. Let's see what I can do. Okay. Fine. I think let's see what we can do. I'm going to hold this tight. We have pins. Okay, we can remove this. I'm going to see whether I can finish. Otherwise, I'll come back and we can do the tibia recut again. But I think I am quite happy with what I have. That's okay. Can you remove this? Fine. Now, I'm going to forget the, remove this please. I'm going to forget the tibia. I have got the base here to put my spacer. Now I'm going to go for femur. Let me remove the osteophytes first and what I can do. I don't want. You start Still you start realizing where I am. See, this is a very confusing case otherwise, but I didn't forget my basics and I just kept on doing. Next step is I'm going to do it because I don't want to forget my routine. One step I forget, I'll get confused. We just become mechanical, let muscle memory help you. Just keep on doing. Now, the next step.
Can you speak a bit slower? We cannot understand anything you're saying.
Sorry. So what I said is that whenever you are doing a complicated case or a revision type thing, don't forget your steps. Do your routine steps as you do. Give me the femur trial. So keep doing what you do regularly, routinely. I may not need to remove the osteophytes here, but I still do it because that's my routine. I'm going to go step by step. 4 number. I think 4 is the right number. We are going for 4 number. I think the femur is 4. Let's 4. 5 dikhayenge? 5. So there is osteophyte here. Let me see 5. Whether I'm making just once 5. Hai nahi? So bas 4 is good enough. So we have to 4. I am quite sure because we extend it up into the femur and go along. I hold the femur like this. Go, show me the that. So I'm holding at in the center. I go in the center. Just is an to see the junction between the patella notch here. Going okay, lie please. Now I'm putting the, as I said, go on the side, please. This is part of the femur. I'm holding this as pressurized downward possible and point as possible of the femur. Okay, can you put in a pin, please? No, medial. Yep. Just so that I can, this doesn't slip. That's good enough. Now I'm going to make a, just make a hole here with a drill. The intramedullary. Okay. Can you listen to me now?
Yes, better now.
Oh, better now. So I'll speak slowly and gently. Yeah, and now I'm putting and I'm drilling the intramedullary canal. See, I'm in the canal. See, because of the extra medullary support that I have, I am in the canal. Can you give me the rod, please? So I'm going to put in the rod, the intramedullary rod. And give me the hammer, please. To go in slowly. This I'm going to remove. And again, remove the pin, please. Can you remove this? I'm going to remove the pin. I'm not going to, I keep it slightly loose so that I can, rotate it as necessary. Can you give me the spacer, please? 4 number. So this is 3/4 spacer.
This is just one way to avoid anterior notching. Usually, in most cases, we do it eyeballing it. So this is just making sure we don't get anterior notching.
Lifting the femur, can you rotate this tibia? And you pull the tibia downwards, please. Pull the tibia downwards. Yep, there we are. So I am hyperflexing. Some support here, so I'm going to use. I have got here. I have put in my 0. The 0. I think we will need a plus 2.5 here because there is some medial lateral opening, but I am not going to touch it now. I'll keep it in my mind, and when I'll do a trial, I'll do that. At present, I don't need to cut the tibia more. I can cut it less, obviously. It is quite stable. So I'm going to accept it, and I'm going to accept this tibia, and that is how I'm going to cut the anterior posterior femur first. Now, if I cut the anterior and posterior femur, this condyle will no longer come and hurt me here. So now I'm safe, and I'm going to do it. First, I'm going to cut the anterior and posterior. First, I need to put in the pins, please. Hammer. Saw yellow, please. And give me the finger. Give me another pin, please. तो ये मुकाई दियो, outer मुकाई दियो. We are changing the mic. I need some time, okay?
Remember, since you're decided to do a hinge joint, does the little mediolateral instability make any difference ultimately?
See, I don't know, it's not needed, but I need to know the thickness of the poly basically. They have a fixed 2.5 mm poly only in the hinge. So this aim is to see tomorrow 0 poly, if I am able to do that, or do I need a thicker poly? Can the 2.5? Do I need to have if it's a big gap, then do I need to put in wedges to lift the tibia up or not? Do I need to cut the tibia more or not? That is the entire aim of what I am doing. I am not interested in stability, but as I said, I will do each and every step of a primary knee in this so that I don't miss anything. Okay. That's what I am doing. Yes. And let people also see what we are doing in primary knee. It's a revision for them also. So I am not going to touch this. I am going to keep it in position. Please put a retractor here. Please. Angel wing. Thank you. Yeah, I am going to see whether I am notching this or not. I am not notching. It's very nice. I am not notching. Okay. So give me the saw, please. Can you hold this in position? Left hand, right hand. Good. Thank you. I am going to cut the. So I have a support now. Can you give me the cautery, please? Yes. Yep. Can you remove this from here? Okay, now I'm going to remove the spacer because I need to cut the condyles, but I am going to put spikes. Give me spikes, please. So that again, I am not going to change. I just want spikes so that I don't cut anything else. If the MCL is weak, let it be. It's still there, no? Give me some support. Give me one more spike, please. Where is the other spike? Yeah, please. It's okay. Okay, Kalpesh bhai, hold it here like this. Okay, fine. No, so now I am going to cut the posterior femoral condyle. Okay, and so this condyle is now not going to hurt me by locking into the tibia. Basically, I have done what I want. I'll use the osteotome. If I am not sure of the cut, I'll use the osteotome. But I'm going to remove. No, abhi pehle nikal do usko. We'll remove the jig. Yep. Yeah. I'm going to use a slap hammer to remove this. Nikal dijiye. So we are removing the anterior posterior cutting guides. And we're going to use a small osteotome. Please lift the femur. Haath pag uparo, Kalpesh bhai. Ahithi haath thi pag uparo. Remove this, please. So I'm going to use my osteotome to hammer, please. See, this portion may not be cut. I still use my hammer to do it, but I'm not going to use my saw. So one, I have removed this. Give me a nibbler, please. There it is.
So that's your anterior and posterior cut of the femur.
Yes, so ultimately I have done the anterior posterior cuts. I'm going to use a black spacer just again to see whether I'm okay with it or not, whether I need to do something. It gives me an idea of what I'm doing, where I am going. Do I need to do something? Keep on doing slowly, steadily, follow your primary steps. Then everything starts becoming clear and you start understanding where you are. You are opening the anatomy for the first time in your own life for this case. It's a very bad case. So I need to keep on understanding what I am doing, whether I'm in the right place or not, whether I need to cut something else or not, whether what I'm removing is enough or not enough. Okay, give me a black spacer, please. So I'm using the black spacer to hold it, superior रहेगा ना, inferior रहेगा, ये बराबर है, hinge के लिए बराबर है, hinge के लिए he is adding 2.5 mm. Now you see, my spacer is perfectly in position. The medial side I am not bothering. I have got enough support on the lateral side, and as you can see, that zero was slightly moving. This is not moving at all. See, it's very stable. So I think plus 2.5 poly hoga, I will be quite safe. If not, I can still go for it. Now I am going to do the distal cutting, and then I'll measure the distal, the extension gap. Give me this distal cutting guide, and I want 4 degrees. I keep 4. If there is medial and lateral tightening, I can shift to. चलो पिन प्लीज, हैमर ले लो कल्पेश भाई, करते जाओ हैमर, या हम 3 डालना है, we'll put 3 pins, okay, because the bone is very soft. या go on, तुम करो शेमस करो, routine. Give me one more pin please, because the bone is very soft. I add the pin. If I need, then I will remove it to, if I want to shift, but I put 3 because it moves. Yep. Now I'm going to remove this and the guide. I'm going to very gently extend the knee. And as I can see, I am going into the tibial cut is not enough. I may need to, but I'm not going to do anything extra now. This is remaining in FFD, but I'll come. Give me some time, we'll be able to do it. Give me the spacer, please. You nikal ke do. Just, I'll do it. I'm going to put this here, lift this here, extend the knee, pakad ke rakho idhar. Give me the hammer, please. No, thoda bend kare. It's okay. We need to do it twice or thrice. It's not a good knee. Okay, dhire dhire extension. Dhire dhire extension. Valgus kariye thoda. That's good. See, now it's coming in. See now. Okay, cholo. See, now I am in full extension. Can you see this? I am in full extension. It is well balanced. Maybe 5 degrees FFD. I am not going to mind it because I don't want hyperextension in a hinge knee. So this is complete extension and very stable. In 0, we have plus 2.5. We'll be okay by then also. But I am happy with this. I don't mind doing this distal cut now. And if I need, I may go again. But this is quite okay. This is comfortable for me. So I'm going to continue with this. And I'm going to do the distal cut like this only. Okay, spikes, please. आगे डाल दीजिए. Yep. एक spike ले लीजिए. Yep. बस hold this आप बीजू के पटेल उड़ाड़ी ना दी. It chance. Give me the cutting guide, please. No, I don't need this now. Just give me the cutting guide and the saw. Can you hold this here? अनमुख की जानी जरूर है. ये कर लेंगे. आपका हाथ आ जाएगा. बासी. Good. Now give me the saw, please. So I'm cutting the distal femur. Very soft bone, like going through butter. Please. Please. Let me remove the, give me an osteotome, please. मैंने cautery आपको. Need to cut this soft tissue. Yeah, that's okay. You'll remove this. No, I'll use the osteotome, please. The bone is so soft. I am afraid I may damage the bone. I may cut this. So again, I'm going very slow. Okay, now I'm going to keep everything in position. No. Give me the black spacer, please. Let me try the black spacer. Let's see what's going on. Let's not hurry. Yep, there is the black spacer. Lift it up and see complete extension and well balanced. See this. See, I've got complete extension and it is very well balanced. Medial lateral no opening. I am forgetting the medial side. I'm not going to look there. Fine. Okay, we are done. And now I want the final cutting guide for the femur.
Can you get away with doing a primary knee in this?
Yeah. Okay, so we are doing this for the chamfer and everything. I use my hand, his bone is very soft, and I'm going to, no, just, okay, I think in the right position. Give me the punch, please. Yeah. Okay. Fine. 90 degrees. Now I am flush and I need to go more in. I am being very gentle. I am being very gentle because it's a very soft bone and I need to go lateral. I think I am okay now. And this is in the center, see? So I want be in this in the center so that we can put in the rod. Okay, I think I am okay. Are you barabar hai? Is that okay? Okay, so now I'm going to hold it there. Put the pin, please. Put the pin, please. Oh my God, it's such a soft bone. Okay, give me the, there's no need of holes in this, yeah? No need of holes. So I'm going to put the patellar groove. Chamfer. Posterior chamfer. Okay, give me the punch and hammer, please. See, we put this so that the bone is very soft. I think it is gone. We will see it. Ajit, I am going to cut this and everything. I know you are right. This has shifted up, but the bone is so soft. Everything is shifted by I was hammering. This is lifted up, I know, but there is no way I'm going to. I don't keep on hammering. We'll do it. Can you hold it back? Because now we have put the pin in, we can't change it. This has gone into extension. That is the reason. Fine, that's okay. We'll do it. It's very soft. When the implant comes, it will come in position. Remove this. We want to do the ultra posterior cut. Okay, let it remain. Hold it here. I don't think I've got anything remaining. There is nothing here. Forget the ultra posterior cut. There is nothing here. There is no bone. I'm not going to do the ultra posterior cut in this because there is no bone here. Remove the pins. It moved while I was doing, but I'm not going to do anything because I need to just wait and watch. Let's see if I have some problem in the implant. I will do it again. Otherwise, the bone is so soft. See, it's just coming out like that. So I'm not. If there is some extra bone, it's good. No problem. I'm just going to try again. Okay. Okay. Now we do the tibia. If femur बाद में करेंगे. If femur finish कर देना का है. फिर तो करना ही है पक्का है. तो femur finish कर देते हैं. तो femur को निकालो सब रॉड बेस का. I'm going to use the. I am going to do the hinge 100%. So I'm now going to finish the femur with the rod and the notch and everything. Let's see what we can do. We're getting the trial now. There is a special cutting guide for that. तो कटिंग गेट लेके करेंगे ना. अब मुझे कटिंग गेट देंगे 4 नंबर का. हाँ तो बॉक्स करेंगे ना. मुझे दो ना. We will need to do the box. Give me the hammer, please. मुझे हैमर दे दो और let me see if I can go.
So this is the first different jig we are seeing. So far, only the primary CPR instruments are being used.
Okay, करेंगे. No, what is happening is this is blocking it. I need to lateralize it. Yeah, then again I can. Yeah, there I am. See, now it is better. See, now I have got a complete margin. Can you give me the punch, please? Okay, I think we are quite okay. Pin डाल दीजिए, please. We are putting this only because in the center that we may need to shift it medial lateral. तो अपन कर सकते हैं. If the intramedullary canal is not perfect, but we are okay. Yep. चलिए. छोटा 100 दीजिए. We are going to make a chamfer hole for the rod and the hinge. If free hand करेंगे आप तो आपके पास कुछ है वो पंच जैसा. Okay, फिर पंच से करें. The bone is very soft. Yeah. दोनों पंच. The bone is so soft. Bone is very soft. It removes a very big amount of bone, but hinge hai to okay. Now, okay, now punch de dijiye iska. So I made a U cut, reverse U cut. We need to remove it. Okay, okay. Give me an osteotome. I'll break it. Give me the straight. Yeah. Very slowly and gently. It's such a soft bone that I'm not taking a risk. I don't want to fracture the femur.
So this big chunk of bone is going to be coming out, isn't it? I don't know.
Yes. Okay, there we are. So I made a notch in the femur to hold it, to hold the hinge joint in it. अभी अंदर का रॉड का दीजिए सब माल सामान. How do you put the rod? You have to have a guide for me. Free hand करेंगे? इसको निकाल दें, तो निकालो फिर. Okay, I'm going to do this free hand now. Hole तो बना हुआ है, we already made the hole. Yeah, just remove this. Yeah. Yeah. Remove the pin. Anyway, we are doing free hands. It's okay. Now this is where I was. Here, wasn't it? This is where I was. There I was. See, there I can see the hole. So I'm going to remove this also. So now this is 9, 10. Okay, 10. I'll tell you one small thing. See, the femur curves posteriorly. From there, it has a slight posterior curve. So you have to raise your hand when you put in your drill. If you go like this, you will strike the anterior cortex. So you raise your hand and then you go in, you're going to slide in well. Please remember this always when you do the femur. Tibia is easy. Femur is, you have to be very careful. So I'll raise my hand slightly, easy. There's nothing, there is no bone here. There is only medullary cavity. Well,
What is this size ring?
how much long do you have stem? This is 75, na?
What is the thickness of this reamer?
Huh?
What is the thickness of the reamer you last used?
This was 12.
10.
I think we can go up to 14. That's what I have a feeling. 13. So 13, I'm going in again, and we are going right up to 125. We have enough. Good. So give me 14. I think 14 is good enough. I don't want to go beyond that. Let's see. 14 is good enough. I am going to accept it. 125 depth, 14 thickness. Yeah, 125 depth. Let's see. If I am done, if that holds. Yep, it's good hold. See, good. 125. Chalo. 14, 125. देखने के लिए we'll remove it again. So we have to do the tibia. We are just giving it a trial. Then we'll remove it again and then do the tibia. So again, let me see if I'm able to put in, and there I am. See, I am able to go in. That's good. So my femur is done. I'm holding it here. Gentle.
I'm quite okay. I'm not bothered about this extra, but I'm quite okay. I'm holding it well. So I'm going to accept this. My femur is in at 14 by 120. Please remember this. Okay, let's do the tibia. Cut nakho. Be very careful about the femur so that we don't break the condyle. Give me a retractor, please. Wait. Utawar nahi karta. Give me a spike, please. Yep. Okay, now I want, can we upsize or downsize the tibia, or it has to be 4 only? Tibia I can put 3 or no? 3 I can put and 5 I can put, fine, tibia, but you don't have 5 tibia. But if this is 4, this can be 3 or it has to be 4. Chalega na? So let me see, give me 3 first, because I have downsized the tibia here. Now give me the spike, please. You have to be very clear. See, Anna karta, because no. Give me a pack. And very gently, because the condyle can break. No, I don't think we need it also. We can do it without anything. Don't need. Give me 4, please. Let me see if I can do 4. And I'm not going to see, I have not even touched this. This is going to be my support system, see, anteriorly. 4 is good. Can you put in the pin and so we can do the needful? I'm able to hold it. So I'm putting an anterior pin because I have a support there. Yep. And I'm in the center. Let me mark this, please. Give me a marker, a copy, please. I'm going to mark my anterior because in this, we may give a wrong rotation. So I'm going to mark this here. This is mobile bearing, but still you need to mark a rotation. Put a lateral pin, please. No, here, lateral. And put the third pin when I tell you. Go in. Go fast. Don't worry. Go in. Go in. Good. Now go. This go in also. No. There is no bone there. Yep. It will tilt. Go down as much as you can. Go. Yep. That's good. Now, okay. Now you drill. I'm going to hold it. Now you need to drill. I'm going to hold it. Go very gently. Okay. Remove it. Do you have a drill? Simple drill which we use? Give me that first. That intramedullary drill that you have. So it's a very hard bone. We have not cut it. It's a very thickened sclerotic bone. So I'm going to use a drill to make a hole, and then I'm going to use the intramedullary things. I don't want to take a chance. You may shatter the tibia because of that. No. Just don't worry. Very gently, we are going to go for drill. We are in the center. We are not in any problem. We are really in the center. We are going to have no problem. I'm going to hold it. Come in, remain in the center. Okay, good enough. Put in 9. Jaiga. Good enough. We are at least safer there. Good, very good. See, a good assistant helps you. Very gentle. Very gentle. Don't push in. Okay, chalega. Be very careful. We may fracture it. Now let's do 9. First, let us do the larger, bigger drill. And I put in the 9 here. Give me the bigger drill. Okay, let's do that. See, now it is easier. Go slowly. Careful. No, you are shifting it. It's okay. Go, come out, please. Go very gently. धीरे-धीरे जाओ. एक काम करें, आप मुझे 10 नंबर करके दो ना. आप मुझे 10 नंबर इसमें करके दो. Let's go till how much we can, then we'll do this. Okay, we'll enlarge the hole superiorly by drilling inferiorly. We are shifting this, which I don't want. I don't want this to be shifted at all. So let's do 10. Now hold this. Now I will do. Now hold. Then he's going to hold it. Right? Let me now have a feel of what I am doing. It's tilting, yeah? Tilting. So how much is this? 75. We need 25 more. Okay, I'm okay. Okay, fine. It keeps on tilting it. Let's go very gently and slowly. Let's see what we can do. We are not, please keep on feeling the tibia. You are not fractured it. You have to be very careful. Okay, put in, how much is this? 11. We don't have 11 rods. We have to go to 12. 11 kare de. You hold it tight. Dabai rakh jata mein pa. 11, please.
If I tell you the rod name, then get the trial ready for the hinge, okay? So 1150 is also good enough for this, but if larger is better. Okay, it's okay. It's okay. How much is this? So 50 is good enough for us, okay, boss? We can't go beyond 50. The canal is turning and it's tilting my plate. So tibia 14 दे दो, अभी 12 दे दो. 12 by 50 होगा तो चलेगा. 12 दे दो. हाँ, 12 का दे दो मैं. ये कितना है? नहीं 12 हाँ पकड़े रखो तो बस पकड़े तो रखो तो बस नहीं तब हमने पकड़ो या 12 का I want the direction. Okay, so this is the 12 mm bill. I am going up to 50 mm because after that there is a shift. Okay, I am done. See, okay, 50 na? Bas ho gaya 50. 12 by 50. I think 12 by 50 is good enough. So femur was 14 by 125 and tibia is 12 by 50. Okay, now let's do the remus, please. Now, because I made a 12 mm hole, this will be easier for me to drill that proximal thing which I was finding difficult. इससे जब कितना आएगा छोटा ये 50 आएगा ना 55 है चलेगा ना थोड़ा ट्राई करेंगे ना विल नॉट पुट एनी रॉड बीनीथ दिस क्या करेंगे आप देयर इज नो ऑप्शन फॉर अस ओके पकड़ के रखो बी जेंटल यप गुड गुड चलो गुड अब बड़ा वाला दीजिए so we are going to ream 1 this is what we do in primary. And now for the hinge, we have a special reamer because the plastic of that hinge, that long plastic will go in that. So show them this reamer, please, when I get here. So this is that strong reamer, the bigger reamer that I am going to put in. Please hold the plate very well. Yep. Must superb. Chalo, let's do the trial, please. It seems I have been okay. Let's remove this now. So tibia का trial अपना करता हूँ. आप tibia का trial तैयार करो और femur का hinge का trial तैयार करो. Nothing. We don't do anything in this. कुछ भी नहीं. We are not even looking at it. We have forgotten the medial side. We are just going to hold the rod. We are going to have a distally held tibia. और माने से ना nibbler आते जो. Let me now remove this. Let it be there. The cement will help us. I am going to make drill holes here. Let the cement hold it here. Cement में पकड़ेगा. I don't think so. If I am okay, and if my 2.5 plastic is okay and I don't get FFD, then I am going to go this way. If I get hyperlaxity, then only I am going to raise the tibia with wedges. So let me have a trial first. Let me have a look. Nothing.
We cannot make out anything you're saying.
I am going to shift it medially. The entire tibia is going to shift medially. Yeah, no. This is medial. इसको मैं इधर ला रहा हूँ. The lateral part is going to come beneath this condyle, which is out. वो medial को भूल के I am going to shift it like this. So I am lateralizing the plate basically. If you lateralize the plate, you shift the tibia medially, obviously.
We cannot make out anything you're saying.
No, I was talking to the other surgeon here. What I have done is I have forgotten the medial part. This is the medial tibial plateau which has sunk in. I am not bothered about this. I have lateralized my plate and I am able to put a 4-number plate here. Then why should I bother about this? I have forgotten this. So the surgeon was asking me, "Iska kya wedge?" No, nothing. I am happy with what it is. I have lateralized my plate. So that means I am medializing my tibia.
Okay.
Yes. Let's see.
Yes.
Let's see and see if it comes in alignment or not. Let's have a look. 4-number tibia. So I am putting the tibia in. There we are. I see the center. I am here in the mark. So I am not going to do anything. So and let there be cement. Let there be nothing. I am having a distal hold. The poly, उसका नहीं है, लंबा poly नहीं है, तो कोई बात. That's okay. That's okay. This is lovely. Very good trial. And give me the femur का नहीं है, क्या है problem? Oh shit. निकाल के रोको ना मेरे को. नहीं ढीला करके दो ना. अच्छा ऐसा करेगा फिर निकलेगा नहीं निकलेगा. Let me try it out once. Okay, अब है ना femur को हाँ रॉड लगा दो. तो नहीं तो काम करते हैं.
Let me first, oh yeah, I need to put it in the rod के साथ डालना पड़ेगा तो किधर I need to do give me the femur only with the rod, give me the femur with the rod. Yep. Trial है तो trial number, so this is plus 2.5. Okay, see the hinge has a plus 2.5 mm, so we are using the plus 2.5 mm trial. So we are sure that we are okay. Then we are going to, no, lift the femur please. Each cursor. Lift it up please. आप छोड़ दीजिए. Good. छोड़ दीजिए. There you are. Okay. So now I am going to put in the femur. Okay, give me this. Hold it there. Now see this. My medial side, this is very stable. If I extend it, I'm going to be very careful because I don't want to break it. I think there is an FFD here. But with time, I want to keep 5 degrees of FFD in this. The hinge doesn't have an anterior lock that we have in striker or Zimmer. So there is a tendency for this hinge to go into hyperextension if you don't keep it in around 5 degrees of FFD. I will be happy if the patient has 5 degrees of FFD, but he is walking pain-free and very stable. So that's what I'm going to do. Now, this is a trial. In implant, you will increase the extension by 5 degrees because it's a smooth surface. But see, I am almost straight. See this. As you can see, I'm almost straight. Maybe 5 degrees of extension is FFD is what we have. See, we are quite stable and absolutely stable medial laterally. Now, let me see the flexion. So when the patella is back in position, I'm not doing anything with patella at present, and I'm getting a very good range of movement, which I'll not get after the hinge. But here, we are getting an excellent range of movement. Let us say I don't do a hinge. Can this last? See MCL, touch karo MCL ko. Please touch the MCL as a third party. Right? Want to do a revision or want to do a hinge? See, he is not subluxating. Do we do a primary and finish it off? Can we do a primary and finish it off not doing a hinge? Because there is no medial lateral instability at all. Yeah, I can do primary. Then it's absolutely stable.
So are you going to continue with the hinge or?
What do you say, sir?
Are you going to continue with the hinge?
What do you say, sir? Satish bhai.
Yes. No, I was asking whether you are going to continue with the hinge joint or just.
No. That is what we are discussing. We can continue with the primary joint. I feel we can continue with the primary joint. It's so stable. And he is so stable in this. We have a tibial rod is perfect. Let's continue with the femoral rod also if we feel, but simple femur also we can try it out. No, अभी rod बिना का femur दो. अगर stable है तो करते नहीं है ना. मुझे सादा femur दो trial में.
Sir, Dr. Neeraj sir. Kinder.
बोलो sir.
Sir, the problem is that the patient has undergone the same surgery on left side by me.
Were you this stable on the table that day also?
Yes, on table.
So again, then we'll do the hinge. Then we'll do the hinge. We have already started hinge karo.
I want to sleep.
Please take out the hinge. Okay. I agree with you. You are a senior surgeon in this case. I agree with you.
Forget about senior or junior on left side. This knee is still subluxated and I need to revise it. So on the right side, I don't want to.
Okay,
go ahead with hinge.
सब size मालूम है ना?
And take trial, sir. Take trial with the hinge.
No, hinge trial में the femur will not come out. There is some problem there. I am very happy here. I am going to do directly the implantation.
Okay, but hinge is final.
पक्का hinge is final. I agree with you.
Thank you.
Yeah,
And
this is
one more
what is
thing-
कहते हैं इसको लोब कहते हैं लोब. तो देख के लोब लग जाता है.
Neeraj sir.
बस.
Hello.
हाँ जी.
Sahib.
हाँ.
We are about to start the lunch and parallelly the surgery will be going. People will have their dishes
Please
inside
continue your
the.
lunch. Give me लंबा रोड. कितना रोड?
Okay.
ये डालना पड़ेगा. तुम सब कर डालो. Let's. Okay. Please start eating and watching.
Yes, sir. Okay. And you are continuing with him and we will start. the
Yeah,
lunch.
we are continuing.
lunch has
100%.
started.
You will not have any complaint from this patient. हाँ, ऑपरेशन में करेंगे, वो करेंगे ना. Not to worry. अब तुम क्या निकालो, चलो, मैं तो स्क्रब दो. कहीं मत करवाना. है? नहीं, आया कहीं मत करो. मतलब काला करवा सकेंगे सीमेंट ना. ए भाई मैंने कहा ना सीमेंट उधर ड्रिल दो ना. थोड़ा होल्स कर दो इधर. हम इधर होल्स करना है मेरे को.
Dr. Neeraj,
परफेक्ट है
निर्भय सर,
हाँ जी
sir, a question. There's a question from my side. If you
Yes.
hadn't got the tip from Dr. Kinner about the laxity on the other side, would you have proceeded with a hinge or would you have gone only with a revision primary?
No, I am doing a hinge because Dr. Kinner had a bad experience on the opposite side. So we
if
are
you did-
100% doing the hinge.
If you did not have that tip, would you have gone with the hinge or the other option?
If I did not have that experience, I would have continued with the primary, landed up with trouble, and in the next knee, I would have done a hinge.
Thank you very much, sir.
Thank you. Cement પકડે તો. Give me a scoop, please. Let me shave it off. એટલું બોન આવે ને એટલું સિમેન્ટ સારું પકડશે. See, forget this. Always કેવું મસ્ત આવી ગયું છે ને. એની લપજ ન કરે. No wait, nothing. You don't need to do anything for this. તમે આવી ગયું. તમે ઈબેને મિડલાઇઝ કરી દીધું. તમારું બધું આવી ગયું. This is the fun of doing. અને જો મસ્ત અહીંયા સુધી આવી ગયું. અડવાનું જ નહીં. તમે જોયું રિઝલ્ટ જોયું ને. પ્રાઇમરીમાં થઈ જાય પણ ઓલું ટિલ્ટ થાય એટલે we are holding it distally. So this is a distally held implant. એનો ઉપર કોઈ પણ હોય doesn't matter. ઉપર I need a stable surface. આ ન હોય ને રોડ તો મારું implant stable રહેવું જોઈએ. If that is there, so that I can measure the gaps. એટલા માટે મેં કટ કર્યું. કશું જ નથી કરવું. સિમેન્ટ મૂકવું જ નથી મારે તો. How do you કાંઈ ન થાય. You did not going to hold the cement. કાંઈ ન કરે. Forget it. એ છે ને રિમોલ્ડિંગ થઈ જશે. તમે જોજો with time it will remold when the patient starts moving. Don't bother. ચલો મુજે first language baby please. First language please. કાંઈ નથી શું થશે બિલ કરવાથી બીક થશે પણ આ કાંઈ થવાનું છે કાંઈ હોલ્ડ કરવાનું છે કે સિમેન્ટ અહીંયા કાંઈ નહીં થાય. Give me a scoop please. એક સ્કૂપ દે દો ને और ढील दे दो. તમે કર્યું છે તમારું તમે દિલ ખુશ કરી દેલો. તમે કયો એટલે એસિસ્ટન્ટને તો માન રાખવું પડે ને મારે. ચાલ તો બોન રીગ્રોમાં મજા આવે ને બરાબર. This is not going to work anymore. एक स्कूप दे दो. स्कूप जैसा कुछ खुरचने का स्क्रैपिंग मस्त છે જો વિડિયો જો ये शेम्फर थ्रू कर दो ना मैंने. अच्छा यू हैव अ फाइल विथ यू. थोड़ा शेम्फर में फाइल कर दो आप लोगों को लिख दो એટલે આ મારે કરવું છે. હા કર દો યુ આર રાઈટ. યુ આર પરફેક્ટલી રાઈટ. અને આ છે ને આ જો નોચ છે આટલા તો નહીં અને વોટ આઈ એમ ડુઈંગ એટલે આપણે છે ને ઓલું જે એફએફડી રહે છે ને જતી રહેશે. યુ આર રાઈટ. અને આપણે એફએફડી જતી રહેશે. વી હેવ અ ગુડ ફીમર હિયર.
Nirbhay bhai,
કર દો હમણાં જ કર.
Nirbhay bhai,
યસ પ્લીઝ.
are you going to be doing a trial with the hinge before you start
We
cementing?
were trying, but the trial is risky. के अंदर जाए ना तो it's possible that we may not be able to take it out. That's why I did not do a trial with the hinge. I was afraid that we may not be able to remove the trial. I was afraid that we may not be able to remove the trial, so we did not do a trial with the hinge.
Oh,
Give me a file or something to file જેવું હોય તો આપો ને please. चलो अब इन्होंने किया तो है. दिस इज आई हैव नेवर यूज्ड द ट्रायल. दिस इज द फर्स्ट टाइम द ट्रायल इज विद अस. इसलिए रिस्क नहीं ले रहे हम लोग. वी आर सेफ इन दिस. हाइपर एक्सटेंशन है नहीं. नहीं निकलेगा तो मर गए. लब થાય ને એના કરતા રહેવો ને. વી આર શ્યોર. I don't want to take the chance. ठीक है जो आ છે ને है ना परफेक्ट. You can't. The assistant has to keep on reminding the surgeon. So surgery में खोई थी. You start then thinking of something else. Wait. Give me a nibbler, please. Here, there is bulge here. And remove that bulge also. We have a good
You may fracture the bone by mistake. So I didn't want to take this chance. Okay. Yep, good. चलो अब पल्स लगा चलो प्लीज नीचे जाके मुकी दियो take 2 or 3 pads. Wait, give me a spike please. Not a retractor now. Anterior dislocation. Isn't તમે આમ પકડી રાખો તાવ બસ લા start please. Ready. હું સ્ટેમમાં સિમેન્ટ નહીં લગાડું યંગ છે રિવિઝન થવાની શક્યતા છે સ્ટેમ કાઢવા નાની માં યાદ આવી જશે મને ગાળો આપશે જે કરશે આઈ ડોન્ટ વોન્ટ ટુ બસ સ્ટોપ ઓકે સ્ટાર્ટ હા ચાલુ રોડ જ પકડવાનું છે આમાં કંઈ ન કરો તો એમાં ओके थैंक यू चलो पकड़ो वो सेक्शन कर लिया मुझे आई एम पुटिंग अ मॉप डाउनस्टेयर्स ओके लॉट ऑफ फ्लूइड फॉलिंग लाओ मैंने आपको मैंने वो आप दीजिए वन मोर ब्लू कवर और टॉवल और समथिंग एक शीट आप दीजिए प्लीज give me a nibbler, please. Nibbler up the person. चलो भाई. Give me a mop, please. A fresh mop. Fresh mop. एक Let me now. मैंने सेक्शन आपी दिया तो एक ही है आज फॉर मोर साइजेस गिव अस 2.5 0 5 7.5 दो बट अभी तक तो है नहीं दे हैव टू इंक्रीज देन इंप्रूव द इन्वेंटरी दैट इज द बिगेस्ट रिस्क इन दिस I that's why cut the bone less so this neither I can cut more I can't cut less again चलो जाएगा नहीं चाहिए क्या इससे ज्यादा चाहिए भी नहीं ना अपन को we have done that कर सकते हैं इफ इट इज लॉन्गर रॉड पर जरूरत नहीं है हमारा लेंथ हमने देख लिया है द कैनाल इज टर्निंग आफ्टर दैट सो आई डोंट वांट टू रिस्क एंड मेक अ फ्रैक्चर सो आई 50 इज गुड इनफ दैट प्लास्टिक शुड गो इन दैट्स व्हाट वी वांट एंड इट शुड होल्ड डिस्टली आमा આવશે તમે જોજો આ રહ્યું આ જાય ને અંદર હા हाँ पर घणो एवं एंटीबायोटिक आपी दो सीमेंट में हसे जामा पलकोस में हसे तो પછી નાખી દો ના ના એન્ટીબાયોટિક આમાં ઓલા રાખે સેફિરોઝા કર્યું છે નાખી જોસેફ કર્યું છે જોસેફ કે પર આપી દો હા એન હા and there is hinge now and rotating the chairs with the entire plastic rotates. Superb idea, I'm telling you. It's a lovely, if they give me modularity, there is no hinge like this. But I do need modularity in this. Yep. We need different polys also. ચલો આમ રાખો અને ભાઈ તમે છે ને પછી આમ પકડજો હું જ્યારે કહું ત્યારે હા અત્યારે ઉતાવળ રહીજો પોપ્લિટીઝ ઓલ્સો વી હેવ સેવ્ડ મેં પોપ્લિટીઝ હેડા નથી હાર્યું પોપ્લિટીઝ આમ કરીને આપણે કરશું ને રિલેક્સ ચાલો ઓકે चलो ओके थैंक यू बराबर हिलाओ एसी चालू रखो फुल ताकि आचन तमोर गिव मी न्यू ग्लोव्स प्लीज इनको नया ग्लोव दिया नया ग्लोव्स पहनो नया ग्लोव्स आप पहनो 7 for him 7.5 for me 7:30 आमने साथ जहाँ पे शीशा है थोड़ा से आपके लिए आप लोगे 7 इनको 7 दो 7 7 हमारा ग्लोव सारा से बाकी ना आप वी आर गोइंग टू हैंडल द इम्प्लांट्स ना अपन को नया ग्लोव पहनने का हम सब प्राइवेट वाले हैं थोड़ा नखरे वाले देयर वी आर आई एम सेफ इसको जान दो चल मैंने एक मॉप आपी दियो है अच्छा अभी आगे ऑप्शन है वाओ 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 सुपर पक्का 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 सुपर सुपर आई एम वेरी इम्प्रेस्ड एंड वेरी हैप्पी नव मॉप ले लियो 7 7 8 જ આપ્યા કરે છે ક્યારનો એને મજા આવે છે 8 માં લે તો તમને હું માનતો એને મજા આવે હા he is that 8 ball guy નાનો બોલે આપે તમે 8 જ પહેરો see subvastus can be used for anything subvastus can be used for anything મારું પટેલા પાસે જગ્યા આવશે પછી પટેલા શાંતિથી બધું ટ્રીમ કરી દઈશ it be say કોઈ subvastus આમ ને બધું you see the exposure that I am getting subvastus is a beautiful approach it has to be done properly that's all I need to do it like this
निर्मय भाई
हमारे कहीं भराव નથી અને કે આચન તૂટી જશે ફીમર
निर्मय भाई
it just હાજી
what is going to be the sequence of implantation for you?
first the tibia and then the
Okay.
femur comes with the poly and the hinge together. See, this is the tibia that I am going to put in first.
Yes.
It has a big cavity here where the femoral implant will go. Now, this is a prefixed femoral implant with the hinge on.
Yes.
And this poly, first I put the tibia in,
Yes.
and then this will go inside. See, I'll go like this. I'll put the femur in, put this in, and then hammer the femur in. So now, then I
With
have
how much degree of flexion will it go in?
initially hyperflexion, then at around 80 degrees, I'll do the final hammering.
Okay.
See, this is the hinge,
Yes.
and it is rotating platform. See,
That is the reason you were trying.
અને ઓલો ફોર્સેસ કે કંઈક લેટર સિમેન્ટ માટેનું wait for 2-3 minutes. There is no hurry. Give me a forceps. Thank you. રાખી દી ચાલ મારે ખાલી સિમેન્ટ કાઢો we have to be very careful not put cement here. This will block the hinge. We'll just put on the surface and on the rod till here. Not more, only till here. And in this, only till here, not more. बोलेगा ये खरे have faith થાકી ગયો છે wants to go and eat रसम चावल बॉम्बे वाला है भाई तो वड़ा पाव खिलाना पड़ेगा ना इसको थक गया इसका दोष नहीं है 3 सर्जरीज एक के बाद एक स्टफ कुछ खिलाओ तो से ऐसे बात कर रहे हो आप ये मिक्स द सीमेंट वी आर वेटिंग फॉर द 3 minutes.
Okay. Can you show us the cement preparation?
Yeah, there it is. Yeah, Rakdo. There it is. We have prepared it. I'm waiting for it to become non-sticky, and then only we'll then put it on this. Can you put the camera on this when he puts the cement on the implant? Yeah. चलो भाई देखो तो चिपकता है कि नहीं हाथ में 3 minutes हो जाएगा पानी ले लो स्टेरिलियम दे दो गुड इनफ नहीं स्टेरिलियम ले लो ना स्टेरिलियम गुड इनफ नहीं होगा स्टेरिलियम ले लो नहीं स्टेरिलियम आपको कुछ नहीं होगा स्टेरिलियम इज वेरी गुड स्टेराइल एंड वेरी नाइस अल्कोहल yeah it will prevent your sticking of the
Yeah, good. Chalo, good. So we are not sticking now. बस समझ लियो. हाँ, very good. Thank you. बस ये कर से भाई करिस मस्त करिस. डॉक्टर साहब ने खबर पड़ी कि मारे શું જોઈએ છે. What I'm going to do is I'm going to pack this up just to create a good surface. Can you show the implant here? Okay. See, now the cement is right up to the hinge, up to the notches here. And I am going to see that I am not in much rotation. So I am going to put this in. I am going to see my rotation. And I am going to slowly and gently keep hammering this. It is rotating. Oh, sorry. I have to rotate it. इसको ऐसे पकड़ के रखो ना, बस अब मैं कर लूंगा. बस hold it there. Don't let it rotate. Rotate हो जाए. It rotates on its own. Just wait. Okay. I'm going to go. Keep rotating. Yep. Very nice. Very nice. Thank you. Okay. Now you can leave. अब हो जाएगा. Okay, remove the extra cement. I'm going to put it here. I'm going to remove that extra cement like this. I'm going to pack this, remove it from here. Okay, femoral cement ले लेता हूँ मैं. मुक्त दिया, बस ले लो. I'm going to hold this here, fine? And I'm going to hold this here. Okay, so I'm safe. Now I'm going to clean this up and now lift the femur. Femur lift karo. Lift it, lift it, lift it, lift it. That's good. Keep it lifted. I'm going, no, not needed. If I need it, I'll let you know. Nothing needed. Now, it's good enough. Cement है. Cement तो अंदर ही जरूरत है. So I'm just going putting cement just barely over the. I don't want cement in the hinge. Very important. Don't put cement in the hinge. Hinge में cement निकाल दो. कुछ भी हाँ. They should know because it will not bend. And then हाँ cement बिल्कुल निकाल दो. कम cement रखो. इधर सब cement कम कर दो. कम करो और कम करो. Just इधर तक ले लो. That's it. हो गया. Give it to me. So I'm going to remove all this extra cement here. निकाल दो इसको. I don't want the cement to go in the hinge. ये तो hinge will not work. And I'm going to go till 50% of the rod. I'm not going to go beyond that. Again, I'm going to remove that extra cement. Okay. There we are. Fine. I'm going to try to go in first in the canal. Yeah, I need to lift it. Lift karo, pair. Bahar nikalo. Yeah, there it is. See, now it is in. I'm trying to extend karo pair ko. Extend karo thoda. Thoda aur bend karo. No, it's not coming in. Chodo. See, now we are in. See, the plastic is in position. The femur has gone in. I'll use my hand first. Now, if I'm sure that my poly is not obstructing, poly is behind this, my extra cement is all out, then I'm going to use my hammer and punch to put the final femur in. So the femur has gone in. See, forceps dijiye, there is cement here. See, the forceps dijiye. There is a cement in the hinge. I'm going to remove it first. I don't want any cement in the hinge. पतला सा कुछ है क्या आपके पास?
Sorry about this, but I need to remove this first before even hammering. Now hammer de do, koi baat nahi. First, let me now put the. चलिए एक मिनट रुक जाओ, निकलेगा वो, फिर ये निकाल दूं। ये इनफ टाइम, सीमेंट को बहुत देर है, इनफ टाइम। इसको और अंदर डालना पड़ेगा, तो वो हाथ से डालेंगे या एक्सटेंशन करेंगे तो हो जाएगा। ओके, अभी रुको। रुको रुको, अभी आराम से होगा। डोंट बहुत देर है तुम्हारा सीमेंट में, कम से कम 10 छोड़ दो। Coming out from here, either we push it in or we remove it from here. Give me a simple plain gauze piece, please. थोड़ा गॉस पीस दे दो मेरे को, पतला सा गॉस पीस आपको कल्पेश भाई। Okay, can we try again? Extension. लाइए थोड़ा टैप कर देंगे। टैप से कुछ नहीं होगा, अभी एक्सटेंशन से ही होगा। अब छोड़ दीजिए, अब छोड़ दीजिए। ओके, अब मुझे लेट मी रिमूव दिस। ओके, चलिए आ जाइए उधर, एक बार मैं खाली देख लेता हूँ, वंस मोर, just to see that, yeah, there we are again. We remove this entirely. Okay, happy? Okay, again we do this. आ जाइए सामने, चलिए अब सामने पकड़ के તમે કલ્પેશ ભાઈ આવી જાઓ ને, હું કહું એમ પંજાને અહીંથી ધક્કો મારો, તમારે છાતીએ લગાડી દો, and just relax, try to push it up, gentle, keep on pushing up, gentle, okay, I'm done. You hold it till it sets. अब हाथ में एक बॉल ले लो, take a ball of cement in your hand, so let's see whether it sets or not. So I am done. We are waiting for cement to set. We are getting around 5 degrees of FAD. I feel that I am quite happy with what's gone on, and I want to keep it. With time, the soft tissues will stretch out. With time, the posterior structures will stretch out and will get a very normal knee. It needs around 6 months for that 5 degree FFD to go. We need to strengthen his quadriceps, keep him in range of motion, and slowly and steadily his FFD will go away.
Remember, we'll just break for lunch now. And
Please do. Fill your stomach.
Okay.
Don't remain hungry. Thank you very much, everyone.
All the participants will want to see a post-operative X-ray later on for this.
Yeah, we will all be very happy if you can see the post-op X-ray. And if anyone is interested in seeing the closure of the subvastus approach, they can continue seeing with the lunch, or rest can go for lunch.
Thank you so much.
Thank you, sir. Thank you. I needed to hammer that last 2 centimeters. Hammer is gentle, so it is holding in there.
Even in femur, we had to hammer it in. Final was very tight, so it's not going to move now. I pray 10-15 years, Marija, he'll be very happy person. I expect 10-15 years minimum. Assistant sir. वो पे क्या उतावળ નથી યાર નો હરી હતો अब काम तो પતી ગયું છે મસ્ત લંચ તો અમે પેક્ડ જ મળવાનું છે પછી લંચ તો પેક્ડ है कोई बुफे नहीं है डब्बा देने वाले डब्बा तो हैप्पी सर ओके हिंज चलेगा ना बॉम्बे वाले से आके बोलना नहीं कि सर ने ऐसा ऑपरेशन किया था खराब अच्छा कि बुरा पता नहीं नाम है कि बदनाम है पता नहीं पर देखा एक चीज भी हमने मीडियल टीबिया देखा ही नहीं मीडियल टीबिया छुआ भी नहीं जो बचा था उसी में से अपन ने कर दिया ठीक लकीली वी गॉट दैट चांस नहीं तो 3 नंबर डालना पड़ता बाकी 3 नंबर नाखी देना 6 ऑप्शन 6 वी हैव नो प्रॉब्लम्स ओनली ऑप्शन आई वांट द थिकनेस टू चेंज 0 આમાં 0 તો મજા આવી જાત ને હજી આપણે આમ પણ હું સાચું કહું 0 તો હું તો 2.5 જ નાખા आई वांट 5 डिग्रीज ऑफ इट आई एम वेरी क्लियर अबाउट इट पहले वेजेस था नहीं सपोज વધારે કટ અને વધારે ઓલું થાય તો વેजेस સ્ક્રીન આપણે રેસ કરીશું હવે 5 mm વેજ આવી ગયા 5 mm 10 mm દો હે ને 5 and 15 ટીબિયામાં જે પહેલા નહોતા હવે આવી ગયા અને આમાં ફીમરમાં નહોતા વેજ હવે આવી ગયા તો નાઉ વી હેવ અ કમ્પ્લીટ હિંજ સપોઝ વધારે કટ થઈ ગયો હોય તો આપણે વેજ નાખીને રેસ કરી દેવાનું ટીબિયા પણ હવે સી હાઉ મચ આઈ કટ ધ ટીબિયા યુ સો ધેટ મિનિમમ 2-3 mm કટ किया આપણે એટલા લૂઝ લિગામેન્ટ પ્રાઇમરીમાં થઈ જતા પ્રાઇમરીમાં થઈ જતા મને એવું લાગે પણ હવે નહીં એમને છે ને આમાં થઈ ગયું ને એટલે બહુ બી ગયા છે ન ચાલે વી હેવ ટુ ફોલો ઇટ ઇઝ હિઝ પેશન્ટ હે ના સાંજે પતે ઘરે નહીં જવાનું કાલ મારે પછી મારે સર્જરી નહીં પ્રાઇવેટ હે કોકટેલમાં સેટ થવા દે સિમેન્ટ પછી હું પટેલા કરું પછી કોકટેલ આપશું કોકટેલ તૈયાર અરે ભાઈ કોકટેલ મારે પીવી નથી એને આપી દે ये 5 डिग्री से ज्यादा एफएफडी नहीं है ठीक अड़ जाएंगे अड़ो तो मैं तो अच्छा लगेगा है ना 5 डिग्री थी खराब था रे कुछ था ही नहीं बोन इतना सॉफ्ट कोई बात नहीं ले लो कोई बात वी डोंट नीड द वाटर ओके सक्शन राज्य अब वॉशलेस कोई बात नहीं वी डोंट नीड द वाटर कोई बात नहीं બીજું પલ્સ લેવા ચાલુ કરતા તો ઈટી મારું હશે પલ્સ લેવા દે દો સરસ વોશ લઈ લે મસ્ત ના હતા जी नहीं बहु वार लगा पहले कोर्स में मैंने त्रास आछे आमनु सीमेंट छे तो 4-5-10 मारे उतार करवी पड़े आमां धगधगाटी बोलावी पड़े आमां अरे भाई बात जान दो 7 मिनट मैक्सिमम हमारा सेट थी जाए एसी चालू के तो 8 मिनट थाय सेट ज नहीं वेट एंड वॉच पहला को सुनिए हमें तो सीमेंट वापरिए सीमेंट इज द डीलर फॉर दैट आल्सो सीमेंट 1 ओ सरस मस्त सीमेंट है फास्ट होता है खटाखट आधा मिनट में तो चिपकना बंद यू कैन स्टार्ट कीपिंग एंड अप्लाइंग हाफ मिनट यूज द डीलर केजन तमने मोकल से तमे नंबर ले लियो ये मोकल से रे पे माल है मुझे कोई पैसा नहीं है नंबर लियो ये मोकल से इज द डीलर मने ही वेचे से तमने ही वेचे हो or 2 minutes we take only half a minute to start using it because we don't get much time we do the
चिपकेगा ही नहीं, आधे मिनट में तो लगाना शुरू फटाफट। एक आर्टरी दे दो ना, कुछ दे दो, नहीं तो लगाने को बस टॉवेल क्लिप के कुछ दे दो ना, उधर होगा देखो तो। और आर्टरी वो ले लो, आर्टरी। अभी सीमेंट सेट हो गया। 1 मिनट गिनो ना, 1 more minute। बापू अजी 1 मिनट गिनो, 1 मिनट गिनो। कोई बात नहीं, ऐसे कर लेंगे, कोई बात। झुक 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 झुक। अरे वाह, नहीं नहीं, इसमें से सेक्शन करो ना, कोई बात नहीं, निकल गया निकल गया, चलो ये करेंगे, धीरे धीरे करेंगे। चलियो तो एमांथी પછી જુદું જોઈએ ને, બે સેક્શન જોઈએ આમાં। જબરું બનાવ્યું તો ઇન્ડિયન માઇન્ડ સેટ થઈ ગયું। 1 મિનિટ કરે એટલે આપણે કરી દઈએ। પટેલા હું જરા રીશેપ કરો, વેરી હોરિબલ પટેલા। ક્લોઝર માટે વાઇક્રિલ અને એથિલોન, બસ બે જ। એક વાઇક્રિલ એક એથિલોન। વાઇક્રિલ 1 નંબર, એથિલોન 20। સેપ્લો યુઝ નથી। ચલો પગ નીચે મૂકી દો। પટેલા હું હજી નહીં કરું, but I'll do the patella side some more time before I disturb the cement। चल लाओ निबलर लाओ, लाइट करो इधर। और पटेल खाए नहीं, if I want to replace the patel I can't see। हालत जो I'm not going to damage anything। अरे तो पेन था से क्रिस्टीना एगिलेरा છે કે કોણ છે આ બેન? આપણે ફેમસ સિંગર છે ક્રિસ્ટીના એગિલેરા, એ આવી ગયા અહીંયા કામ કરવા પૂછું। અગર હું કરું છું મારે, let me not reshape it। Let this remain, this gives it a hello 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 hello। तो बी कती डूबी जासो, धंधे लागसो, फ्रेक्चर वेक्चर થશે ને તો ઇજ્જત ની ધજાગરા થઈ જાય। You have seen lot of things happening in demo surgery, huh? जैसे पकड़ के रखो ना, बस that's good। इस टाइप टोटल एल्बो, हाँ टोटल एल्बो છે एक जात में। ये तो हिंज है, ये तो प्योर हिंज છે आने। एल्बो इज हिंज जॉइंट, हो गया, छोड़ दो। ठीक, अभी वॉश लाओ, पल्स लगा दे दो, ला ऑल सक्शन ले लो। चलो सर चालू चालू। पानी आ नहीं रहा, आया। चलो बस 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 स्टॉप। और बीजो सेक्शन ले लो ना તમારું, આમાંથી લઈ લ્યો ને, ઓલો બીજો સેક્શન લગાડી દો, પકડો લા। ठीक, हिंज इज ओके, મારું સિમેન્ટ હિંજમાં નથી। ओके, गुड इनफ, गुड न्यूज। चलो गिव मी निबलर, वो બધું સિમેન્ટ का आजा बोन पीस काट लो, पकड़ो। Okay. 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 Everything is okay. Chalo wash. Wash दे दो. ना ना बढ़िया. तुम सक्शन अलग से रखो. किडनी से पकड़ो. चलो. Thank you. बस 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 stop. वाह. Lovely, lovely, lovely. You done a good job. Fine. आप निकलो आराम से, मैं बंद करता हूँ, थक गए हो गए. चलो जाओ जाओ मजा करो. अभी देखो विद्या पटेल ट्रैकिंग देखो. ओके चल लो. हेलो भाई, इंजेक्शन आपी गयो તમારા. कॉकटेल आप दो कॉकटेल. If anyone is watching, we are doing closure of the subvastus approach. I am putting in the cocktail that they are using here. I don't know what's it made of, and I'm not going to ask. It's their cocktail. We only put sensorocin with antibiotic. I don't use steroids. And we are going to put this back, this point that we had marked to this point. Once we do this, we repair this, we are done. We don't touch the patellar tendon of the vastus medialis. See everything healthy, nice. And we have done a hinge with a subvastus approach. Sensorocin and antibiotic, bus base. Pain matters, sensorocin. 30 ml sensorocin, 10 ml antibiotic, 40 ml ठीक है, 10 ml 4 बार. चल वाला राइफल दे दो ना. हाँ सेफिरोज दें बाप यार. ऑर्डर फॉर्म आमा हूँ, आमा तो नहीं, आमा तो अंदर ठीक है. 10 ml तंबे बनाई सको ना पाउडर फॉर्म. हाँ डाइल्यूट करी ना 10 ml में. ना नानो फोर्सेप में थी. अल्लाह. Now see this. This is the point which we mark. See, I have to mark to it. So this goes here. L, inverted L goes into the V. Then nothing to it. You pakar se. Coverage by you pakar se. Nothing. We don't know. Nothing. Kuch nahi chahiye. Ho gaya. Kuch bhi nahi. No damage to the soft tissue. Puru. However, we do flexion because we want this tight, and we'll do this so that we don't over tighten this to prevent flexion. So we don't over tighten it, so we get good traction. चलो पकड़ पे खेलता जाओ. साहब नहीं जाओ देना, साहब मेरी मदद कर सकते हैं. यहाँ भी जाओ. अब जो कल पे जगह भी जाओ. चलो आ खींचो, खींचो खींचो. आप निकल सकते हो. Go. Thank you so much. Loved it. Thank you, boss. I want you to thank our assistant who is here from Bombay. Thank you very much. खींची रख जाओ. Thank you, boss. ऑफ कर दो. करो तो हमारा तरफ तो जो लागतो नहीं, મને અવાજ નથી આવતો. ઓકે જો બાકી કાઈ નહીં. પૂરું कर दो. તમે ખાવા પીતા પહોંચો ભાઈ. એન્ડલેસ છે તો. ચાલો ખેંચો. Bas, there we are. See, now I'm going to go right up to here and then I'm done. Thank you so much. એટલે હું ના પાડું વાર કાઢવા. તમને ખ્યાલ આવ્યો? હેર રિમૂવલ થી જ કરવાનો. અહીંયા તમને દેખાય નહીં ઓટીમાં. then extend again. અહીંથી લાઈટ કરી દે જરાક આપણે લાઈટ કરી દે બસ એ રે ભાઈ આવી ગયા થેન્ક યુ આ કરો અહીંયા કરો બસ થઈ ગયો now આપણે જે કટ કર્યું છે ને રેટિનાકલમ એ રોટેટ કરી લો અહીંયા સુધી કરશું આપણે ક્યાં અહીંયા સુધી that's all then we don't need to go beyond that. પતી ગયું મસાલા ત્યાંથી કરવાનું પતી ગયું ધી એન્ડ સી હવે તમે કરજો ફ્લેક્શન હલશે જ નહીં પટેલા હા ને આ તો ચોટી જવાનું છે દોરા બગાડવાના ખોટા એક વાયકરી ને એકામાં પતી જાય બધું મહાકાળમાં ભલે આપણે ન કરતા હોય પણ એનો વિચાર તો કરવો પડે ને કટ ચાલો લાઈટ અહીંયા કરો તો finally it compression bandage બાંધીને જ કરવાનું ને I don't put a drain finally ટૂલને ઓફ કરીને કરી દેવાનું compression કરો compression bandage બાંધીને કરતા હોય તો કા પહેલા કરવું અને કા compression bandage બાંધીને કરવાનું we don't want unnecessary bleeding inside અને અધવચ્ચે જરૂર રહેતા હોય ને શું કામ કર્યું છે ટૂર્નિકેટ તો 5 મિનિટમાં શું જાય કેટલા મિનિટ થી જોતો જરા ટૂર્નિકેટમાં ટાઈમ કેટલો થયો 2 કલાક નહીં થયા that's good enough for a hinge, no? એ માઇક લેવો તો લઈ લે ભાઈ આડું આવે મને કારણ કે અહીંયા પડી જશે આમ અંદર ગુણમાં અનસ્ટરાઇલ બસ પકડી લે બસ થઈ ગયું હું છે ને ભેગું કરતો જાઉં નહીં અહીંથી પકડવાનું છૂટું મળે અહીંયા એ સ્ટાઇલસ કેમ આમાં પોલીમાં એમાં તો હોય હું તો રૂટીન 0 જ વાપરું આપણે કે બીજું વાપરી શકીએ કલ્પેશ જ વાપરીએ લપ નથી કરતા ટુ બી ઇન ધ લાઇન ઓફ ધ સેકન્ડ ટો હું એટલું માનું છું એનું જે બેઝ હોય ને એનું દંડીકો નીકળતું હોય ને એ સેકન્ડ ટો પાસે હોવું જોઈએ then you are safe then you are right અને પછી તમારું વર્ટિકલ જોઈ લેવાનું in the line of the tibia or not ઠીક છે કરતો 10 ડિગ્રી બીકોઝ મારે રોડ નાખવું હતું ને એટલે 5 ડિગ્રી રોડ ની તો ઇન્ટિરિયર સ્ટ્રાઇક કરે તો ઇન્ટિરિયર રોડ આવે ને સ્લોપ ઓછો તો સીધો જાય ને એટલે માઇક ડીડ સ્લોપ 5 ડિગ્રી કર્યું અને એ સ્લોપ 10 ડિગ્રી એટલે છે કે એને મૂકી દો એના મોબાઈલ બેરિંગ તમારું સ્લોપ ઓછું હોય ને ઓછું હોય તો તમારું ટીબીયા ઢીલું પડે આમાં તો અમે રોડ નાખવાનું છે ઢીલું ક્યાં પડે સો આઈ એમ નોટ બોધર્ડ એમ ગોટ માય પોઈન્ટ ધ એન્ટાયર point is invalid about the tibia getting loose because we are anyway putting a rod.
નોચેસ આપી દીધા છે ખાલી. એટલે મારે રાખવામાં બહુ ધ્યાન, તમારે રોટેશનમાં આવી જાય તો રોટેશનમાં જ રહી જાય, પછી નીકળે નહીં બહાર, સિમેન્ટ હોય ને. એટલે મેં પાછું કર્યું તરત જ, મેં નહીં, આઈ વોન્ટ ધ પરફેક્ટ રોટેશન. એટલે મેં માર્ક. હા. ચલો ઓલા આપો ભાઈ સ્કીન.
Hello, everyone. Hope you enjoyed the lunch. Now we will continue with the topic, what is myth and what is true in TKR. I would like to invite Dr. Rakesh Rajput sir as a speaker and Dr. Satish Patel sir and Dr. Karthik Shukla sir as a moderator. Thank you.
Please, sir. Mike. One check. Hello. Yes, please, sir. I would like to invite Dr. Rakesh Rajput for his lecture. He is our esteemed faculty from Calcutta and Kolkata. Sorry. Or he performed lecture. Chalu. He has performed an excellent surgery today at our hospital. So, sir, please take your lecture.
First of all, thank you very much, team TTK, Beuchel Pappas Legacy, and also the team Ahmedabad, Dr. Kinner, and all the others who put up the show. This is probably one of the largest shows BP has put in. There were a couple of other shows, and I'm sure they'll do more. So I'll just carry on with my talk, which is about, a lot of things get said about TKRs. So there are some things which are true, some are which we don't know. It is new. Time will tell us whether they will become myth or they will remain facts. And some of them are downright myths, like they're not really true. So let's try and clear a few of them. Yes, we agree that there is a need for innovation. We need to do something new. And particularly in TKR, if you look at all the studies, who's looking at the follow-ups, the PROM scores and all that, quite nearly 18-20% patients are not happy. Now, whenever we try and bring an innovation, we always blame that figure, that 20% I'm trying to correct. Not that they have done a lot in Trachea, there's still so many unhappy patients, but that is a huge number. If you look unhappy patients, we're not talking about people who didn't really do it. So fair amount of people are not getting better. So let's see what we can do. And, these were the things which was brought upon, like, can we do something about fat embolism? Can we do, and, how much of fat embolism are you really thinking about in doing one knee? What about smaller incisions, accelerated rehab? And in this place gave us zero technology or something. I forgot about the actual name of that technique. But anyway, a lot of things happened. But there is a need for true innovation. And the need for that is that yes, we do want patients to stay less in hospital. If you see one hospital-acquired infection, you would want then these patients to go home much quicker. I was in US a few years ago. 70% of the TKIs were done as day case, and the rest went back next day. So nobody stayed for 2 days. Yes, we have reached 3 days in many parts of our country, but day case, I don't know if anybody is still doing them. No, I'm not talking about UKRs, but TKRs we're talking about, okay? And we want them to return faster to the activities. If you see people struggling, and the first thing they ask you is, when can I get back to job? There are a fair amount of people who really want to get back to job, and you say, well, 6 weeks, 2 months, and then they get sort of disheartened, So, and pain. Pain is something very paramount still in our surgery. And if surgeon can actually say that it will be a painless surgery, that he will have abundance of patients. We can somehow guarantee no pain or almost minimal pain to your patients, everybody will flock to you. We've not actually got a very big handle on this, but some things have happened in this. Alignment, I think we fought a lot. I don't know if you ever been to one of our orthoplasty conferences. The Indian Arthroplasty was done recently. So a lot of fight has happened over which alignment is good, but yes, we know that function has to be good. That's something we all believe, and that's something we have to aim for. So we got to change our paradigm from what we were thinking before to what we are thinking now, and see if we can actually use the modern technologies to achieve that. So regarding post-operative, first of all is the pain. And here the anesthetic is actually playing a fair amount of good roles. And you can see that most of the current anesthetic literature, and some of my patients are sufferers of that, because all the papers now are based on TKR, like, okay, my new DNB PGT is doing this study and that study, and so evening I'm not allowed to give painkillers unless they come and give. So a lot of things are happening. Antibiotic use, we've gone from 7 days to 3 doses. And if you go to some abroad center, just 1 dose of antibiotics, but that is 1 proper dose of antibiotic given at the right time, not the generic medicines, quality less medicines which we are subjected to. And the initiation of rehabilitation is not the day later, it's on the same day as soon as they come back. So how useful is pre-operative planning? We keep thinking that, okay, I'll go to the operation and I'll perform a surgery. But in the end, if you look at pre-operative planning, is it important? So there was this small study which was done in which they were making people kneel and doing exercise and seeing how much rotation they have to dial in. So this was the first study which was looking at rotation of the femur is important or not. Not that this study actually proved a lot more to that. Yes, they realized that people have different rotations, but it set the ball rolling that can we do something about it? That was more important. Rather than just knowing that people have different rotations, how to put that theory into practice. Like today also you saw that we were trying with this knee. And if you're doing some other knees, which is fixed bearing, you will have more struggle with that because there you have freedom of doing what you want. Today, you didn't have freedom because you're balancing. Gap balancing was more important than rotation. But in some cases, you will have freedom. Then you are really stuck. Should I rotate 3 degree, 4 degree, 5 degree, 6? So you don't know, right? Now, if that paper set the ball rolling, this paper really made us thinking. This is still a relatively newer paper. And I would ask all of you who are younger guys to go and look up on this paper from McDessie, from Australia, who's looked at the CPAC axis. What they're trying to say is that not everybody is straight, not everybody is varus. Some of them actually are valgus. And it doesn't matter what happens when they're just lying. What happens in weight bearing? So a lot of arthritic patients actually are in valgus, still medial arthritis. So when you look at their alignment, they are in valgus, but still the arthritis is medially. And then of course we have this constitutional varus people who will have medial arthritis. Some of them have got huge varus, but no arthritis. So they are saying you don't need to give everybody same true mechanical axis 0 degree. Don't aim for that. So this is the paper which has really set us thinking that perhaps there is some truth which all this while the Steve Hall group from US was telling us about kinematic axis. So there is some truth. So please do read this paper. I will say something more about that. I can't just dwell on this paper alone. So now we look at the PROM scores and all that. Do we need to know what our patients are doing or should we just carry on our surgeries? The answer is yes. So if you are going to look at the PROM scores, I believe me, you will start changing a lot of things in your surgery. It's very, very important. And then, also if you look at the X-rays, if you see very minimal arthritis, but patient has pain, believe me, when you do the surgery, this patient will not be very beautifully improved. He will still complain and moan about something. And the persons who have really bone-on-bone contact with osteophytes, these people are very forgiving people. There's something to enjoy. So make sure that the arthritis is really advanced before you subject them to operation. Make them suffer. That's what I'm trying to say. If they have suffered, you will get a beautiful result out of surgery. If they haven't, they will make your life miserable. So choose your patients well. Now laminar airflow and suits, and you saw today also suits. So initially when Charlie was doing all his studies, lots of things came in. He got his, at that time they had a Howard system. Then Charlie brought in his laminar airflow. So nowadays we have a mixed one, which is called Charlie Howard laminar airflows. So it showed reduction, antibiotic showed reduction, cleanness showed, hand washing showed, all these things showed reduction in, I think, including para antibiotics. But if you look at the current literature, all these have been questioned. Space suits, very badly questioned. Look at this study from New Zealand. This was the first one which came out, which started thinking as that is space suit really required. And it clearly showed that space suit doesn't make any sense. Even they said even laminar airflow doesn't make any difference. The question is, how many of these things are you going to discard? It's like going to a temple, you know. When you go to a temple, you don't need to wear, you can go in jeans, you can go in your shorts if you want, so does it matter? The question is the belief. So when you're doing something, you need to have the trust, the belief in that I need to be like this. Like I know that even the masks have been questioned now in OTs. If you start discarding all this slowly, you'll probably find some sleeper people roaming around here and there, even outside shoes coming in. So the quality and the standards will start going down. So don't trust all these reports on the face value of it. These are all trying to inculcate some good habits into you. So don't let these habits fall apart, even if there is no scientific evidence behind it. So some of them we are latching on because we believe in system that yes, people should be aware. Otherwise, you'll probably find 100 people coming out of the door. Because उनका OT में सब कुछ चलता है, उनको कुछ नहीं आता. Don't let the standards fall. That's what I was trying to come. So that's important. Minimally invasive surgery. This was such a vogue a few years ago. Thankfully, in my city, I had these huge hoardings that we can do keyhole operations. So we actually complained about them that this one particular hospital was putting these hoardings up. So then they were hauled up and said, what is this keyhole surgery for TKRs? They said, oh, our locks are so big, so the key is also quite big. So, that sort of a gimmick somehow I don't think should be left to politicians, and I think doctors should not get involved in this. So again, keyhole surgery for all its beauty and all its appealing probably should not be taken at all, because it doesn't really matter what you're doing with skin. It's inside what you've done is almost the same amount. Also, there's no point in macerating the skin, which is looking red and ugly, but just because the size is important for you. And believe me that you've all grown up now. So the days of catching a ruler and measuring up things when you were adolescent, those days are gone. So don't go around doing these keyhole things and don't measure things. You've grown up now. Okay. So minimally invasive total knee arthroplasty, comparative studies. These are all the papers which were trying to put us into that. So there was some. So I'm just putting that there is still some evidence for that. But if you look at evidence after 6 weeks, 3 months, you'll find almost dwindling. Same thing with approaches of the knee. If you go for looking for evidence, 3 months down the line, everything seems to be the same. So it's the KISS technology, keep it simple. That's what I would say, that whatever you've been taught for so long actually has been quite good. Now post-operative drainage. So before we talk about drainage, the tourniquet comes in. Should we put tourniquet around? Again, it doesn't matter. So people who have done tourniquet, people who have done tourniquet, no difference in results. Initial pain slightly might be less, people are not using tourniquet, but then you do find lots of patients in ward suddenly filled up with blood. So that site you have to be then ready for. Similarly, if you don't use a tourniquet, then perhaps you may not even need drains. But if you put tourniquet on, then you might need drains, particularly if you've left the dressing on, because you're going to ooze just after tourniquet comes off. But then don't leave these drains forever and ever. 4 hours, 5 hours is enough, because that's when you are having the maximum bleeding. Afterwards, take the drainer, because the counterthing to drain is chances of infection. Okay, and constant bleeding. So your knee will always have some blood in it. Same thing with hip. We have shown with ultrasound studies. The moment your vein comes out, you still will lose. You will have some amount of blood inside, and in hip, it's almost 500 ml, not less. That's the amount of blood you can have without you even knowing about it. So that's been done and dusted. So implant technology. Now this is the interesting part. Now we've done very basic things till now. Now UKR and TKR, CR versus PS, and PSI, gender solutions, bearing surface. I'll see if I have to go. Yeah, so let's first take up the UK. So just hands up, how many of you are doing unicompartmental arthroplasties? So just 2 hands. So why is it so that even this day and age, so few people are doing UKRs? And the answer is unfamiliarity. Not everybody. So if like half of you were doing, the rest of will definitely pick up. Same thing with like BPD. Very few people were doing, so nobody was talking. And suddenly now more and more people are doing, so more want to know. You know, we were expecting probably 20, 30, and suddenly we see 100 odd people. That's because now more people want to know. So they will bring more people who want to know. So same thing with UKR. Believe me, try and do it. You will love this operation. And I'm sure Karthik is just gone, I think. He probably doesn't find a reason to do a TKR. For him, everything is UKR. So your own state guy, for him, there's hardly a patient who needs a TKR. And I've seen him doing 8, 10 UKRs. Even Chris Dodd, we have a group actually, a UKR, where he said, I have only done 7 maximum in my life. And that's the world's best surgeon saying it. So we are actually beating that world's best surgeon with our numbers. So UKR is that good. Because if you believe, you will love this surgery. So the beauty of UKR is all this: bone conserving, functional alignment, no overstuffing, no less stuffing, no condylar offsets, just beautiful. But it is a bit more difficult. That's a drawback of this operation. It's a bit more difficult than TKR. You have to spend more time selecting your patients. Don't pick up a rheumatoid. Don't pick up severe deformities. Don't pick up so many FFDs. Don't pick up other diseases. So that's the trouble that you should not pick up, and you should be sure about that there is no arthritis in other compartments. Okay. For example, of a 41-year-old came to me about 10 years ago. And I said, well, you probably need an STO. I was also not very convinced at that time that I should offer him UKR. So he said, sir, XTO, will I be able to do that? I said, yes, you might, but because you have bone-on-bone arthritis, I can't guarantee you too much. So he said, then just change it. I said, you're too young for a knee replacement. So then we decided to do a UKR on him. And once you've done that, I had told him that this is an interim operation. After about 8, 10 years, you'll have to come back for a TKR. So he comes to me after about 10 years, very loyal patient. In fact, we become very good friends. Said, sir, abhi replacement kar dijiye. So I said, what is your trouble? He said, I don't have any trouble, but you had said after 10 years, you have to change it. So I said, can you do some exercises for me? So that is him going up and down stairs, that is him doing treadmill, still asking for a, so he's so happy guy. He trusts you so much because you've given him so good relief and such an important function for him. So now he's 51, but still a loyal person with no symptoms. So UKR will keep running and running. There is the wave rates in a UKR is 0.03 mm per year. So you can imagine how successful these operations are. The disadvantage I've just spoken about. So the indications are also very clean. Now, we'll probably skip this effusion. So is still anybody doing epidurals for TKRs, for unilateral TKRs? No. So thankfully, we've gone away from it. We've realized that that is not a very good way of pain relief. But the blocks are very good. So everybody using intra-articular blocks, you're giving infiltrations. So all studies have shown that to be good. And so there is nobody now who doesn't do that. Okay, so periarticular injections. Now, we will skip this one also. So there are various combinations of the injections. And if you ask 5 surgeons, all 5 may have a different regime. It doesn't matter. Whatever works in your hand, do that. The only difference I have with the Ranavat regimes and all that, they put steroids also. And then they say in a very small note, don't use if it's a rheumatoid, don't use if it's a immunocompromised. And if you look at your patients, half of them are that. So, when accidentally you will end up injecting a rheumatoid, you don't know. So I have actually taken away steroids from my cocktail. Is anybody here who's got steroids in cocktail? So 1 or 2 have, yeah. So you have to be very vigilant in that. That you give everybody? Yeah. So, but that's the steroids were added by Ranavacha, and he himself says that be careful about that. But whatever you use, if it's working in your hand, stick to it. That's my thing. So whatever works in your hand, stick to it. Simultaneously, everybody hands up. Everybody doing simultaneously bilateral TKR. No? Very few? Just few. Yeah, I think the senior ones will do, the juniors one might not want to do it. So it's not a unsafe. I come from a city where the first case happened actually against a bilateral TKR. So he became famous. So my friend Ranjan became famous all over India because of going to court for a bilateral TKR. The verdict against him was given by a doctor who's never done a TKR. Of course, he was a professor of orthopedics. So we fought against the court. In the court against this judgment, we won. And he was back reinstated, and that professor was told, never give judgments if you don't have experience in that. The professor was told. He was not happy with us. But then I think the seniors also have to be told that if you don't have domain, don't use that. Stick to what you know. Stick to what you were professor at. You were good at some other aspects of joints, not in knee joints. Okay? So bilateral is an option, but now we have very well-defined things where we can do and where we can't. So I'll just go back to a few slides because I think otherwise I'll miss. So CR versus PS. Any debate? Absolutely no debate, okay? Go and read Cochrane review about joint replacement, you will probably read all this. So you want to do CS, you do CS, you want to do CR, do CR. The only thing I would say is that when you're a beginner, probably stick to PS. It's a bit more forgiving knee. As you grow in your practice, switch towards CR. Because CR is a slightly more difficult knee to balance because you are now balancing one more aspect, which is the PS, the posterior crochet. So if you take away that, then there is less tissues to balance. So when you're beginner, at least do that. Later on, if you want to migrate to CR, migrate. Okay. PSI. Has anybody done a PSI? We know what PSI is? Patient specific instrumentation, not implant, instrumentation. Nobody's done here. So, in fact, one of your guys actually was a pioneer in that. I don't know, he's not here probably. So, we started doing PSIs about 10 years ago, 10 or maybe 11 years ago. We really took on to it. The only trouble with PSI was that it was not as easily available. Most of the companies were not promoting it in India. And very few surgeons really took on to it. Again, you have to sit in your office, spend time with X-rays, and then decide what to do. Okay. So we'll come to PSI a bit later. Gender solutions. So does anybody know what gender solution was? So the first time gender knee was brought in was by Zimmer, the next gen. Okay. So when they brought the thing and they were targeting the female population, which is 3 times as much as the male population. So you're basically targeting everybody. So what they were saying, the female, you require the notch to be a bit nicely convenient for the patella to track because they have wide pelvis, the patella will go out. So make sure that the patella sits well, bring the lateral condylar femur out and make it thin because otherwise there is overstuffing. So these 3 concepts were taken into gender knee. But if you look at the modern knees now, all of them are like that. I'm sure Beuchel Pappas will also slowly bring it a bit more longer, a bit more shallow. But there anyway is very friendly patella groove. So you don't need to replace patella. But that was all because most people had gone away from replacing patella. Right. So that was one. But if you see all the modern joints, that's exactly what they are. So there's nothing called gender knee anymore. All knees have become like that, like bearing surfaces. So it doesn't matter much in knees because hips have got a lot of bearing, but there is some issues here also. So should we have a poly which is highly cross-linked, or should we have the normal poly? Anybody here? So where is the evidence now? No. So read Seth Greenwald's paper. He will tell you which poly to use. Okay. He is one of the biggest researchers we have, Seth Greenwald. So even 3 years ago when I had met him, he had said that there is no evidence for good quality poly, the actual poly in visa. But now he's also come back and said the highly cross-linked that we use in hip is a better poly than the conventional poly. Okay. So the debate has been solved now. So the other part is, what about the cobalt chrome and the titanium? So should I ask PPK people? No. Where did this come from? So if you look at the oxinium, which was the Smith-Nephew knee, which was a zirconium. So they heat it so much that the top part of the oxinium layer forms. The zirconium becomes zirconized oxide, right? But it becomes passivation, repeated heating. So the whole layer almost behaves like ceramic. So it's got very smooth and it becomes black. It is actually a black colored one. So they found in lab that it can last 30 years in the lab. It can last 30 years, but it was, if you scratch it, it will disappear very fast. So allowing to prevent scratching, it will last very well. Another thing they found was because it's got no nickel, no cobalt, no ions coming out, the allergy results are going to be much better. So people who are allergic may be better used by this implant. Now they have a patent for this. So what did the other companies have to do if they had to get over the patent? To manufacture something similar, not exactly zirconium oxide. So the titanium nitride came in. And of course, we are Indians, we love gold. So all these knees started being called gold. Some even called it aura. So if you look at one of the competitive rivals, they actually call it oro, right? So gold knees as we call it. So the titanium one, again, with whatever limited research we've had on these products, are showing wear resistance, are showing less allergicity, and perhaps will last longer. But time will tell. I think we have to know when these have been implanted for 30 years before confidently coming here and saying that it will last 30 years. So resurfacing versus not resurfacing, again, the debate has been put to rest. Do whatever you want. You really can't look. I do hear these people from different forums looking at, I will look at the patella and selective resurfacing. I will look at the patella and decide. Again, there are studies, and one was with in my own center in Bristol, John Newman paper, Ben Square paper, but you cannot look at a patella and decide that. So there's enough evidence that if you want to change, you change. If you don't want to change, don't change. But you cannot be in between. Okay, occasionally there might be a reason for you to change, right? Something happened, but otherwise, so robotic surgery, again, a big domain. We have talked on robot here today? No? Okay, so hands up, anybody involved with robotic surgeries here? So you are involved? Rosa, yeah. So robotic surgery is again the one big thing in here. As I said, a lot of innovations will keep happening. You can't stop innovations. Whether they will stand the test of time or not, like navigation. When it came, it really hit the market. It was next thing after sliced bread, but slowly it disappeared. But there were still some surgeons who kept on using it. They believed in it. So, you know, we are all different. We're not exactly same. So in my hand, this may work. In your hand, this may work. A lot of people have now jumped onto robotics. I don't know whether it's purely for marketing purposes or it's actually giving benefit. I do lots of robots. I actually believe in it. Because, you know, what you set out to do in the beginning, I can finish at the end and say, that's exactly where I entered at, which I can't do with a conventional knee. I don't know how much femur I cut, how much tibia I cut. These measurements are also not very accurate. And then later on, what did I do? I cut some more. What balancing I had, I have no idea. We do by hand and say we are good. You give to your assistant and say, sir, for a lax lateral side knee. Right? Your assistant may not agree with you. But when you look at these readings on a robot, you know that you perform well. Plus, robot is not just planning, it's also execution of the planning. The execution is not by this thing. So, but I think robot is also not come here because what we need in robot is the artificial intelligence. That it should tell me that if this is the amount of osteophytes, if this is the amount of deformity, this is the amount of correction I need. That robot is still not telling me. Still, I'm accepting sometimes 6 mm deformities and I'm doing it and I'm getting it right. So how does this happen? I don't know. So there are still certain things which robot is not telling, but that is time will tell. So I think I'll skip now and come to the. So in days gone by, we were looking at durability. Technology changed, our phones changed, and definitely something else also changed. So all these things actually came in. So PSI I have already spoken about. Shape match implants. Has any of you ever had experience with that? That you are actually manufacturing a knee for a patient? Never? It's quite beautiful actually. I had a dwarf once. He was like 4 feet or something. But she needed she was one of the nurses actually. She needed PKR and I couldn't find the smallest size fitting into it. Do you know the smallest implant available in India at the moment? Any company? It's an Indian company. Yeah, so smallest implants manufactured still big for that patient. So I had to actually custom made with same company. I had to make the implant for this patient. So we had to, so that technology is also available. So if you want to make. Okay, so navigation, I think I'll skip that. So the navigation didn't really make our life that easy as we wanted it to be. So then came the custom, which we just spoke about the patient. So what happened, what went wrong with custom was, this is how it actually went. So if you haven't seen it, see it now. So I'll skip over most of it. But what were the drawbacks of this technology? Because this is now outdated, it's gone. Only I think 1 or 2 centers are still trying to bring back this technology on experimental basis. But what was wrong was the waiting period was too long. If I had to get it from US, 2 months was the minimum waiting period. 6 weeks, the company used to say, invariably it happened 2 months. So I did a lot of these. And people found difficulty adjusting technology. No surgeon wants to sit in his room and spend another 15 minutes trying to speak that I want to do this and then give it to the company. And they will then spend 2 months. The patients, our patients are so bad. They will not get a surgery done, but when they decide to get it done, they want it tomorrow. That's a typical patient of ours. They will not wait 2 months. And then they have to pay advance. So not many people you could convince to actually get this sort of operation done. Naturally, when the patients came with the jig, you could only upsize or downsize by one side. So if you get it wrong by spending not enough time in your room, then you have to throw away this technology and actually come back to the conventional system. So you have to really spend time in your room to be sure that you only are one size up and down and not anymore. But one size up and down is generally good enough. Right? I don't know whether any of you is old enough. Maybe sir might be or sir, sir, when you did bipolars in day gone by, you only used to order 3 sizes. Were you from that era? Yeah, so we've all been in that era also. You could only order 3 sizes of bipolar. So you would do with X-ray 45. So you would have 47 and 45. That's it. Three implants will come for you. Not the today's implants, you know, where you have such a huge range coming in. So same thing with this one here. STO, because it's a arthroplasty conference, I have to mention there is still a role for STO So the role has to be every day getting more and more defined. The angles have more and more defined. The lateral or medial side has more and more defined, but we are getting there. So we are getting there with STO also. This is again a surgery which we should probably know even as an arthroplasty surgeon, not leave it to so-called the sports medicine guy. There is no sports medicine in here. Now the sports medicine guys also want to do UK and say that is a domain of sports medicine because it is joint preservation. I don't know how it is joint preservation, where you're actually changing a joint and still calling it preservation. So newer materials now. So has anybody heard about a peak metal? No? So have you done cages, peak cages in your spine? So now that is coming into me. The trial has already been done. We are waiting for the first 5 years of this trial coming in. If it is successful, it will be launched. So peak will be launched. I think it probably will be launched within a year or two. Just waiting for that period of, because whenever you do this, 100 cases have to be done, followed up for about 5 years, and only then you can. So these are quite strict. Uncemented knees. It's not something new. It came and went, but it is coming back again. So and I think even BP has got uncemented knees, which probably India they have not launched, but they do have uncemented knees also. So the uncemented femoral part generally does well. The tibial part somehow has always been a trouble. That is why nobody ever picked them up. So if you have to use cement, then it's probably better to use cement on the other side. That's the logic. But uncemented femurs will come, but I don't know how they will actually get cooperated with NPPA, where we are using us. But this will come. Okay. Robotic surgery, as I mentioned, CAD/CAM technique. I have given you one example, and I can give you more examples of my own, where we have used this technology not for primary purposes, but for other purposes, particularly in hips. A lot of these, because I do acetabular fractures a lot, we have to use this technology fairly often, sometimes to actually get what we want. I was just seeing one very interesting X-ray from Dr. Juneja. This is again a technology where you can use CAD/CAM if you have enough financial resources. So what we still have here is a lacuna. So where are we aiming at? We are still trying to match our patient to what implants we have. So if I have 5 sizes of Beuchel Pappas or 6, I have to match my patient to one of these 6 sizes. What I should ideally be doing is to get a patient and see what implant I can use. So first option would be if I can know which company implant I can use, right? So there is a technology available for that. Not that 3D version or 3D version or something it's called in Ahmedabad, but there are, I don't know whether you see TraumaCAD. Have you ever heard about TraumaCAD? So it's a software which will take the sizes and will tell you which company's implant will fix the best to this patient, which size for femur, which size for femur. But then it doesn't tell you about the ligament laxities. Sometimes you are upsizing, downsizing to actually balance your knees. So, whatever you get, what we need is what we have along with the AI, the artificial intelligence. And I think this is where the robots might actually come in. That they can balance things for you, put their brains in, because it will get better. We are not getting any better. The robots will get better. So, but this is the day we are all hoping for. So in conclusion, these are newer things, which some of them may stay, some of them may not. But what is definitely true is the pre-op antibiotic reducing infection. We all know that. And the tranexamic acid reducing bleeding, I didn't focus on this one. That's been a huge changer. These days, we hardly use a blood for a single knee. We hardly use. Even for bilaterals, only occasionally I've used blood transfusions. This is how good this has been. And if you're not using it still, please use it. Okay. And energy cocktails do work. So what cocktail you want is a matter, but use one of the cocktails. What is doubtful is all the bottom ones, and I think I've gone through all of them. These are really doubtful. CR, PS, patella doing, patella not doing, this alignment, that alignment, no evidence for any of that. Right? So thank you very much. In the end, I will just finish by saying it's all about balance. That is the paramount. That still remains the paramount thing. Balance in your knees. Alignment doesn't matter that much. Thank you. Shall I take a question now or can we do it later? And
First of all, I thank the organizers for giving me to talk about kinematic alignment in total knee replacement. I should thank the previous speaker also for his plethora of views that one view is no view. It can be done by various means. Every surgeon thinks is correct and is able to produce and reproduce. They should follow that sort of thing. But anyhow, innovations keep on coming as per the previous speaker. Some will stand the test of time and some will disappear. But the goal and the aim, everything should be the same, to give a painless, mobile, happy joint to the patients. So, coming to the slide, kinematics, kining means movement of the knee joints. Movement occurs where only the articular surface. So, kinematic alignment means we have to reproduce the original joint line. In compared to the standard thinking of mechanical axis, where center of the hip, center of the knee, and center of the ankle is aimed to be in a straight line, for which you strip all the soft tissues unwantedly, to give 3 degrees or 5 degrees of external rotation, you are imposing a torsional effect into the joint. You are not respecting the soft tissue envelope around the knee. So, though 75% people are satisfied, only 25% are fully satisfied. Another 50% of it, they adjust with it. Last 20%, they never ever satisfy with the mechanical axis alignment. Because of this, Stephen Howell tried kinematic alignment. Kinematic means our aim is to recreate non-arthritic joint surface. Okay. John Insall is considered as a father of knee arthroplasty. Total knee replacement is a soft tissue surgery with bony cuts. When it was introduced, everybody had all sorts of deformities. So he said, to release the deformity, soft tissue is on the contracted side. For example, the varus knee, release it on the medial side. Valgus knee, do something on the lateral side. Flexion deformity, elevate the posterior capsule. And finally, take cuts at right angles, and flexion and extension gap should be balanced. So, going in that, popularized by Insall, stood the test of time. Center of the hip, knee, and ankle were aligned in a straight line. That is, hip, knee, ankle angle is 0. Ligaments on the contracted side are released. Proximal tibia and distal femur are cut perpendicular to mechanical axis. Femoral component is externally rotated. Joint line is perpendicular to axis or floor. So, everybody should be familiar with this. This is the aim, but on kinematic angle, in non-arthritic knee, in young individuals, before they develop arthritis, this alignment exists in less than 3% of the population. When nature has produced in a less than 3% of population with the neutral mechanical axis, when you aim 100% everyone to that axis, either by manual instrumentation or patient-specific instrumentation, or with computer navigation, or with robotic surgery. This is the concept of kinematic alignment. So, all the 20 years I was doing mechanical axis alignment only. The gentleman is an 84-year-old MBBS doctor from Kanchipuram. This is 11 years old follow-up of BP in a bilateral. He has no problem from the side. Then why should we change? Because this mechanically works well. He is a doctor who understands any minor problem. He will not come disturb me, this is not correct, this is not correct, I'm getting this is something, but other patients will keep on coming and complaining. So problem of mechanical axis alignment is release of ligaments to straighten the limb. Distal medial femoral cut more than the distal lateral femoral cut. That means unequal bony resection. You cut more on the medial side, you will cut less on the lateral side to make the limb straight. Similarly, on the posterior side, posterior medial femoral cut is more than the posterior lateral cut because of your external rotation of the femoral component. Whereas when it comes to replacement, you replace with equally thick implant femoral component. Medial side is not more thicker than the lateral side, but you resect more. That means you are not giving any importance to the original kinematics of the natural knee. Result, loss of natural joint feeling. Some may have explained stiffness, some may have unexplained pain, some reduction of motion. The worst to the scenario, they may have total dissatisfaction. So, this is the original Ranawat slide in 2017 Coimbatore. He has told that incidence of dissatisfaction with or without pain is about 14 to 28%. This is another slide which says reported incidence of pain and crepitation of the PSDKR with patellar resurfacing has been variable. From 4% to 50% people are having some or other form of pain. Dissatisfaction occurs with manual instrumentation, occurs with computer navigation, occurs with patient-specific jigs also, because you are altering the natural kinematics. So, proposed by Hungerford, Krakow, and popularized by Stephen Powell, this kinematics is, so they tried to change the design changes that fail to address the dissatisfaction of gender-specific knee, multiple radius on the femoral side, multiple radius, single radius, gradually reducing radius, and mobile bearing. Whatever you implant, this dissatisfaction still persisted. So this patient is a totally dissatisfied patient. Then in #1 hospital in Chennai, radiologically looks fantastic. We can't find any defect in that. He frequently comes and tells me, please do above knee amputation for both lower limbs. I will be grateful to you for the rest of my life. I referred him to a psychiatrist and got the opinion that he is psychologically very strong. That means there is something in everything. But I just gave tramadol or something which is nephro-safe and tell them that it will get adopted. But again and again, we keep on running from hospital to hospital with patient, wherever he goes, including homeopathy and everything, but he doesn't have any relief. So what is calibrated kinematic alignment of the total knee arthroplasty? You see, she was proposed by Stephen Powell. Just cut the distal femur along with the thickness of the blade, both distally and posteriorly equally. Don't overstuff it, don't understuff it. Just to resurface the femur, as such it is being adapted to the natural joint. If there is bone loss, for example, on the medial side in varus or on the lateral side in valgus, you cut less so that the thickness of the implant you do, you will bring back the articular surface to the original area. So this is the first breakthrough from the traditional mechanical axis alignment. Kinematic replacement. Kinin means movement. Replacing the original articular joint line is the goal. Replace cartilage and bone loss. The true resurfacing procedure for the femur especially, hip, knee, ankle angle need not be zero. Oblique joint line is the goal. Constitutional varus or valgus should be accepted. No external rotation in femur. No ligament release to correct the deformity. Equal amount of posterior, medial and lateral femoral resection. Equal amount of distal, medial and lateral resection. If part of resection, resected material plus thickness of the prosthesis should be cut with 3 degrees varus in varus knee. For valgus knee, tibia should be cut in valgus. Creation of oblique line is the goal. Extension gap to be rectangular. Flexion gap should be slightly trapezoidal to allow lateral laxity because lateral opening should be there. That is the physiology. It should not be tight. By doing external rotation, you are knocking off the natural lateral laxity. So that should be preserved. Medial side should be slightly tight in flexion. Lateral natural laxity should be preserved. So these are all the kinematic axis. One is the green, in which patellofemoral, the axis along with the patellofemoral, which is not like this, the tibiofemoral articulation occurs. One above the magenta, this is where the patellar axis. And the third one, straight one, is the tibial axis where internal rotation and external rotation occurs. So try to recreate all these in the joints. What to do? You have to take a distal cut equally on the medial and lateral side. Posteriorly, take a equal amount of medial and lateral side. You are not altering the kinematics of the femoral side. Together, you take a cut on the medial side and the varus. Lateral side, in original true kinematic, take it in the valgus, but in restricted, you can change it to neutral or varus. What is the aim? Aim is the x axis is the natural axis, 2 cylinder superimposed on the posterior aspect. So this is the true flexion and extension axis. This is not anatomical axis. This is not transepicondylar axis. This is generated as a result of computer model generation. So to bring back the x axis is the main goal. So coming to the mechanical axis and kinematic difference. Mechanical axis G, you are taking more on the medial side and less on the lateral side in the first picture. So taking a perpendicular cut on the tibia. When you go to kinematic axis, to take both on the medial and lateral same thickness. The shape may vary. Also, we give the natural 3 degrees medial-lateral slope to the tibia. So this is the difference in taking and the thing. In kinematic and mechanical axis, you take on the other side, red is the mechanical axis, where you take less on the medial side, and you come to the lateral side, you take bulk. You see the kinematic, you take equal amount. If there is a bone loss or cartilage loss, you take little bit less. So this is the example of mechanical axis, which I was doing all these years for 20 years. Once everything is over, you can see on the first picture, you take more on the medial side. Lateral side, you see, just a few, because of the external rotation required for the mechanical axis. After taking the cut, you see the second picture, almost you have taken more on the medial side, there is no cut on the lateral side. This is the one thing which mal rotates the kinematic axis. So coming to the surgical technique, first thing is varus tibial cut. Instead of second metatarsal, you aim for the third or fourth. Don't go beyond the fourth. The cut may be more than 3 degrees. Always stay between 3 to 5 degrees. The second picture you see, medial and lateral flexion condyles are equal. Place it equally. I didn't even put an intramedullary rod. Why should I put an intramedullary rod? My articular surface is the moving surface. Based on that, I am going to do. I am not going to do the mechanical axis. Just to the anterior reference, I kept it on both sides on medial and lateral, pinned it, checked it to the gap positioner. It was found to be stable. After cutting, I verified that flexion gap is excellent. So that means I have not mal-rotated the natural kinematic axis. Similarly, equal amount of distal I have just kept on my eyeball itself and verified with the gap positioner. This is a pre-tension effort where you can get before bony resection that whether what you are going to do is correct or not. So then I did the distal. The see on the other side almost I have resected equally. This is the distal side. When the broader one is on the medial side and the smaller is on the head. Shape may vary. But whatever I want to replace, you see it is the thickness of the trial. Almost I have manually got it closer to what I want. Distal you see, almost what I want to replace, that amount alone I have taken out. You see the same thing. Tibia, I have taken both medially and laterally equal side. And see the other bits. This is the total amount of cut. Highly bone preserving surgery. Kinematic cuts for varus knee, 3 degrees varus cut for tibia, 8 or 9 degrees valgus cut for distal femur. No external rotation of femur, no ligament release. Restricted kinematic cuts for valgus because in original thing you have to take a valgus tibial cut. 3 degrees varus is acceptable in restricted kinematic. So this also corrects deformity to some extent. So 3 degrees varus cut for tibia, 3 or 4 degree valgus cut for femur, no or minimal lateral release. So now you compare, the first one is the mechanical axis. You take more on the medial side and less on the lateral side. The second one is the kinematic. You just take equal. Caution, stay within 3 to 5 degrees. It should not go beyond 3 to 5 degrees. And you may be crossing the red line. In cuts or in overall alignment, in mobility joint line, whatever may be, your deviation should be within 3 to 5 degrees. So, coming to the differential cut, the first one is the mechanical axis, which I was doing 2 years ago. You see how much release damage I have caused to the medial collateral by releasing all around. See on the kinematic side, I have never touched any of the soft tissues. So, the soft tissue envelope around the knee is good. So, post-operative rehabilitation, post-operative pain, everything will not be there. Even by after doing bilateral knee, even sedation will not be given in the night. So see on the mechanical side, when I did 3 years ago, how much I have stripped on the medial side. See on the kinematic side, this is a natural flush. I have never released anything. So that means doing more than this knee. See, this is the comparison of this mechanical axis and the kinematic axis. This is Stephen Howell's slide, not my slide. You see the kinematic side, you see the natural contour of the lower limb. Whereas see, it is straight. Also better flexion on the kinematic side because you are not altering the kinematic axis. This is a severe rheumatoid arthritis in 37-year-old lady. This is after kinematic replacement, varus cut and valgus cut. Overall alignment is satisfactory. This is a varus knee, kinematic replacement. Overall function is better. This is a valgus knee. I have taken a 3 degrees varus cut. The alignment is excellent. The result is excellent. This is a post-traumatic OA. If I had to do a mechanical axis, medial side is very much down. I have to take only from the lateral side, and my base plate has to sit on the lateral side, what we saw in the third life surgery. So your fixation area is less. See on the post-op X-ray, same size port sits equally on all sides. I have never used any stem or anything. The patient is having excellent function. So Stephen Howell, TKR is a bony surgery. No soft tissue release. Hip, knee, ankle angle need not be zero. No external rotation in femur. Don't correct constitutional varus or valgus. When people came to my department, I had a photograph with him. Coming to the BP knee in particular, at the end of 17 years, 99% survivorship is reported by Beuchel, which is not equaled by any other knee. This is Pelagan, past president of AAOS. He has reported at the end of 18 years, 97% survivorship. This survivorship is not being duplicated by any other design in the market. So this is the 16-year postmortem retrieval. See, the plastic is fully there after 16 years in an American population, not in Indians. So there is no wear, no metallosis, nothing. So conclusion, kinematic alignment is an alternative paradigm. Mechanical axis alignment is the standard method. Both are suited to BP knee. So when coming to the freedom struggle, I took the picture from Vallabhbhai Patel Museum. All the three had different views, but their aim is to achieve independence. Thank you.
Thank you, sir. I would like to invite all the organizer and the faculty to the desk.
Hello.
Any query, any question to the
Hello, My question to you is, when AP had a design, RP and RPM, then the recommendation was of 0 degrees of slope, despite of this being the design. So what is the? Do you think that if the poly has inbuilt of 3 degrees or 5 degrees of, can it compensate? Not the design, not the design, the box and so. If you take more than 3 degrees, that will be expected into the. That is not at all. Only limited system. There are 2 things, not the standard system. Can go up to. So we realize that we really want to be that as well but look at the slope in the field of X-ray. Right? So measure that. That's a rough guiding.
My question is my personal practice. First one, your personal experience regarding brain. Second one, your choice of coping, if possible, you have a basic yourself.
No drain, since not out of medium drain, what we still. The cocktail is antibiotic which is cyclophosphamide, which gets diluted with 20 ml of 0.5% of central pain. And I think clonidine. My anesthetic is prepared, so I will maybe adjust content. Someone can even say that virgin medicine for cocktail. But you see, for pain, I have a slight different view than what her expressed, because by cash and Mediclaim patients, I still prefer to put epidural anesthesia, and it works well. Really works well. This thing works well. So do you mobilize your patient same day evening despite of spinal anesthesia? Same. No, I know your protocol. Yes. Same day with spinal anesthesia. So now that we are doing evidence and the problem of identifying we started and second is now block. So I will find accept is a time when we can think that we can think of it. If someone screams and I will like cry, it is very second is now block. So there is no I don't need it. I don't need any how to do it. Then the second is now block is taking full of motor power, no need of it, no problem like. So you want to know block is doing something, but if you are the physical is not getting something start walking, you will have a fall to the fracture. So it is very important. So your sensory block you want all the time, not a motor block. The second is now block is the way forward, and this is working very well. This is choice of cocktail, sir.
Okay, we've stopped using drains many years ago. We do have ecchymosis of the local part, but that clears up after a few days. So no drains, and we do infiltrate all our patients. It's basically sensor gain, and whatever you want to add with it is fine. It all depends individually. We add, I think my place, my anesthetist gives tramadol and clonidine as well. So, but it varies, doesn't matter. And I use steroids in all my patients as well, because I think that is the best anti-inflammatory agent we can have locally, and I find it works. Other than that, we do put in suppositories at the end of the procedure. And with this, we've actually decreased the hospital stay by 1 day. We feel that injectables have gone down drastically because of this.
Steroid, which steroid and what amount, how much ml or how to? Steroid, any brand or any
I think injection Kenacort is being used, 40 milligrams.
Okay, sir.
we used to use drains, but I stopped them because I saw a lot of fall of hemoglobin post-operatively. We saw great fall of hemoglobin. We used a lot of blood, pre and post-op. We have almost come back to zero. Like stop using drains last 4 to 5 years we don't use drains. I even compression drains post-op. We record removing the then we have maybe this one is I will use simple self-contained with antibiotic is what I use, and otherwise we have good pain control over these years. I quite happy evening. If I do in the morning by 5 o'clock, the patient is walking with the walker, obviously, but walking. We have done in the afternoon by night 8, 9 o'clock the patient. That's what our experience is.
I don't use tourniquet, so I don't use drain. I use Granavat cocktail.
Sir, one question I would like to ask to all the faculties who are routinely using Beuchel Pappas knees. While using these knees, as we can see that the rotation of the femur is set by the, how you have taken the proximal tibia cut. And it is okay in various knees, which is the case in most of the time. So it is tied medially and we end up having more external rotation. So I think that is favorable. But what is if it is a valgus knee, if we rely again on the same mechanism, we will end up having more internal rotation because the lateral will be tight in that case when we are taking the cut. So that I think is not favorable because it will decrease increase the chances of patellar subluxation.
You see, in valgus knee, as you rightly said, that basically the femoral rotation is determined by two things. One is the tibial cut. And secondly, basically, it is not only the tibial cut. It is basically, that is what we say, that it mimics the natural external rotation. So it is not whether it is going into this much degrees of internal or external rotation. Whatever the patient was having, this mechanism, by using this mechanism, we are mimicking the natural external rotation. In valgus knee, if you observe closely, usually what happens that the cut is the same, what is you are cutting medially and laterally, the cut is equal. So in a way, your tibial cut is correcting almost half of, because you follow the inside out technique. I usually follow the inside out technique. So by taking the proper tibial cut, you are halfway anyways correcting the valgus deformity. And then this jig goes and then this spacer block goes. So as per my experience, it does not go into internal rotation. Because generally you remove the PCL, then you do the posterolateral, because it is just the opposite what you do in varus knee. So by doing this inside out technique and taking the tibial cut, it does not go into internal rotation.
Your question is more applicable to mechanical axis. In kinematic, medial side should be slightly tight, lateral side should be slightly open. And also internal rotation up to neutral is acceptable. So need not fear for that.
So again, I don't want to keep coming back to robot, but if you do robotic surgery, sometimes you're internally rotating femur and still no problem with patellas. So I think that mindset we had about that if I don't rotate patella, outside patella will not track well, probably should be done away with. So it's not something we want to advocate though, that you should rotate in, but there are surgeons doing it, that's what I'm saying. And they have not had problem with patella. So like if you want to do real kinematic axes, you can actually do varus cut quite easily with the robot. The trouble with is that all of the implants weren't manufactured for kinematic axis. They were manufactured for mechanical axis. That's why sir told you that up to a limit, red line don't cross. Because after you cross that, then you need angled implants. The insert has to, the stem of that implant or the keel has to go in a different way. They were not manufactured for not being perpendicular to the leg. Do you understand that? So then you have to start manufacturing different implants. If you want to go into real and push this envelope of kinematic axis into more. I know a South African surgeon does 11-degree kinematic axis. I don't know how he manages with conventional implant, but it's not something we would like young surgeons to actually start doing it now.
Sir, what is your experience of valgus knee with kinematic alignment?
I don't do true kinematic axis because in true, you have to take a valgus cut. I take a 3 degrees varus cut. The valgus knee only. In true kinematic, you have to take a valgus cut. In restricted kinematic, you can take a 3 degrees varus cut. So I follow restricted kinematic axis in valgus knee, take a 3 degrees varus cut, and posterior cut, I make both sides equal, pin it, and put the gap positioner, and see where there is no instability, I go on cutting. If the any one part is loose, just a little bit change the rotation, and see that it is stable, and then cut it. Distally, we reduce the valgus angle to 4 degrees.
No, you have to reduce valgus angle is 3 degrees. You have to reduce it either 3 or.
So I think the two people who you really can follow regarding valgus knees in current day and age, one Ranawat and one JL Brad. So apart from this, nobody really has understood valgus knees very well. So what we have understood from their teachings is that, like the way we are doing with varus now, that we don't want to correct it all the way to 0. Similarly, with valgus knees, if you have severe valgus, bring it to small amount of valgus. If you have, let's say 10 degree, bring it down to 3 degree. Don't bring it to neutral and never bring it to varus. So if you follow that, then you don't need to do too much of corrections. It's only when we do too much of correction when we try to bring it to neutral. Because that's what we have been trained in our mind to be 0. So don't be 0. And it's now true even for varus. Don't bring it to 0.
So most of the robotic joint surgeon, they can measure it, how much varus and valgus after cutting the tibials cut. How do you measure with the alignment rod? I mean, generally, when we are cutting at the 90 degree, we put the alignment rod in, which is, aligning with the second toe of the foot. So what is your guide regarding the, 3 degree of the intentional varus cut for the kinematic?
There is no need to measure. That is absolutely so. All instrumentation that evolved is based on mechanical alignment. So you just put your tibia, your jig is done, you put your tibial trial or the hold, again you put a rod, check your tibia, you are good in varus valgus. Same at the last, you put trial, connect the rod, see the femoral head. Some people used to put ECG lead on the femoral head during painting and draping, and you check that you can see the femoral head, and then you align this entire rod, femur and tibia, and check in neutral position with dead AP patella. So you can play with this under IITV, you can check, and femoral head, and then where the rod is going. So ultimately, that's not the aim of TKR. So that is pure mechanical alignment system. So it is respecting only alignment in a coronal plane, again, in full extension. See the entire spectrum of alignment. You are taking care of coronal plane alignment only in full extension. That's it. See, this is a so narrow spectrum of entire knee replacement. What about sagittal plane? What about 90 degree fixed, 90 degree flexion coronal plane? So it's so half-hearted thing. I think why we should chase this full straight leg and what we are trying to get. If you have a tibia var of 5 degree, you are happy at the age of 65 years. You don't want deformity to correct at the age of 65. You want pain relief, better kinematic, better soft tissue respect. There are 6 layer moving so that we have to understand: skin, fat, fascia, muscle, synovium, and the implant. The least you disturb all 6 layers, the better is your range of motion and pain relief.
Of course, we do have a certain range of, freedom to do the error. But sometimes if the varus is...
It is not an error. It is not an error. For him, what you are doing is an error. And for you, what he is doing is an error. See, that's why he showed 3 people at the end. Gandhiji, Jawaharlal Nehru and Sardar Vallabhbhai Patel. Both are in the same direction.
See, the point is, 3 degree to 5 degree of varus or valgus is most of the time is forgivable. But beyond that, varus particularly is very detrimental because the whole body, baseline can. Yes, that is the question I'm asking him. So how, what?
I think that was exactly his question.
My question was that only, in a mechanical alignment, we aim for the second toe by putting the alignment rod towards the second toe. But if we want to have an intentional varus of 3 degree, with robots, it is very easy. But with alignment rod, how? I mean, whether it's a 3 degree or 5 degree or 7 degree, because beyond that degree of varus, that is very detrimental and tibial plate will fail.
So we got your question. I'll ask sir to answer because he does with conventional jigs. But let me tell you something. You drop your rod. Don't keep your foot where it is. Okay. How many times have you not derotated the foot to actually come in line with the rod? So that is why, in where I come from in Bengali, drop rod, that's what we call it. So drop is lies. So we call it drop rod. It actually doesn't align very well. It's wherever you want to move your leg, you can move, Your leg is almost floating around. So that rod actually is drop rod, not drop rod. But I let sir still tell you how many degrees you can move from which side to which side to give you that 3 degrees.
Because most of the practitioner surgeons, they don't have a facility of the robots with them. And in initial practice, most of the times this varus tibial cut is a very detrimental for survival of the tibial plate. That's why.
If you are using a mechanical axis alignment and you are using any knee other than BP knee, taking 3 degrees varus cut and independently externally rotating your femoral component is totally unkinematic because it loads more on the distal and posterior aspect. If you use the same thing with BP knee, even if your cut goes varus up to 3 or 4 degrees, it automatically get internally rotated to neutral position. So unknowingly, you are moving yourself from a mechanical axis to kinematic side.
Yes,
this knee is totally forgiving if you take a varus cut. Whereas if you take a varus cut and independently externally rotate the femoral component, it stretches more, it tightens more on the lateral side. They will have lateral pain, lateral wear and tear will become inside. That may fail in longer time.
Do you recheck, but after taking cuts? Do you recheck?
Under IITV?
No, not under IITV, with alignment rod.
No.
Do you recheck?
No.
Because sometimes what happens, the medial tibial condyle is very hard. As during the surgery, you have faced the same problem. With the new blade, I think with that problem, yes, because of the sclerosis, sometimes we cannot go for this desired cut.
So I don't check with the mechanical rod and anything.
The second
So
important thing, if you want to do a varus cut, like kinematic, you can do with tibial cut, and then you have to use a gap balancing instrument with all result detection technique people have done. So that you have that instrument, Zimmer has that instrument. So you have to go for varus cut, do hybrid technique. Actually,
I think both the techniques are, they are hybrid. I mean, we are using
what he said, you can't rotate it. But your tibia in varus, rotate femur externally is not going to. Then you are mentally ready. Either you may be 0 degree of your external rotation in femur, or maybe a little bit of internal rotation as well. So that should be acceptable to your mind. Then only you are ready to cut your tibia in your varus, because everything is connected. So that is also connected to.
So why all these questions are keeping into our mind? Why cut varus? Why cut femur in all this? Because you don't want to touch the soft tissues. That's what we have taken into as a paramount importance. So we have to decide at what stage am I going to go on cheating with the bone and not tamper with the soft tissues. So sometimes if you look at, suppose, I'm getting a bit older, so many times my juniors have started and I've then gone in and I've realized that I'm feeling a bit tightness on medial side, and then realize that they have not actually explored very well on the wound down here. Their exposure has not even done enough to release the soft tissues, and that is causing the tightness. So before we jump on too much there, make sure that your exposures are also very good. Sometimes you realize your MCL is tight at the exposure area down near the tibial because the wire is actually on the joint line. So all these things can reveal. So you got to decide at what stage am I going to release soft tissue or am I going to keep on changing with the bone? Because some deformities can be quite bad. Quite bad. If your bone is not collapsing, then the soft tissues are getting contracted.
And one more thing, if you have observed that in many of our Indian patients, even after properly done total knee replacement, we still find that the knee is in varus because it is metaphyseal varus. And if you want to correct it, you have to do HTO only. There is no other way by which you can correct the intra-articular part, but not the extra. Still they are in 7 degrees of varus because it is originating from metaphysis. It is not exactly.
So
Many patients.
So here there are two types of the deformities which you have described. One which happens on the mid shaft of the tibia.
Metaphysis.
One happens exactly just below the tibial fibrosity. Around that is the apex. And that happens with very late presenting severe deformities. Yes. Those ones you can actually correct on table itself and put around. So that is one stage correction, as we call it, intra and extra correction, and you can correct. The one which is down here doesn't need to be corrected. Remember, we've learned from deformity correction that if it is away from the joint, you can ignore those deformities.
But it will look crooked.
Let it be. Doesn't matter.
Does this system have a facility of the VGs and in a primary? In the primary. Okay, that's good. Thank you.
One more advantage of this system is that you see it is actually a deep dish design. So if you compare that, DePuy has this deep dish, SQLF had deep dish, and if you go to the literature or go to company people, they would say that nahi sir, wo PCL rakjo, because actually speaking, the anterior flange is just acting as ACL, or what sir rightly said, but posterior flange is not that deep. So if you take out PCL, then there are chances of instability. But this is the only design where you can sacrifice the PCL and still you will not find the posterior instability, because if you look at from the lateral, you will literally see this half moon. Yeah, sure.
Up to 60 degrees of tension, 100% congress. There is not even a half and 50 of the complete congruent humanity. You have to see that slide between the places and otherwise, there is 60 degrees of tension, there is 100% congress, there is no reflection. And 90 already tested. 90 are sure there is no instability. It's a good tight tension. What else do you want? I think so ultra-congruent, again, the only problem with ultra-congruent polygon, people are not happy, companies are not happy, the fear of usage of the thing. There is nothing else which is preventing people, everyone from going into ultra-congruent. Everyone should go to ultra-congruent, they are afraid because of the one. Any other ultra-congruent, if you have a fixed value, so we can take a card in the ultra-congruent, 100% needs a mobile. Otherwise, it is different of the all fixed bearing units have not been very successful. Only 40 to 45 years before this before Oxford tried the mobile bearing. It's very common, simple common sense that mobile bearing body always lasts longer. And what is about the tripolar hip that we see there? Again, a mobile polymer. It's a mobile bearing polymer.
Dual
mobile bearing polymer. This is a better option, less dislocations and long lasting. Ultimately, everything comes to there is a way of movement of the poly. On the upper surface, it is a to posterior. On the lower surface, it is a down circular movement. That's what you're getting. Same thing happens with unique Oxford. On the upper surface, it is anterior to posterior. On the lower surface, it is front to back. It's a translation versus rotation. That's what happens. So, mobile bearing concept has been developed to give us a good result with ultra-congruent poly. You have to have a combination of both to get good. Biomet has what is known as the AS mean the anterior supporting it, if you are doing a CRV, you are doing a CRV. If you are not very happy with the condition of the PCL, what are you going to do? You do a CR, femur, everything, it preserves the PCL, but Dr. McPherson, because in the PKC also he had come to us also. He's a revision surgeon only. His LA Institute has a report of, I mean, they have their own reports and results of 30% failure of PCL in one year. He said, we have come up with this idea that if we are not happy, we are not sure, put in a poly, which is just, it is not an ultra poly, just highly raised anterior surface, so that even if PCL fails, you are really. So that everyone is actually coming up with it, that they are really not satisfied with PCL, which is even there. Here you have a PSP with the CR femur, with the ultra-covalent poly, you are getting best of all the world. I mean,
Thereby you're saying that the anterior stabilized knee of the is again like what is Beuchel Pappas anterior parties.
yeah, it is that. That's one more. That's what you're coming. Yeah, that's what we want. Now see, there's a difference. Dr. McPherson was telling. There is a difference between a gradually raised anterior raised poly that we have in there and in biomet. It's a gradually raised anterior surface. So what we have in Canada was is an abruptly raised surface. So abruptly raised surface to keep on sliding, keep on causing it polyware, it can cause a breakage. In this there is a gradual raise of that entire wall. You will not get breakage, you will not get cracks, you will not get a camel post, wear. That is another very big advantage. That's why they have done the ASP in Los Angeles with Marriott. They said that this gradual rise of the poly decreases the wear and helps us to prevent anything what for not getting any camel. Please remember that also. That's also very important.
So also we do other knees also, and you have this ultra-congruent knee. The trouble is you can't just suddenly decide that you want to do an ultra-congruent because of the lip, and it has to be put in later. You just can't put it. If you have a 9 gap, the ultra-congruent is almost like a 11 gap. So you really can't push it in. So be very careful. Then you have to again, if you decide to put ultra-congruent in the beginning itself, then you have to again put it the way we put the Beuchel Pappas thing. So again, you're coming back to the same thing.
So it has to be decided first, tibia first, insert then, femur, or else it is not possible.
Short of gaps. Then we could we have changed. There is a way of doing that also. We can do that, but then with experience. Initially, you will not be able to do it. With experience, you can add one extra size of poly if there is a mistake. But there is a way of doing it. But otherwise, please think it's an all poly, don't have modularity, and you want to with that poly and nothing else. Then you will be happy.
So I have one question for all the thinkers. So we always talk about, as that gentleman is rightly saying, coronal alignment. What are your views on sagittal alignment?
Pass.
So why does this question arise actually, that sagittal alignment is important? And the answer for that is, if you actually look at the femur on a lateral view very carefully, from today only you go back home and actually have a look at it, you will probably find the femur on the end actually bows down. And this concept was first realized by Stryker. So once they started looking at it, they actually designed instruments in which the femur will actually, the rods will go in such a way, there even rods are flexible, the intermediate rods, so that you actually have anywhere between sort of around 6 degree bend to the actual alignment. But all our traditional instruments, if they go straight, you are actually putting back the knee almost on a straight at the end of that pole. But we need to bend slightly. So the good thing about Nikui knee was that once you finish it, automatically 3 degrees. But then Nikui knee, and suddenly we found the results were actually quite nice. So we realized that we need to bend. Even in robot, if you look at the robotic knees, the default position is 3 degree flexion. So we've realized we need to flex our knee. So coronal alignment is very important. We require some amount of flexion. How much we require, and can we do this with our instrumentation is the question still to be answered. And I think slowly companies will work towards it. The robotic is not difficult. You can dial in as much flexion as you want, but still, how much do I need? That is the whole essential question. So when I can do balancing flexion extension with robot, that will tell me how much flexion. But if I'm doing a conventional system, I don't know that how much to put. So I'll probably look at my lateral view and somehow cheat during the operation if I can dial in some amount of flexion. But it won't be possible with DP. That is a very rigid system. It has to go in, fit in very well. But with other systems like DPI and all that, which automatically flexes anyway, because it never sits very well on the femur. It's always doing, so I don't know how do we do gap balancing with DPI. So whenever I have done, I have just somehow done the trial. The trial is always shaky.
So in connection to this, do you use CT or simple scanogram, long like axis X-rays or scanograms like this? No, for the so AP you don't.
Simple lateral X-ray will take you, then going down or what?
And for routine cases you don't use scanogram.
It's important to know what do you do after that. How do you tackle this problem? If you find the flexion is at 9 degrees, what do you do with this? So that is where we are stuck. That maybe that knees may not function as well as the ones we were like say 3 degree flexion. So 3 degree को अगर हम 0 में ले आते हैं तो probably उतना problem नहीं है. But what about bringing 9 degree to is that what you were?
Second important thing is the paradox you have to understand. If you do a standard PS knee, so you cut the tibia or femur cross, whatever you do, mechanical alignment. Actually, we don't know what we are doing. We just do it. So let's finish it off. ORG, how many of us are taking ORG? Very honest. And how many are going to measure 3 degree far or 5 degree or 7 degree? And how many times you have on-table possibilities of everything? They will give you the instrument 5 degree valgus, 9 mm cut. Agree or not? We are all doing this thing. So we don't now by nature any PSC when you cut PCL, you are opening 2 mm flexion gap. So we have to understand all PSCs are tight in extension by nature and loose in flexion. All CR knees are tight in flexion and loose in extension. So there are a lot of things, but as a surgeon, you have to play with the facts and the system for me. That's why I put the slide. What I am doing when what I know from my healthy mind or what the disease needs. This we have to balance the gap between these two things.
So again, we'll come back to a stage. Now with robotic surgery, we know all this and we can do something about it. Now, if this doesn't show improvement in results, then we are really doomed. After knowing this and even able to correct that on table, if we are now not showing improvement in result and reducing those 20% dissatisfied patients, then we are doomed. Then we need to rethink the whole design of these from today. After that, results don't get better.
In this case, sometimes what happens that if the flexion gap is a bit crucial and there is minor play of 1 millimeter or so, which was, I think, in the first, my case was the case, then I released the PCL partially. Or as this happens, that then you put the femur either in, because you are putting it in a tight knee, then you are putting the femur in slight of flexion. That is what happens.
Whether that flexion is good or not.
God knows.
We are all at sea. We are still.
That was the $1 million question.
3 dimensions. It's not even 3 dimensions, it's 7, 8 dimensions. How the femoral implant is made, if you have a 7-axis CNC machine doing the function of the implant, it's not 3-axis. The 7-axis machines we are doing those cutting and those. Even while manufacturing, you are looking at so many axes. Are these thinking in so many axes? Maybe 1 or 2 max. You are not even thinking in the third axis. We are all humans, we are not robots. Yes, it may give us better results. I don't say no. But this question is, even after robotics, if that pain remains at the 20% dissatisfaction remains there and what? We don't know. Time will say, maybe 10 years down the line, with 90% surgeons doing robots, and then the number of dissatisfied or percentage of dissatisfied patients. If they get the same number, you have to read it. Better, okay, let's all go to that direction and see what it is.
But no, one thing is final that Mr. Venkat has to consider giving at least the faculty members a robot. Yes, yes.
Over the years, if you look back 30, 40 years, the dissatisfaction and survival, so much innovation and new things have come up, new design in joints and bodies, quality of joints. The survivorship has not really changed drastically. Even in computer navigation, people are trying to get 0, 0 figures and all their parts, range of movements, everything. Still, survivorship has not changed. So I doubt that going too deeply or rethinking and rethinking of small points is going to make much difference. And no matter how well you do a surgery or technically how good it is, satisfaction rate is not dependent only on the physical stuff. Patient's perception and expectations, the goalposts we put up for them and what others put up for them has a huge influence. You will never get a completely satisfied patient. Because they all want to be 20, 30 years younger than they are. It's never going to happen.
The implant design is never going to be exactly right for what has given us. It will never be exact.
What I understand is by removing the arthritic joint surface, most of the patients, who is having it, as Dr. Rajput has told, then let them suffer more. If they suffer more, your surgery will be more appreciated because more the arthritic joint.
This is not surgeons to do. This is surgery patients come for. One fine day patient will come to you with their mind made up that I want my knee replacement done in 5 days' time. And if not you, your colleague next to you.
Yes, that is very true. That is very true.
So the thinking that the patient will still coming back to you for years and will be really needed.
I mean, but
to come back forward.
patient to patient pain perception is very different. We know.
Is the walking style of walking, the energy level, they blame everything to the
But
surgery.
I think there is a range of safety or range of as I said 3 degree of varus or valgus.
No, that's where you're wrong. UKR, you're not supposed to correct the virus at all. You're not bringing them into neutral. Till they do it.
Because that is a kinematic thing.
Calculating the virus itself is a great burden on your mind.
I mean, no. See, I think nature has given 3 degree of varus.
No.
87 degree of the. Yes,
They do very, they're happy at the bed.
You get intense with low virus. You get severe wave 35, 37. You have to do a during such patients. Sometimes they have, and we have no reason, we have no answer to why this happens.
But we cannot.
No virus means other is absolutely okay. No history of injury, no history of fall, X-ray, etc. is totally normal. No meniscal tear, nothing. Severe erosion of the what to do in those? And specifically, you do not correct the virus because you have to overload the medial tibia in a unity. You have to offload the lateral tibia, and then you are going to get a good result.
It is sometimes very difficult to recreate the original. We don't know the original things because when the patient with us, they are completely arthritic. Both the knees are completely arthritic. And how we can judge what was the nature's original given slope in the tibia or femur?
So this is exactly.
So that's why we have to be fixed with the one range. That's why we have to be fixed. Yes.
Even so, when I do Oxford, there's a difference. I don't like it. It's all the 7 degrees. I don't see.
That is the thing I'm telling you. We have to be one range, that is defined range by the all the expert and experienced surgeon. They also have to be in that range. They also have to be in range.
That kind of luxury, what you are seeking for, you are if you don't know measurement, that's why there are 2 ways. Come back to the basic fundamental word of the measured resection and balanced resection. Resecting means cutting. Either you measure or you balance. You decide what you like. If you are like measuring with the scale, you can't on the right side, you should always use the system.
But both the systems are interconnected. We in both systems we are cutting the tibia at the 90 degree. First, and in both the system we are equal gap.
That is the biggest difference here. In measured resection, you are starting with your extension gap.
But the aim is to have an equal gap, and at the tibia is at the 90 degree.
You just tell me. I will show you in Robert. Come to the OTs and see the patient like sitting like this, anesthesia, the robotic arm. It's a
You understand? This lateral laxity on the lateral side, how in measure resection you will give a rectangular space. I will come to your routine, follow your measure resection technique. I will select calibration and you give me a rectangular space. I will stop doing horizontal.
I think
You can't do it. You will do 3 degree, you will do 5 degree, you will do 7 degree. How you will decide your flexion gap? Any one of you, this is my final question. How you decide your flexion gap? You will draw the line.
That's what I
See,
said.
anyone can give my answer. You draw the line. You come back for coffee and draw the line. You will draw a different line.
In this gap
No one in
balance,
the world can do a ultra-contour rotating platform to measure the section. I cannot do Oxford with measure the section. I'm not looking at it. I'm just looking plastic in. How this will be there? No bars, no bars, no measurement.
so ultimately, in both the system, we are, creating the equal gap.
We are not creating equal.
No, no, I mean, how? Then every knee will fail in major resection. No, no, no.
It's a lot of abnormal femoral body. Many folks are femoral body, oblique of body, set LCL, even now you want this gap to be equal. How is it possible?
We are doing sliding osteotomy for that thing. And if it is not possible with that thing, we are accepting with the hinge. Tell me now what is my question now. Now my question is, no, Karthik, wait. My question is, simple question. Simple question. Very simple question. In major resection, extension gap is equal to flexion gap. I think, do you agree?
No.
Do you agree? We make it, but at the final result is, this is very simple, basic.
One thing I want to contradict. Just the moment you release the PCL, the flexion gap opens.
Yes, that is true. 2 mm extra, every
Gap by measured resection technique.
we accept up to 1 to 2 mm of the lateral laxity in most of the knee because that is the nature's. No, that is the nature's permissible thing. No, that we are seeing. No, permissible limit in a alignment.
How we do it? Let's come to the basic question. This is an orthopaedic. You have done arthroplasty, like you are planning femur cross.
Okay.
So you have put 9 millimeter distance cutting G, 5 degrees of arc. You have cut.
Okay.
So you have cut TI, your extension gap is done.
Okay.
You are okay with the 9 millimeter for your 8 millimeter, 10 millimeter.
Okay.
Extension block is going very well.
Okay.
You are very happy.
Yes.
Now, if you do this bar of stage in 90 euro flattening, your lateral gap is opening up like this.
Okay.
Here this time.
Yes, trapezoid.
Because this is the RSA, my middle structure has to be tight. Let me remove some osteophytes here and there.
Yes.
You will remove some of the osteophytes.
Yes.
You are still feeling better, still you are not balanced. Now what you will do? Then comes different techniques. This is where the catch starts. Insta and initially people want to go discovery. Release, put an osteotomy. I had seen. Being a traffic. Let me ask you one question. What will happen when you release the idea by something? What will happen?
That will open up on the medial side.
What will be open up?
The trapezoidal gap will be, towards the rectangular.
That is flexion. So you can easily remember atrial fibrillation and pulmonary embolism. So anterior fibers will open up only your flexion gap, medial flexion gap, and posterior fiber will open up only extension gap.
That is according to
You
the.
are releasing better for doing back posteriorly. You are able to do better in extension. That already done. Now what you will do? You will go anteriorly either in the femur or in the tibia. You have a sling to release.
Yes.
So either you crack the bone, release the
soft tissue from mid-structure or epicondylar osteotomy or dystally, where to stop. When you will know now this is perfect, you will not overcome. If you see the literature, read the papers, there are maximum cases of medial femoral condylar lift of after trial reduction with laser dissection. Because you have over-release. Now you have over-release, you will go for thicker body. And now your thicker body, all in you are losing flexion. You are putting 10 to 10, you convert it to 12, you are very happy with your flexion there. And then you are putting an extension, you see this is flexion deformity. Now you reduce the posterior gap. So one एक जूट और जूट करता है. This is what everything starts. You do 100 cases with gap balancing and you talk.
But I have done the 100 with mirror resection and I am not all. I mean, I'm not wrong in that thing.
That you should continue. You should not be.
No, my point is,
You want to learn something. I am not doing this. I have not started 3 months back. Why did I start?
This system does have a certain good thing. This system does have a certain good thing. That yes, we have to be, open-minded to accept both the things. Even
because in whether section but won't pass away. Yes, to address form issue later. Here to address the form issue which is primarily needed as needed as possible. If you want to be more conservative, you can follow disease ideal. If you don't agree on disease ideal, can or mechanical line. I want 90. That's fine with the system. So this is more permissible and you can balance the need and whatever the inaccuracies, either the bone cut or the soft tissue balancing, you can manage vice versa. So I don't say when I release the soft tissue in the Maharashtra in this technique, I am correct. I may be undercorrected, but I am more towards undercorrection, which I can easily manage through my bone research.
So I'll just ask you some questions. I'm not saying measure dissection is bad, okay? We're not here to say that. So just tell me your sequence. You do the whole femur first or you start with tibia?
No, I will always tibia.
So you do tibia first,
Tibia
then what do you do?
I release it.
What release?
Yes, up to the mid of the tibial. Initially,
No, the tibia part is done.
tibia part is done.
Okay, now what do you do?
Then the femur.
So femur, what do you do, femur?
I may.
You do the whole femur one go?
No, I first distal femur. Then
So you do distal femur. You
Distal
get your extension gap.
Yes, first extension.
Let's say you've got 9 gap now.
Yes.
Now what do you do?
Then I start with the chamfer cut and other things of the femur.
So you do the rest of the femur cut?
Yes.
Will that? So how do you measure the size?
Of.
Let's say you've done a size. Let's say size 4, arbitrary number.
Of
You
femur.
want to, yeah. So you want to cut size 4 now,
Yes.
right? So now when you put the jig in, how do you know your flexion gap is right or not with this size 4 cut?
I take all the, as a perpendicular cut of the tibia, then the trans.
So you're getting the jig balanced on the tibia?
Yes, I do check all the things.
So that is not true measure dissection then now. Now you've already modified. You've already modified. So, okay, fine. Now I'll go with your modification, but now let's correct. We are not on true measure dissection anymore. So now you're balancing the jig based on parallel to the tibia. So you've taken tibia as also reference.
Yes, tibia.
Are you still going to take epicondylar axis, white side line as
Yes.
reference?
Yes,
So all of these?
all of these.
Good, very good. So now, how do you decide what size femur you want to cut to balance the gap? How do you know before cutting that your gap is balanced?
Because femoral size and tibial size also I check, or tibial base plate.
No,
size.
no. How does it tell you exactly before you cut that you are going to be balanced in flexion? One simple question I'm asking you.
Because after putting this spacer, 20 mm spacer, the line will
With a jig on, you can't put a spacer.
but you measure the femoral size from the lateral femoral condyle.
Again, we are coming back to, so you measure, the sizing is okay.
Okay.
You've done a size 4. Now you put a cutting block.
I use the 3-degree external rotation. In that position, my femoral zig will be perpendicular, parallel to the
Now
tibia.
you said you're going to be parallel to the tibia.
Yes.
So that could be 3, that could be 5. You
Yes, but
can't.
most of the time it is 3-degree.
Now we are not here now. See, that's why let's not get a proper number here most of the time. Now you're going to go based on tibia.
But the system has a 3 and 6-degree options, so I have to go either 6 or 3.
No, we are not going to decide about one particular system. We are here for generalizations. Like measure dissection techniques could be Debouy, could be Smith-Nephew, could be anybody.
Anything.
Not just one system.
Yes, anything.
So you want to put the jig size 4 cutting block.
Hmm.
Before cutting the tibia, how do you know your flexural gap is going to be balanced? The simple question I've asked you.
Are you pre-balancing it? That is the question.
How do you know?
That's why the system is different from, this is a major resection from the bony side. Okay, so I have checked with I am parallel to the tibial cut. I am parallel to the trans-epicondylar axis. I have measured the femur from the lateral femoral condyle. The size of the femur is 4. Okay, so there is nothing wrong. I mean,
Maybe I'm not understanding. Okay, tell me which system you're talking about.
I'm using either debut or max.
Dipui?
Or
Okay,
max.
let's come to Dipui now.
Okay.
As I said, Dipui 9 is not there, so 10, let's say, or 8. Okay, so you're on 8 size now. Small size, so you're okay with 8 now. Okay, so you got 8 extension gap. You put, let's say, size 2.5 femur, sizing, cutting block. How do you know that when you cut this posterior condyles, you're going to be balanced in flexion? Very simple question I've asked you.
Because, you know,
In Dipui now, I'm going back to the implant which you said.
Are you sure that what are you doing?
Definitely, the cut is parallel to the
What
tibial.
you aim is what is.
Cut may be parallel. Your gap is 9 mm or not. How do you know? 8 mm or not? How do you know?
So that is, you know, that in gap balancing, that precision is there.
No, sir, no, don't go back to gap balancing. In your measured dissection, the way I'm progressing with your surgery, before you cut the actual tibia, do you want to be sure that your gap is going to be 8 mm now or not?
Obviously.
Obviously. So what device do you have to tell you this?
Laminar spreader
Apart
can help. Laminar spreader can be helpful.
So if you look at the jig, it comes down. You cannot put laminar spreader there now.
But I can
If you put the jig in, it has come down.
Now the catch. What is about the lateral axis?
up to 2 mm is, I think, acceptable on the lateral side.
So we agree to that also. I am still asking you, medial side that you've got 8 mm gap, how do you know?
On the femoral side.
Yeah.
But that sagittal balancing is a question.
Balancing comes later. That you've got minimum 8 mm gap you've opened up and not 10 mm, not 6 mm. How do you know? Before cutting.
Posterior referencing system, you know, because of the posterior referencing system.
That gave you the size. Forget about the size. That just gave you the size. That didn't tell you the gaps. So that is what I'm saying. In measure section, you cut and then you see that you are balanced or not. Now, if you were 10, then the thickness of that blade capture is 4 mm, though, not 2 mm. So I wish I had a 6 mm thing which I can put underneath that and then make sure that my flexion gap is okay. But Dipui doesn't have that. And most companies don't have that. No companies have that. So if I could have put a spacer block in between the jig and the actual tibia, based on the thickness of that cutting block, I would have known whether I'll be balanced or not. So this is exactly what the gap balancing is doing for you. This is exactly what the gap balancing is doing. So I'm telling you, none of these systems are exclusive to each other. They are all coming back to the same, that while cutting, you are balancing also.
But not
So
answering your
so that is
question.
why I spoke during my life surgery. We are all hybrid surgeons actually.
Yes, we are
We are all
hybrid.
hybrid
We
surgeons.
are hybrid surgeons.
But you are not. You are cutting first and then seeing whether you're right or not.
Of course, I measure all the things.
No, that's what I'm saying. You're measuring. You're measuring.
Maybe I have not answered.
Then you go on
your own way, but
Sir. Sir, we are, yes, we are running short of time. Thank you very much for the exciting discussion and the session. So I would like to invite Mr. Venkat, please. Yes, sir, please.
Thank you, all of you. I would like to invite Dr. Neeraj Shah, sir, Satish Patel, sir, and Kinnar Avasya, sir, to facilitate the faculty. First, Dr. Manish Diwakar. Dr. Jyotish Patel, sir. Dr. Kuldeep Chaudhary. Dr. Karthik Shukla, sir. Dr. Rakesh Rajput, sir. Professor Dr. Srilangan sir.
Dr. Neeraj Ashok. Just one word to express and all of you for the program and faculty for I hope there is someone all of us take back those, including us as partners and if this event is created as a purpose of the mixer all of us, I'll be grateful. I thank all of you once again for giving us those. Good day. We have IT, so don't forget to have a cup of tea and coffee. Yes, so those participants who are interested in having hands-on experience, then we are having arrangement in the opposite hall next to the registration counter, where you can have the actual field.
म्यूट राकेश पण आवाज आहे याने अंजना म्यूट से आता धड़ाधड़ काट हेलो भाई कमर वाला ही लो यार नेट बैठ में बच रही लो आदि खाली वाटर अलग अलग बता